Hello everyone. Good afternoon. On on behalf of organizing team, it gives me immense pleasure to welcome you all to this bridge course, which is locally adapted breast surgery course, and we are all gathered here in, to make sure that advanced breast cancer care does not remain confined to metros or high income countries but reaches every woman who needs it. And we are honored to have with us an outstanding galaxy of national and international faculties who have generously agreed to share their wisdom and who have helped us in curating this program. A big thank you to all our delegates also who proved one thing very quickly that surgeons may take time to decide in the OT, but when it comes to registrations, they are faster than Amazon flash sales. So this program would not have been possible without the unwavering support of so many national and international societies and their respective members who have joined us today, like Breast Surgery International, Association of Breast Surgeons of India, Indian Association of Endocrine Surgeons, both President Professor Anjali Mishra and Secretary Professor Pooja Ramakant are faculties also. Then Indo-UK Breast Forum, a huge thanks to Dr. Raghavan Vidya and Dr. Rishikesh Parmeshwar sir for helping in this program and all our national and international faculties. So, with gratitude in our hearts and enthusiasm in our spirits, let's get started. And before we start, I would like to invite our mentor in chief, Professor Dhananjay Sharma sir, to please share the vision behind this course.
गुड आफ्टरनून एवरीवन। आज हिंदी दिवस मना रहे हैं। अनुराग सर, अग्रवाल साहब, आप सबको सादर नमस्कार और आप सबका स्वागत है। फॉर द सेक ऑफ ऑल इंटरनेशनल गेस्ट्स एंड डेलीगेट्स, नाउ आई विल स्विच टू इंग्लिश। It's a privilege to welcome you all for this very important breast surgery course. And why affordable breast surgery solutions are important, we all know that, but just give me a couple of minutes to re-emphasize why these points are so important. Everybody talks about value for money. When we talk about affordable surgical solutions, we provide value for many. And that is why we are all gathered here. This is something which is in our hearts, everybody's heart. And we have done quite a few publications we have on this issue with the help of our friends and colleagues. And it's a call from our side for a global breast cancer care pathway from diagnosis to prognostication to treatment. We have solutions which we have published. I think Sanjay has already shared most of these in the booklet, which has been shared with all the delegates. So I will just stop here and welcome you all. My humble request to all the delegates, we have a great panel of faculties. Please make sure you ask them questions, share your experiences, and make full use of this opportunity. So a very warm welcome and pleasure inviting you all to partake in this academic feast which has been prepared by Sanjay and his team. Welcome.
Thank you, sir. So, We will proceed to our first lecture, which is Breast Cancer in India, setting the stage for equitable resource adapted care. And Dr. Raghavan Vidya will be speaking on this. Why that will kind of show us why we require these kind of courses in India. Sorry for this technical glitch. Plus, give us few seconds.
Good morning. Sanjay, can you unmute everybody because the audio is not great. If people cannot hear, they cannot tell us. And then can you play the recording from the beginning now? There is no audio in the one which we played.
Okay, let me share this again.
Or if you play it, I can talk.
Right.
Try it once more. Compared to the high income countries. That is audio now. 90%.
Okay, so I will start from the beginning.
Breast cancer care in India, setting the stage for equitable, resource-adapted care. I'm Dr. Raghavan Vidya, working in the West
Is it
Midlands
audible
in the
now?
United Kingdom. This talk was prepared along with Dr. Sanjay so that we have a good understanding of the global perspective and the cancer care in India particularly in low-resource adaptable conditions. Breast cancer remains the most common cancer among Indian women. There's a rise in incidence, particularly affecting younger women. What is happening to the mortality? In India, the mortality remains very high, while globally, the survival rate is increasing. There are more than 200 new cases diagnosed annually in India. Unfortunately, more than 50% present in late stage in 3 or 4. Hence, the survival is much lower in India, which is only 60% compared to the high income countries, which is more than 90%. What are the key barriers to care? Lack of awareness or low awareness remains a major problem, and there's a social stigma for being diagnosed with breast cancer. There is a big rural-urban divide in access to cancer care. There's a high out-of-pocket cost. The financial implications remain extremely high. There is workforce shortages, and the system appears to be fragmented as this is a large country. Looking at the key barriers to breast cancer care in India, you can clearly see that most of them are locally advanced or late presentation. Social stigma continues to remain low, and the attitude and the distance to tertiary care remains very variant. And there's a human resource gap. So there could be suggested interventions, and there could be a big urban rural divide which has to be addressed. This is an example of sentinel lymph node biopsy, where in low resource settings, only 25% are eligible, whereas in a well-endorsed setting, 100% are eligible. Looking at the immunohistochemistry, lack of access in more than 40 to 60% is available in low resource centers, whereas in well-endorsed settings, it becomes universal or the norm. Radiotherapy, only 8% are eligible, while 75% are eligible in a well-endorsed setting. This is a paper which was published by Dr. Yadav and is a very interesting read demonstrating the level and the accessibility to cancer care available in India. Looking at the patient journey, late presentation remains a norm. There is limited diagnostics. Mastectomy becomes the default. There's a poor follow-up and there's reduced survival. Look at a good condition where good early imaging happens. Patients are diagnosed early with co-biopsy with immunohistochemistry. Sentinel node biopsy becomes a norm because of early stage disease. Breast conservative surgery and radiotherapy is available due to multidisciplinary care, resulting in good patient-centered care. Why resource adaptable care? Western models are not always feasible in India. We need local solutions for local problems. We need a scalable, affordable, context-sensitive solution. We need focus on early detection, decentralizing the care, and cost-effective treatment. It starts from basic to limited to enhanced care. Early detection strategies include community awareness campaigns, clinical examination by trained workers, self-examination and education, and selective imaging in high-risk women. Decentralizing and strengthening care will be the answer, with district hospitals having basic oncology capability, tele-oncology links with tertiary centers, task shifting, probably will help to a great extent. Affordable treatment and pathways have to be implemented. This includes use of generic cost-effective treatment and surgery, guidelines stratified by resource levels, including basic to enhanced care, focus on multidisciplinary but practical teams. Financial protection and equity would be important. This includes some examples such as the Ayushman Bharat and the state insurance scheme, support for follow-up and palliative care, equity lens, accessibility, affordability, and acceptable care should be the norm. So the closing message, breast cancer care is a challenge. At the same time, it offers a golden opportunity to adapt care to resources and close survival gaps. A woman's chance of survival should not depend on where she lives or what she earns, but to provide accessible, equitable care even in low resource settings. Thank you very much, and I'm happy to take any questions.
Okay,
Good
so
morning, good afternoon. Thank you very much for this opportunity. If you have any questions, please put it in the chat and we could answer it. And do we have a minute for some questions, Sanjay?
yes, we do have.
You're all unmuted.
Anurag sir, please unmute yourself.
You at my end? Yes. So thank you, Vidya, for wonderful beginning. And it's a great initiative on your part and on the part of the British Breast Group. So I'll take some of the issues that you have said. One of the main reasons for late presentation in our country is the screening coverage. Screening coverage in most of the states, Uttar Pradesh, Bihar, and Jharkhand, northeast states, is less than 2%. In some states, it's 0.9% in Uttar Pradesh. So that is the major hurdle why patients come in a late stage. Although National Health Mission by the Government of India had launched screening way back in May 2017, but still the coverage of screening to the target population, that is 30 to 65, is less than 2% in many states. So we are trying to increase that, bridge the gap. Second is you mentioned about sentinel node mapping. So one reason for not doing sentinel node is the lack of training among surgeons and the high cost of gamma probe, high cost of indocyanine green, and high cost of infrared camera required to capture the ICG pictures. So Dr. Sanjay and his group has developed a low-cost, affordable sentinel node mapping with fluorescein, and you will probably hear that late in the presentation today. Selective mammography is an excellent idea because mammographic screening is not being used as a mode of screening in our country, because 30% of cancers in India are picked up in the age between 30 to 50. So 30 to 50 age group, mammography doesn't work, and therefore we have not used mammography as a national screening program. Clinical breast examination and teaching the ladies self-breast examination are the two modalities being used by the Government of India for screening. So this is all I would like to say. Thank you very much.
Thank you. Dr. Kha, you got some information. You want to say something?
Dr. Vidya, how are you? Just a wonderful talk. I want to just applaud you for your work. On your first graph, when you shared the disparity in survivorship between Indian breast cancer and in America. I was just wondering, was that correct as stage to stage, or is just all comers?
This is basically based on the overall view, and the stage to stage gets worse.
And then
Stage
the second question is there any role for risk reducing interventions, for the high risk population? Just like you said, screening, but I guess we got to start with screening before we got to do anything else. But tamoxifen happens to be a very good and very cheap drug that can potentially help.
I totally agree, but the compliance is extremely poor even in Western countries. So I don't know how the compliance is going to be in India, but it's always an option that can be offered in suitable settings.
Absolutely. So all studies do show that the compliance is very low. However, if surgeons initiate that conversation, most places that do prevention are primary care facilities. But if the surgeon does that intervention, the compliance becomes a lot higher.
Thank you, Steve.
There are two questions in the chat box. One is, do we have strategies to increase awareness among masses? And why we do not talk about incidence and how to bring it down?
No problem at all. Incidence is a big elephant in the room, and it varies because India does not have a basic standard database like other countries. So the incidence varies in different regions and is actually extrapolated from this. We have the World Health Organization, which has published, but I did not know exactly how accurate it is in each state, so I did not touch upon it. But the incidence is very heterogeneous, but definitely the breast cancer incidence is rising in India. And what is the second question, Sanjay?
Strategies to increase awareness among masses.
Definitely, that's why we are hosting such program. Is just a beginning.
So can I just mention about the data from incidence? The National Cancer Registry run by ICMR has presented the latest Global Can data for 2022, which is 25 new cases per 100,000 population per year. That is the national average. It's highest in Delhi and Chandigarh, which reaches about 40 new cases. In Delhi, it's 41 per 100,000 population per year annual incidence. So it varying, you're absolutely right. Among the metropolitan towns, Delhi, Bombay, Madras, and Bangalore, it's very high. But in the villages, it is still low. And in fact, it is less than the cervical cancer. In villages, we still have cervical cancer as the commonest cancer. So, but the national average is 25 per 100,000. Yeah.
Dr. Anurag, I tend to differ. I think it's more reported in urban areas than rural areas, and hence the incidents appear to look very low in the rural areas. I don't think the incidence is low, but we do not have any accurate documentation.
Okay. So thank you for that talk, ma'am. Now we have breakout room also. If you can join there for a couple of minutes and see if anyone else has any question. Meanwhile, we will now proceed to our next talk by Professor Suhani ma'am, additional professor, surgical disciplines, AIMS, New Delhi, and she will be speaking on the holy trinity of breast cancer diagnosis, the triple assessment. Ma'am, over to you.
Thank you, Dr. Sanjay. Good afternoon, everybody, and good morning to the international faculty in various parts of the world. Professor Dhananjay and my teacher, Dr. Anurag Srivastav. Firstly, I thank Dr. Sanjay for the opportunity, and I'll straight away move to the task that is the triple assessment in breast cancer. So it's a very basic presentation, and what has happened? Okay. So triple assessment is, as we all know, the gold standard diagnostic approach for breast lumps, and it combines three complementary modalities. That is the clinical assessment, radiology, and the pathology. And the basic aim of triple assessment is to differentiate benign from malignant pathologies. And triple assessment, all three together, when they are concordant, then it has a sensitivity and specificity of over 99%. So the components, we'll first go to the first component, that is the clinical assessment of breast lumps. So briefly in the history, we all have to ask about the onset of the breast lump, the duration, the progression, associated nipple discharge, other lumps, axillary lymph nodes, metastatic symptoms, history of previous malignancy in the patient, any history of recent lactation, because both the imaging and the pathology may give confounding results which mimic malignancy in the absence of malignancy if the patient is lactating or has recently done with lactation. Now, breast lumps may always not be malignant, and we see a lot of granulomatous mastitis. In this case, the history of autoimmune and autoinflammatory symptoms need to be asked. A detailed detailed family history with preferably a pedigree chart analysis should be done for at least 2 generations. And we did a study wherein we saw that before training, like casually asking in the OPDs what is, if there is any positive family history, versus training the surgery resident and drawing a 2 generation or a 3 generation pedigree for all the patients, there was a 5% extra pickup rate when a proper detailed history was taken from the same patients as compared to a casual history taking like most of us do in the OPD. Now, examination, these are the key points on inspection. We have to see the position, size, symmetry, dimpling, puckering, the skin changes, nipple, arm edema, and the lateral inspection for the breast and axilla. We have to palpate and see for the lump, their number, location, size, fixity to the skin, chest wall, pec major, the any discharge from the nipple areola, from the nipple, the thickening of the nipple milk ducts, regional lymph nodes, that is the axillary, supraclavicular, intraclavicular, and we do an ultrasound breast and axilla. So if it is available, then all the clinicians should start practicing a breast and ultrasound of the breast and axilla alongside with the clinical examination. The third most important thing is to document the findings so as to give it a valid look as well as for comparison at a later stage. So what we use is the dial of clock method, and it basically highlights the area of the concern and abnormality as well as the distance from the areola and the nipple breast, this thing. So now this is a small video which I'll not run, but I just want to tell that this has been uploaded in the various sites, and this depicts a detailed clinical assessment along with the pathophysiology of the various clinical signs. So supposing there is skin tethering, so this video will show about skin tethering, what is the pathogenesis with an animated video that has been embedded inside. So similarly for Paudiaran's nipple discharge, nipple retraction. So if anybody is interested, they can watch this video at a later time. Now documentation is very important, and we use this worksheet in our OPD. It's printed on the OPD card. This is just a representative from the one of the patients. And as you can see, we've drawn a biplanar, the anteroposterior as well as the lateral aspect, and the lumps and the clinical finding, the extent of PDO, like here the PDO was localized. So we just draw in it here, and we record the main important clinical things that we need to start up or we need for the management of breast cancer. So this serves as a baseline thing for us, and it also tells us the depth of the location of the lump, so that in case after chemotherapy it goes away, we know what was the scenario pre-chemo. Now, coming to the second component, that is the radiology for breast lumps. So radiology, there are 3 main modalities: the ultrasonography, mammography, and the contrast-enhanced MRI breast. So ultrasound is often said to be extension of clinical examination, but I often feel that it's an extension only if it is done by the clinician. If it is done by the radiologist, then it's an investigation that we are requesting the radiologist to do. So it helps in characterization of the lesion, whether it is solid, cystic, or a complex solid cystic mass. Now, for suspected benign lumps in less than 40 years of age, it can serve as the sole imaging modality. Now, if there's a suspected malignancy of any age group, then ultrasound is just as an adjunct to mammogram. And as I said, it helps you to delineate the characteristics of the lump. It also helps in doing guided biopsy both from the breast lump as well as the axillary lymph node, and is very important for response assessment. Now, just some representative just from a patient. This shows a clear anechoic, well-defined cystic lesion. This is a complex cyst with a solid and a cystic component. This is a very benign-looking fibroadenoma with some shadowing, and this is an irregular mass which is suspected of having a malignant potential. Now, apart from that, ultrasound when done bedside or in the OPD rooms, it can help in identifying abscess. So here you can see very clearly that hyperechoic, echogenic shadows are moving inside the breast lump, and this was a breast abscess which was later percutaneously drained. Now, mammography in symptomatic women over 40 years and above, it is obviously recommended. And it has a diagnostic accuracy of 90% in fatty breast and 65% in dense breast. And that is the reason that less than 40 years, mammography is generally not, the investigation of choice. But we have to remember that all cases with suspected malignancy, a mammography has to be done irrespective of the age. And if you see, the four important things mentioned in the lexicon for mammography are the mass, calcification, architectural distortion, and asymmetry. Unfortunately, an ultrasound will just tell you the mass. A very good radiologist may just pick up some architectural distortion, but calcifications, architectural distortions, apart from the mass and asymmetry, are seen on mammography and not on MR. And if the lady has dense breast on mammography, is a young patient, then apart from this, we can supplement it with a contrast enhanced MRI. Now, there are certain important takeaways that I would like to quickly tell here. Firstly, we need to assess the quality and the level of exposure. So the shadows of the pectoralis muscle usually should come at the level of the nipple areola to see that the adequate exposure has been covered. Now, there are certain areas which are often missed, and the clinician should also see, apart from the radiologist reporting, the mammogram. And what are these areas? These are known as the wrong places because these are often missed. So one is the lines that you draw from here to here. So here lesions in the axillary tail are often missed. Second are the lesions in the retroareolar area. And third is in the retromammary space of tabar that the lesions are often missed. Now, you should always see this films, and reading reports from another person is useful, but we should develop the habit of seeing the films. Now, here you can see in this, it was reported as a normal contralateral breast in a Birat's 4C lesion on the, I'm so sorry, on the left side. Now, I will just zoom in the opposite side, which was reported normal. So if you go and see the opposite side, so this is the this side, you can see very suspicious clustered microcalcification. So this has been missed on the reporting from a mammogram done elsewhere at another healthcare facility. So develop the habit of reading the films and discussing the reports with your radiologist again. Now, a lot of time this term sonomammography is used. So is it an apt term? No, our radiologist. So I've just shown a screenshot here from our breast cancer clinic WhatsApp group that we've made with various allied specialties who help us. So here there was a resident who had just joined 2 days ago, and she had written sonomammography on a yellow form, which in our institute is meant for radiological investigations involving X-rays. So the head of the breast radiology got really annoyed, and she just posted there that another sonomammography request. And I have repeatedly asked residents to use proper terms. Sonomammography is an ambiguous term. So in case you have to write that do a mammography along with an ultrasound, it is always better to mention that a bilateral mammography with bilateral breast and axilla ultrasound. Now, this is very quickly the ACR BI-RADS classification. We all know that as we go from 1 to 5, the probability of having a malignancy increases, and almost all BI-RADS 4 and all 5 lesions have to be sampled. And BI-RADS 0 does not mean that it is benign. BI-RADS 0 means that the assessment is incomplete. Either the lady has a lot of dense breast or the imaging has not been done properly, and we need an additional image or prior mammograms to compare the findings. Now, tomosynthesis is now routinely available, and for us, it has become a routine part. So this was a study where we showed that breast tomosynthesis increases the diagnostic confidence and the yield by the reader. Now, MRI for us is just a problem-solving tool and not a routine investigation. Discordant radiological and clinical findings. We discuss the scans again, we reevaluate the patient, and if required, then we go ahead and do an MRI of the breast. MRI of the breast in case, as I said, young women, when dense breast is there and a breast conservation surgery is planned, or even otherwise to rule out any sinister looking lesion in the contralateral breast. It also helps in radiological characterization of lesions which are equivocal on mammogram and ultrasound. In cases of lobular carcinoma is a soft indication, but we do most of the times go ahead, especially for picking up contralateral lesions in case a mastectomy is performed on the ipsilateral side, for carriers with hereditary breast cancer mutations and ladies with breast implants. Now, this is just a case snippet in a lady with, what do I do here? Okay, sorry, there's some poll coming. So here you can see that there is a suspicious looking breast mass on the mammogram. Just give me 1 second. Yeah, sorry. And an ultrasound, again, it was a suspicious looking breast mass. This is in a contralateral breast of a lady having a small breast cancer. And this was a large breast mass. But on ultrasound in the other images, we could see some sinus tracts going. So since the problem was not getting solved and the biopsy was inconclusive, just showing necroinflammatory infiltrates, we did an MRI where there was a lot of enhancement, lot of draining tracts going in all quadrants of the breast. And a repeat biopsy was then done from a representative area, which showed it to be a granulomatous mastitis. So coming to the third component, that is, and the last component, that is the pathology. So for pathology, what is routinely done is an ultrasound guided core needle biopsy from breast lesions along with any suspicious axillary lymph node. It tells you the histological type, whether it's an invasive breast cancer of no special type or any special type. It is DCIS or invasive cancer. It tells you the ERPR status, the HER2 status, the grade of the tumor, the Ki67, and the tumor infiltrating lymphocytes. Now, just quickly, how to do it. So, Saksham is a learning management platform by the Ministry of Health and Family Welfare. And the nodal center is here with us at SET facility AIMS. So, how to do a core needle biopsy has been given in detail on the Saksham platform, and anybody can go and enroll and see this. It has a video, the PDF document about it, some assessment questionnaire. There's a discussion forum on the LMS, and you can also give your feedback. Now, coming to the role of FNAC. So initially when triple assessment started way back in 1975, the modality for doing a biopsy were the incisional or excisional biopsies. Percutaneous biopsies were not available. So the evaluation of palpable breast masses by physical examination, mammography, and FNAC is the definition that has been described in one of the original articles way back in 75. Now shift to open biopsy to percutaneous biopsy, the importance of knowing hormone receptors, knowing the grade of the tumor, everything, the international guidelines shifted from an FNAC to a core needle biopsy, and gradually all centers started adapting to a percutaneous core needle biopsy. However, I would still say that 70-80% of the patients diagnosed from elsewhere, or maybe tier 1 and 2 centers do come with a FNAC. And when I looked at the literature, there is something called as modified triple assessment, and a lot of this is coming from India. There's an article recently that has come up from Gujarat. So I'll just tell this was the original JAMA article this is from 1999, 98. So 259 patients they had, and they gave a scoring from 1 to 3 for each of the 3 modalities. 1 was benign, 2 was indeterminate, and 3 was malignant. And they said that, points up to 4 are usually benign and can be just followed up. Points 5 or more, they require open biopsy. And this scoring system and triple assessment reduced their open biopsy rate from 40 to 80%. So here what they have used in the is FNAC and not the biopsy. This is prior to the widespread adoption of core needle biopsy. So we reviewed our data in, I think, 2016-17, and there were 698 patients from who had undergone an FNAC, and the gold standard was the histopathology here. And we saw that it had an absolute sensitivity of around 90%, a complete sensitivity of almost 100% with a 100% positive predictive value. Out of there, only 2 cases were there which were not picked up by the FNAC, and they were somehow not picked up on the core needle biopsy also. Now, the second argument that is given is the immunohistochemistry. So this was again way back in 2014 from our institute, where it was shown that FISH can be done and it can be a cost-effective model, because by and large, the core needle biopsy setup and the instruments are more expensive than the FNAC. So then, since this bridge course is all about tier 1 and 2 cities and cost effectiveness, I thought that this point can be highlighted. Having said that, in our own clinical practice, this was the audit from 1993 to 2019, and we realized that FNAC have definitely gone down, core needle biopsy has come up, and now we routinely do a core needle biopsy in accordance with the international guidance. There has a lot of safety net that comes along with it, and everybody obviously wants to follow the international recommendations and play safe in today's time. So those who don't have an access to core needle biopsy, maybe they can choose wisely and or adopt cheaper methods of doing core needle biopsy. So to sum up, this represents the triple assessment, and it is the cornerstone in assessment of breast lumps. In case there's a discordance, before jumping on to any conclusion, always communicate with the radiologist and pathologist as to what has to be done next. We all need to learn to read films and perform conatal biopsies ourselves. It shortens the diagnostic pathways and definitely brings down, performing it yourself definitely brings down the cost as well. Whenever you are in doubt, the triple assessment is not concordance. Instead of, doing something uh, like a very badly done BCS for a excision biopsy, seek opinion and go and read resources which are reliable. There are videos on triple assessment by Dr. Anurag Srivastav, which are there on the website of Love and Bailey in the previous edition. So with this, I'll end up my talk, and if there are any questions, I'll be very happy to answer them.
Thank you so much, ma'am, for that very lucid talk. And the bottom line for all the delegates here is that triple assessment, which includes clinical examination, radiological evaluation, and core needle biopsy, is currently the standard of care. And we should try to offer these to our patients. And then someone has asked that please give link for suction.
Okay, so you can just go and type Saksham on Google. I'll share the link also. So it is available. It's an initiative by the Ministry of Health and Family Welfare. And not only this, there are various other resources that have been pre-recorded by faculty, which is available on the platform. And they are both didactic lecture type lectures and skill-based lectures as well.
Yes, so you can share the link with me. I will
I'll do it. I'll do that.
forward it to delegates.
Sure.
Yes, Vidya ma'am, please.
Thank you very much for your presentation. Very nice. I just want to add, core biopsy is not an international one. The reason we're doing core biopsy, it has tissue. The tissue not only divides and distinguish between invasive and pre-malignant or DCIS or LCIS, it also gives us receptor status. But there will be time coming up where we can use cell cytology to look at the invasiveness and also the receptors. But until then, core biopsy will remain the standard.
Yes, rightly said.
Perfect. Actually, that is what I had mentioned, that core needle biopsy is standard. Even for us, it is the standard. But since there's a resurgence in the interest on cytology, I think, and especially I found that there are papers which are published from India on, the modified triple assessment where they've replaced core needle with FNAC. I thought it's a good platform to convey it to the delegates.
Right. So someone has a query, and it was asked in our delegates group also. What about open incisional biopsy in case core needle biopsy is not available or it is too costly?
Now, I think maybe you can liaison with a government setup in your city and get a core needle biopsy and come back, because an open incisional biopsy is, I would say, it's a morbid procedure. You give an incision, then your future prospects of doing conservation surgery get limited. It is not that it goes away, but maybe a scarless technique may then not be possible if you are giving an incision to get a biopsy done. So I think, plus there are now core needle biopsy is getting cheaper and cheaper. There are companies, not only the standard ones, there are companies which are indigenously, giving the guns at a much lesser cost as compared to the conventional barred biopsy guns. So I think maybe you can explore those options. I personally am not very comfortable doing the first time an excisional or an incisional biopsy for an undiagnosed breast lump.
Yes, ma'am, and rightly, as Vidya ma'am pointed out, for the benefit of all the delegates, that we can reuse the biopsy gun. And the cheapest biopsy gun available, automated biopsy gun available in India costs around 1,500 rupees. And you can use it in 5 patients, 6 patients, like that. So the actual cost for per patient will be less than 300 rupees. So I think in this scenario, we should not opt for open incisional biopsy, or I will also say FNAC, because core needle biopsy is not a costly affair as at present in India, right? And even under Ayushman Bharat scheme for biopsy, there is 5,000 rupees available for biopsy and evaluation of patients with cancer. So for even for like poorest of the poor patients, we have option available. So I think we should stick to that.
So now, while everybody thinks that funds are unlimited at AIMS, even we reuse the biopsy because the poor patients cannot get it and we don't have unlimited resources available with us. And the only thing that we do is we take a consent before using a used biopsy, which has been cleaned and sterilized again, that we are using a reusable biopsy gun. I mean, we are reusing a biopsy gun, which is meant for a single purpose.
Right. Thank you so much. So, with this, our next talk is very important because that is something which we face in majority of our OPD clinical practices. Like majority of our patients will be suffering from just simple benign problems, not a cancerous one. And for that, we have Professor Anurag Srivastava, sir. He will be speaking on benign breast diseases, how to navigate them. Sir.
Thank
Over
you.
to
Allow me to share the screen. Thank you.
yes, sir. You can share it now.
Okay. Can you see this, the first slide? Should I go on the full screen?
Yes, sir. Yes, sir.
Okay. So thanks very much, Sanjay and Dr. Vidya and the whole team of Bridges. I dedicate this talk to my great guru of benign breast disease, Professor Leslie Hughes of Cardiff, who set up a great benign breast clinic and center in Cardiff way back in 70s. And I also introduce you to the ANDI concept, ND concept. And at the end of the session, we will play a small video clip animation to explain what is this about. This explains all the benign conditions which are an aberration in normal development and evolution. That's the acronym for ANDI. So I come to the most common uh, affection of the mammary gland, that is mastalgia, which is a very distressing symptom. And in some studies in Cardiff and around, it has been shown that about 70% of all women during their reproductive years of life suffer from some degree of mastalgia. And in about 50% of all women in some breast clinics and maybe more will present to you with just breast pain as the main presenting symptom. And cancer among patients presenting with mastalgia is rare, but in some studies, 5 to 20% of cancer patients may also present with breast pain. And it's classified into two, cyclical or non-cyclical, depending on whether it's related to the menstrual cycle or not. And a doctor has the duty to identify whether the lady is suffering from true breast pain or a musculoskeletal chest wall pain or referred pain from, say, angina pectoris, reflux esophagitis, even pancreatitis or gallstone disease or pleuritic pain. And we have a detailed video on this. It's a triple assessment. It's available on YouTube as well as in the Bailey and Love breast chapter. So students can watch it and understand more about it. Now, conventionally, the Cardiff breast pain chart has been used throughout the world, but there were some issues in this pain chart. The ladies could not differentiate between the left pain and the right breast pain, and nor did they were able to put the recording of the periods experience in the same chart. There was cluttering of the information. So we developed our own pain chart where the pain on the right and the left mammary glands is depicted on a visual analog scale of 0 to 10. And for illiterate women, we also put these faces to explain the visual analog scale. So we have a objective way of measuring the breast pain on a monthly basis. So it's a basically objective pain diary for the right and the left mammary gland. And in the bottom, we have a separate chart for menstrual experience. So there's no cluttering, and it's available on Indian Journal of Surgery, and you are free to download it. And recently, Dr. Deepten Sarkar in Calcutta has developed even a more beautiful advancement of this pain chart. So you're also welcome to use that pain chart from Calcutta. So coming to management principle, because Sanjay told me to have a very brief presentation. So essentially triple assessment, as Dr. Sohani has just mentioned. However, if your lady has no discrete lesion seen on ultrasound, there is no need of biopsy. So examine the lady, there is some nodularity, and you do the ultrasound shows no discrete lesion, then there is no need for any biopsy. And therefore, it may be just dual assessment, not triple in all cases. And one has the duty of excluding malignancy, especially in 30 to 40 plus age group. The reassurance is the mainstay of treatment. And if you reassure in some randomized trials, 85% women will be happy with just reassurance that a senior doctor has seen them, the imaging has been done, and a thorough examination has been done, a proper explanation has been given to them, and they feel very happy. They don't need any further treatment. In those who are the pain, so they are called after 1 month of their pain chart filling, and their experience is noted on the pain chart. If the lady has more pain than 3 on a score of 0 to 10, we offer some adjunct treatment in the form of flaxseed, randomized trials of flaxseed, which is a rich source of omega-3 fatty acid, given in the dose of 30 grams, that is 2 tablespoons, 2 large tablespoonfuls a day, has been found in randomized trials to be more effective than placebo in controlling of breast pain. So we offer to all these ladies. Exercise and reducing the weight, along with wearing appropriately tight sports garment, is also very effective. And randomized trials have shown that about 89% of women wearing tight sports bra in the daytime has again been found to be beneficial compared to a non-sports bra. So again, we should use it. Local application of non-NSAIDs drugs like pyroxicam gel or diclofenac gel has been found in randomized trials compared to the placebo. So again, it's recommended. And in Iran and some Asian countries, the kalonji oil, which is a black seed oil, and Nigella sativa is the kalonji, and it is used in Unani medicine. And again, this oil massage over the painful area compared to the placebo oil has again been found in randomized trials to be beneficial. So it's also recommended if a lady can find it. It's available in Unani medicine and Ayurvedic medicine shops. For women who have trigger spot pain localized to just one spot, and local injection of long-acting steroids like triamcinolone and medroxyprogesterone acetate, along with lignocaine, local anesthetic, is really works wonder, and you repeat it 3 weekly for about 4 to 5 cycles. Systemic medication is reserved to women who have persistent breast pain after all this, after 1 month of conservative medication. So we performed the first meta-analysis on all the treatment modalities, all the trials available to us, along with Dr. Mansell in Cardiff, and we found that the tamoxifen, bromocriptine, and danazol, they're all very effective. And but evening primrose oil, it's not effective. The effect of evening primrose oil was similar to that of the placebo. So we don't recommend evening primrose oil as a treatment because it's not supported by randomized meta-analysis. So in India, an anti-estrogen drug like tamoxifen was developed by Central Drug Research Institute, and it was called Centroman or ormeloxifene. So we performed the first trial of its role in regression of mastalgia and fibroadenoma. So way back in 2010, and we found that compared to danazol, it's more effective. And you can see the pain response on this graph. On the vertical scale, we have the visual and log scale pain record, starting from around 5 or 6 in the beginning. And just in 1 month of therapy, 4 weeks, you find significant reduction in the pain score, coming to 2 to 3. And then this persists till the therapy is given for 3 months, that is 12 weeks. After that, in women who were given Cencroman, the pain remained at this level. So the ladies had sustained pain relief even after cessation of therapy up to 6 months, that is 24 weeks. Whereas in danazol group, the women, the pain score rose to again around 4. So there is a prolonged carryover effect. In mastalgia trials, it's called carryover effect of Centroman compared to danazol. So this is something to keep in mind. So just to summarize, what we should do, we evaluate the ladies with the triple assessment, rule out any malignancy or significant organic cause for the breast pain, and if there is none, then offer ormeloxifene or Centroman, an anti-estrogen drug, provided ovaries are normal. There should be no PCOD or ovarian cyst. If the ladies have an ovarian cyst or polycystic disease, then we offer tamoxifen for 3 months. This is half the cancer dose, 10 milligram daily for 3 months. And for women who have no response or minimal regression with the first line or meloxifene or tamoxifen, we offer the second line drugs like danazol or bromocriptine. They are put as second line because they carry severe side effects and they are more expensive. However, if the ladies, even after danazol and bromocriptine with 3 months, have minimal or no regression of pain, we classify it as a recalcitrant mastalgia, that is pain lasting for more than 2 to 3 weeks in a month and more than 6 on a scale of 0 to 10. Really severe mastalgia, not relieved by first line or second line drugs. Then Dr. Sohani in AIMS has done a study where she gave a total estrogen blockade, that is a combination of leupride or goserelin along with tamoxifen or Centroman. This given for 3 months had remarkable benefit. 7 out of 10 ladies in this study had complete relief of pain. So this is something to consider, total estrogen blockade for recalcitrant mastalgia. What we should not do is to give evening primrose oil, vitamin E, vitamin B, vitamin A, and other drugs, diuretics. They have no role in randomized trials. So then we come to so this is the conclusion. Is the commonest breast symptom in any breast clinic, mostly physiological. Reassurance would do the job. Lifestyle improvement like diet control, flax seeds, Centroman or tamoxifen, along with anti-inflammatory gel massage will do wonders, and avoid drugs like evening primrose oil or vitamin E. Coming to second question, breast abscess, which are of breast, 2 types, lactational abscess and non-lactational abscess. To save time, I shall focus myself to only lactational breast abscess. The message must go to all the postgraduates and surgical trainees that aspirate, and do not incise, do not put incision and drainage. So it is by far the commonest affliction, I would say, of the mammals. There are about 4.9 billion ladies in the world, and with a crude birth rate of 17 live births per 1,000 women, and mastitis happens in about 11 episodes per 1,000 women of breastfeeding per week. So about 5 to 10% of these will progress to abscess. So you can calculate it's the commonest affliction of the mammals, of the human being, much more than cancers. So if you put an ultrasound probe, you will find a hypoechoic lesion with floating debris, as Dr. Sohani just showed. So that's typical of a breast abscess. And you can measure its dimension and its volume calculation. If it is less than 3 centimeter across or less than 30 ml in volume, then treatment is simple aspiration. If it is larger than 3 centimeter across or more than 30 ml in volume, then treatment is better in the form of a suction drainage. So a word about prevention, we have to educate ladies about correct practice of breastfeeding during pregnancy in the antenatal clinic. We should check about presence of cracked nipple or other abnormalities which may hamper or cause difficulty in breastfeeding. Apply moisturizing soap rather than ordinary soaps which are drying in nature, along with emollient cream. And if there is infection, you can apply mupirocin cream in the cracked nipple. But this must be done in the antenatal period so that lady is prepared and ready for breastfeeding. We should also educate the mothers in the nursery about correct method of latching and feeding at 2-hourly intervals. What we should treat, there's a remarkable change in the practice. There's a practice changing study came from Edinburgh. Dr. John Dixon revolutionized the treatment of breast abscess. that is aspiration and antibiotics replaced incision and drainage, which was most troublesome for the ladies and took long time to heal. So ultrasound guided aspiration is a very convenient way for lactating women. It leaves no scar and does not affect the breastfeeding, does not require even general anesthesia. Some sedation and no hospitalization is often needed. So the management principles are: curtail the infection and empty the breast. This is very important. Emptying the breast by continuing breastfeeding. Women often stop breastfeeding thinking that there is pus in the breast, so it will go to the baby's mouth and will harm their studies. BMJ guidelines have clearly shown that there is no harm to the baby if the lady feeds even from the affected infected breast. Ultrasound guided needle aspiration is the method of choice for treatment. Start anti-staphylococcal antibiotics, continue for at least 10 days to 2 weeks. Erythromycin is very effective because it is effective in presence of milk in the milk ducts. Amoxiclav or flucloxacillin can also be used in women who are penicillin sensitive. Then we can use, or if there is MRSA available on the pus culture, then use lanozolid or clindamycin, which are effective against MRSA. Emphasize the lady to continue breastfeeding and empty every 2 hourly. There is a method of emptying the breast, and the breast care nurse can teach the lady how to empty the breast. Cold cabbage leaves have been found to be very effective in giving soothing sensation to the breast and relieving breast pain. Fitting the appropriate sports brassiere to give compression and prevent the congestion of the lactating breast is again very effective, and along with the analgesics, appropriate analgesics. So studies on ultrasound guided aspiration have demonstrated almost 70 to 100% success if the abscess is less than 3 centimeter in diameter or is less than 30 cc in volume. So most studies have shown remarkable success compared to breast incision and drainage. So that's why for large abscesses more than 3 centimeter in size or more than 30 ml, results are better when we put a suction catheter drainage. And in Banaras Hindu University, Professor H.S. Shukla and his group developed vacuum suction drainage similar to what we put in the operative patients. And this results in very effective suction of large breast abscesses, and lady does not have to come daily for aspiration. Cold cabbage leaf was this grandma's method of treating breast congestion way back in 80s, previous century in Britain and other parts of Europe. So studies have been done comparing chilled cabbage leaves along with other methods, and it has been shown to have marked benefit in terms of, because cold causes vasoconstriction and decreases the permeability, reducing the swelling and pain. And lady, the same day as you have put the aspiration or suction drainage, can commence breastfeeding. So consider this cold cabbage leaf application every 2 hourly. And there was an AIMS study by our nurses, again showing significant benefit of cold cabbage leaf application every 2 hourly, chilled in a refrigerator. Coming to fibroadenoma, is again the commonest form of benign breast mass, solid mass. It's a result of lobular hyperplasia. It's a part of ANDI, aberration in normal development. It's not a true neoplasm. And the WHO consider it as a benign condition where there is combination of connective tissue along with epithelial proliferation. The median age of presentation is around 30, presents as solid, well-defined, rubbery, mobile, lobulated mass, often called breast mouse. Majority of these lesions are located in the upper outer quadrant because 50% of the ductolobular tissue, the TDLU, is present in upper outer quadrant. And it is a result of proliferation of the lobules in the TDLU. That's why most lesions are located in upper outer quadrant. On imaging with an ultrasound, is seen as hypoechoic lesion, wider than taller. When the lady is lying flat on the ultrasound couch, you'll find that this dimension, this is the width and this is the height. So the green line is wider than the taller, with a smooth line and relative low vascularity in the lesion and no sharp edges and no lobulation or angulation of the margin. This is a typical ultrasound picture of a fibroadenoma. If you happen to do mammogram, you will find involuting fibroadenoma presenting as popcorn calcification. And again, this is labeled as Virat's 2. So there are two types of fibroadenoma. Majority of them happen to be simple type called simplex fibroadenoma with low cellularity and benign cytology or histology. And about 15 to 20% would have a complex histology presenting as combination of sclerosing adenosis, calcification, papillary lesion, and cysts. And this type of complex fibroadenoma has been shown in some studies to increase the risk of breast cancer with a relative risk of about 3. Is biopsy always necessary? No. In young girls below 25 years of age with no family history and typical ultrasound picture like this, which will be labeled as Birat's 2, there is no need for biopsy. Just put her on regular follow-up. Sometimes they present as multiple lesions, and that poses a management problem because we do not have very effective drug treatment for these large fibroadenomas. Then they keep recurring. You keep removing and they keep recurring. And if a lesion is more than 5 centimeter in dimension, it's called giant fibroadenoma, and it can present either in the adolescent age group or in the perimenopausal age group. The relative risk for cancer for the garden variety of fibroadenoma is around 1.4 to 1.7 if it's simple. However, if the histology is showing some atypia or hyperplasia, it can go up to 3. Mostly, the cancer arising in fibroadenoma would be of lobular type. However, LCIS and DCIS both have been reported. The management is, again, reassurance in young girls, fibroadenoma less than 3 centimeter in dimension, age below 30 with no family history can be just put on regular follow-up, 3 to 6 monthly evaluation. Medical management can be offered if the patient or the parents ask for some treatment. You know, Dr. Vidya, we have a unique social structure in our country. The parents would come bringing the girl saying that, doctor, the girl is getting married next month and we want the lump to be removed. I have seen patients and their husband coming that this girl did not tell me before marriage that she has lump, therefore I am going to divorce her. So that situation, you know, so we face this unique social problem. That's why we offer some, and we did some studies, and Dr. Fentiman in London demonstrated for the first time that tamoxifen in this doses can reduce fibroadenoma to about 25% or so, given once a day for 3 months. So we carried out a trial on ormeloxifene, which is Indian version of tamoxifen, 30 milligram daily for 3 months, again showed 30% reduction in fibroadenoma. However, if they are multiple, again, it poses a problem because this is not sensitive to drug treatment in any form. So the regression of fibroadenoma was evaluated in a randomized trial, and this is the typical presentation. In the control group, the Western studies, mostly from long-term follow-up in Britain, has shown that about 1/3 of fibroadenomas will regress. 1/3 will remain static and 1/3 may progress. 1/3, 1/3, 1/3. However, in our group, in the control arm, only 6% disappeared, 18% decreased in size, and 75% actually increased or remained static. So this picture was different. Our experience was different from the British fibroadenomas. So Centroman group, which is an anti-estrogen like tamoxifen, and we had 29% disappeared completely in 3 months of treatment, 54% decreased in size, and only 16% increase. So there was a relative risk of reduction of 4.7. So women who are given Centroman are 4 times more likely to have regression of their fibroadenoma, either complete disappearance or regression to a significant extent. So surgical management is followed if there are the following criteria. The American College of Surgeons has presented their criteria for surgical removal: age more than 35, size more than 2.5, restricted mobility with ill-defined borders on imaging, and image histopathology discordance. In our country, because of younger age of onset of cancer, we have put a cutoff of 30. Patient preference, again, and the family preference is also taken into consideration. Of lump is painful, or giant, more than 5 centimeter, if histology or cytology shows some atypia or complex fibroadenoma, or if there is a family history. So these are the criteria of removal of fibroadenoma. And what do we do? With young girls below 30, we offer enucleation, preserve the capsule, and do not occlude. Like in oncoplasty, you try to occlude the cavity. No, please do not do that. Otherwise, the cavity will never fill. It's remarkable how in just 6 months' time, that cavity will fill by proliferation of ductolobular tissue, and there'll be no cavity left in younger age groups. Keep the capsule intact, do not occlude. But in older age group, more than 30, the capsule is less well developed, and there is always a risk of either missing a phylloids or even an early cancer. So we excise with a rim of normal tissue just in case the final histology happens to be carcinoma or phylloids. So enucleation in younger and excision in the older age group. Now come to the fourth benign condition, which Sanjay asked me to talk, simple cyst or Birat's 2. So lady comes with a breast lump, mostly in the perimenopausal age group, 40, 45 age group, and she is very anxious, worried about cancer. You are also worried on physical examination because a tense cyst may feel hard. It feels like a cancer. And the last week I had a lady, 50 years of age, and I was worried about cancer. I told or discussed all the prognosis and everything with the family. But when she came with the ultrasound, this was a typical Birat's 2 lesion, smooth walled cyst, no filling defect. And if you put a Doppler probe anywhere, you will find no vascularity. And on aspiration, just to console the patient, you need not do an aspiration in typical Birat's 2, but just to console and put her mind to rest, you can put a needle and aspirate. If this fluid is non-bloody, there is no need for sending cytology. In Cardiff Clinic, we used to do aspiration, and about thousands of samples were aspirated. And there was a theory that if you show apocrine metaplasia, or if there is sodium to potassium, high potassium ratio to sodium ratio in the cyst fluid, there's an increased chance of cancer developing in the future. So a lot of studies were done in Cardiff, but again, the final result was there is no benefit of aspiration or doing cytology or any fanciful study in the breast fluid, cyst fluid, if it is non-hemorrhagic. If it is hemorrhagic, please do send it for cytology because it could be malignancy. However, if a lesion shows like this is a simple Birat's 2 cyst. However, if a lesion is showing a cyst with a filling defect on one wall, it could be papillary cyst adenocarcinoma, and it's called as complex cyst. Complex cyst is a solid and cystic component, or one with the septa. This has a high risk of malignancy, and we excise the lesion, and we found that this was the solid part. This actually proved to be cancer. And some breast surgeons say that if you see a papillary lesion, you should not biopsy, you should just excise it. Because when you put a biopsy needle, and if it goes through this wall, it will collapse the cyst, and you may miss this part of the lesion. So it's better excise the whole cystic solid lesion and complex cyst rather than doing a biopsy of papillary lesion. So complex cysts are not very common. About 5% of all cysts will be complex, but they have a higher rate of malignancy compared to the usual garden variety of breast cysts. Histology could be anything from fibrocystic change to duct papilloma, abscess, hematoma, phylloids tumor, or even ADH or early carcinoma. And Burge et al. Has given 4 types of classification. So it's very important to ask the radiologist which type of breast cysts are we dealing with, because management would differ. So this is in short about the 4 common conditions of the mammary gland, which affects majority of the ladies. And if Sanjay permits, I may play this.
ND concept of benign breast disease has been explained in this video animation. ND is an acronym for aberration in normal development and involution. This concept was first initiated by experts in benign breast disease at Cardiff Breast Unit, led by Professor Ellie Hughes, Robert Mansell, and David Webster. This concept allows us to understand most of the symptoms and presentation of patients suffering from benign breast disease. It is thought that nodularity of the breast nipple discharge, mastalgia, small lumps in the breast like fibroadenoma, duct papilloma, and breast cysts can all be explained with this pathophysiological concept of ND. We shall explain this concept through some anatomical facts. There are 7 to 8 lobes in each breast. These are arranged like bunch of grapes, each grape representing the milk
Sir,
gland or acinus, and the stalk represents the major milk duct
Anurag sir,
at
I
the
think
nipple. Each lobe
It's just finishing
contains
in
10 to
2
40
minutes.
lobules, which in turn are composed of 10 to 100 acini. These acini are the basic secretory unit of the breast. The terminal ducts, together with the lobules, constitute terminal ductal lobular unit, known by the acronym TDLU. TDLU is the most hormone responsive and most active part of the mammary gland. The epithelial lining of the duct
think this. Hello.
Yeah.
I think this video is, we are not able to hear anything. So what we can do, you can share this video with me. I will
Okay, okay.
share with the
Achha,
delegate group.
okay. Sound was not audible to you?
Yes, yes.
Okay, we'll share it then. Thank you.
So,
Thank you.
thank you, sir, for this very important talk. And going by the chat box, we know how much interesting benign breast disease is, because we face these challenges regularly. And even at the ASBRS meeting last year at Vegas, the session on benign breast disease was almost full. So I will assign you to the breakout room. So many people have lots of doubts regarding centromet, tamoxifen. You can clarify their doubts.
Right.
Meanwhile, we will start with our next presentation.
Sure. Thank you. Thank you. Thank you, Sanjay. Thank you. Thank you. Thank you.
So, Dr. Dilip will be speaking on bone needle biopsy. It is the standard of care at present.
Sanjay sir, you will go with the recording or?
Yeah, I am trying to play the recording.
Left side, left leg.
Is it visible now?
Yes, Sanjay.
Myself, Dr. Dilip. I'm from
Okay.
Tata Memorial
And
Center.
audible as well?
Yes.
Okay.
I thank Dr. Sanjay for giving me this opportunity and bringing up this course, which is a unique thing, locally adaptable solutions in breast surgery in a resource limited setting. A wonderful initiative. Greetings from Tata Memorial Hospital. This is where I worked in initial 2 years. Now I've moved on to ACTRED, which is another Tata Memorial Center unit, where me and Dr. Deshpande were asked to set up a breast clinic environment. So today's topic for me is bone needle biopsy. Why do we have to do it? Why not choose a simpler and a much commonly available system? Why not go with AC? What are the major advantages and disadvantages or drawbacks of doing an FNAC for breast lump diagnosis? The good part of it or the better part of it, let's see the studies one by one. So this is an article from AIIMS New Delhi which came up in 2017, which is a retrospective study which talked about the diagnostic accuracy of FNAC. which showed that it had an absolute sensitivity of about 90% and a complete sensitivity of about 99.7% with a positive predictive value of 100%. Wonderful results of FNAC giving us a diagnosis. Similar studies came up in many other resource limited settings. This one is from Sudan, which said that the FNAC is an ideal solution in a resource limited setting. Similar to that was another study by Dr. P.I.N.K and his team, which showed FNAC as well as core needle biopsy almost had similar results when it came to sensitivity, specificity, positive predictive value, and diagnostic accuracies. So in a resource limited setting, all these studies concurred that FNAC is a valuable tool in coming to a diagnosis. So why there is a disadvantage when you can nicely diagnose breast cancers? So let's take this paper from Williams et al., who did an extensive review, and they did mention in majority of the studies, FNAC did show a good diagnostic accuracy. However, it should also be noted in the study that they included had all of them had either a proper benign or a proper malignant diagnosis, ignoring the atypical and the suspicious category lesions, which account for up to 20% of breast daily pathology. So, this another study from Netherlands which showed that these 20 out of these 20 percentage of lesions, the diagnostic accuracy for a suspicious lesion was only about 78% in an FNAC, whereas it was 100% for needle biopsy. When it comes to atypia, FNAC just fared very poorly. In about only 1 out of 5 cases where it could actually say 1/5 of cases where it could actually come to a diagnosis, whereas pure needle biopsy was far better with 4/5 of it could be diagnosed with. Good diagnostic condition. The suspicious rates for needle biopsy still had 5% problems, whereas FNAC you can still see the inconclusive reports, it's about 15%. So we're still having a lot of issues over there. The FNAC is inconclusive in about 15% of cases. So the same review paper from Williams et al. Showed the red bar shows the core needle biopsy, and the blue bar shows the FNAC bars. In all of them, the sensitivity, the FNAC is just better. The sensitivity of core needle biopsy is just better than the FNAC. Whereas when it comes to specificity, again the red bars fare much better than the blue bars. So in this they concluded that the FNAC sensitivity was about 35 to 95%, whereas the core needle biopsy sensitivity is about 85 to 100%. Now the specificity say for the FNAC is again 48 to 100%, whereas for core needle biopsy it's about 80 to 100%. Now, can an FNAC can be predictive and prognostic? Can it diagnose the predictive and prognostic marks? Can it pick it up? So there are multiple studies showing that this FNAC can pick up cycle cell can pick up the markers. So the overall accuracy, however, the overall accuracy of these tumor grades, tumor types, PRPR status is less reliable. So this study shows that the diagnostic accuracy of cytological grading is only about 70%. The same study gives the sensitivity is about 98%, but when it comes to specificity of ER detection, it's just about 75%. So 1/4 of a case who is positive is dismissed. Coming to the another study from Nizam Hyderabad. So they came up with this. They compared the immunohistochemistry and immunocytochemistry, and the concordance was just about 50% for ER and 29% for PR. What is the major pitfalls? So what are the major drawbacks with the FNAC? FNAC has huge diagnostic challenges when it comes to high-risk lesions, pre-malignant lesions, ILCs, tubular carcinomas, papillary lesions, fibroepithelial lesions, cancer. FNAC has either a very low accuracy or cannot diagnose these conditions. So the literature review by P.J. Chandigarh came up with this table which shows that core needle biopsy in the left column and the FNAC in the right column. It completely outperforms the FNAC in terms of picking up the ERPR status, the tumor rates, the in situ and the invasive component, differentiating between the in situ and invasive components, and LVI, PNA, which is not possible. So what are the advantages? The diagnostic accuracy, the ease of doing it, the estimation of ERPR is possible, though less reliable. The disadvantage of less reliable prognostic markers. Now, you want to take some decisions based on these FNAC reports. Now, that is something which I would be worried about if I'm not sure whether the markers given are right or wrong. And once we have done an FNAC, patient again has to undergo a repeat procedure in about 15% of patients to find out for the inconclusive reports. Now, it fares very poorly in core diagnosis of higher lesions and invasion and cannot diagnose a lymphovascular invasion or peritoneal invasion. Now, so again comes back to this main question. Why do we need a core nerve biopsy? If FNAC is not good, is core nerve biopsy good? So for that, what do I have to see? So we have already seen that it has got a lot of advantages over FNAC. We've got high predictive value, high diagnostic accuracy, pick up all the difficult problems like papillary lesions, premature lesions, and the nasal cancers, and also try and pick up all the ERPR, HER2, and tumor grading and quantitative indexes indices. Now, what is so if FNAC is not there as a surgeon, I would think that okay, I'll just take the tumor out and then let me see what the tumor has got to say in the final pathology report. So for this, Rakha and Oles, they came out with a paper where they correlated the needle specimen with the surgical specimens. So they reviewed and they saw that core needle biopsy was equally effective as any surgical X-ray specimen, and it showed almost 85 to 95% of accuracy in ERPR and HER2 identification and tumor typing and grading. Though grading had a less correlation, but the typing and other factors were quite well correlated. Now, what is the impact of core needle biopsy as to management of abnormalities? Now, why do I have to do a core needle biopsy before I go ahead and excise? You can see here only 58% underwent excision of the lesions that was core needle biopsy, whereas 97% patients underwent an excision biopsy. So we have avoided 40% of unnecessary surgeries. So core needle biopsies just prevents an unnecessary surgery which is being done. And with a preoperative proper core needle biopsy, this facilitates wider initial margins of excision, fewer positive margins, fewer surgical risks to accomplish definitive treatment and diagnosis. Once now established the role of diagnostic accuracy of core needle biopsy. So we wanted to see if the can be used for treatment planning. This started off with the visit of Deshpande's paper, who is actually my mentor now in ACRET. So we started off with the idea whether we can use it for treatment planning, management of breast cancers. So yes, though initially it was a study which was negative to begin with, but over a period of time, the entire idea of the started to revolve around the markers that came out with the total biopsy. So it determines the need for neoadjuvant therapy. It also guides us surgical planning, whether it's DCS or a massive for a vaccine stage procedures. It also helps in alternative concept and risk stratification. Lower complication rate, minor dosing of rare risk infection, and it does not increase tumor spread. Guidelines, NCCN guidelines, core biopsy is recommended. All the major societies or major guideline bodies do suggest core biopsy is definitely in plan patients for breast cancer. Now, NCCN came up with this basic resource framework, which was basically basic minimum standard of care that is needed to improve the disease-specific outcomes. And yes, in that, diagnosis of ERPR is definitely needed. FNAC is less reliable when compared to core needle biopsy in terms of reliability. So, in conclusion, basic, simple, essential diagnostic outpatient procedure, assessment of predictive and prognostic markers, management planning tool, attacks to managing planning tool, cancer, minimize unnecessary surgery, and second surgeries. And yes, core biopsies improve patient outcomes.
Thank you, Dilip, for emphasizing once again why core needle biopsy is important. And if anyone has any question or comments, we can take it now.
Thank you, Sanjay sir. Any questions I would like to take?
Can I ask you a question, Dilip?
Sure,
What
ma'am.
are the core biopsy guns available in India now? Because you can use TrueCut core biopsy, for which you don't need a gun at all, isn't it? It's available on, I just Google, is available on some supermarket for £100, 100 rupees.
But we'll have to check if they are really worthwhile using them, whether we would get that good tissue that we need for a proper histological examination, ma'am. So we do have a lot of variety which is available, but the lowest which is available, as Sanjay sir said, it's about 1500. We do have a disposable gun along. We do have a reusable gun along with disposable needles. So probably we can use them and change the needles along. We do that in TMH as well, where we use the gun, but we change the needles. And each and every time we change it, it comes around 800 or 1000 rupees for that needle to be used.
Sanjay, maybe you have some job to look at these guns because I just Googled on Indian market. It's available for 100 rupees.
I'm talking about that. What kind of needles we have? I'm just showing in my slide.
Yes, definitely. So as I guess it earlier also, there are a lot of cheaper options available now in India. So now once we have now seen that core needle biopsy is essential part of breast cancer care, and both the speakers, Professor Suhani and Dr. Dilip, have clearly emphasized that point. Now we will learn how can we perform core needle biopsy, how to do it accurately. So for that, we have Dr. Vishwak, who is Chief of Breast Surgical Oncology at Rajiv Gandhi Cancer Institute, New Delhi. Over to you, Dr. Vishwak.
So, am I slide visible and am I audible?
Yes, perfect and clear.
Okay. So, good afternoon, everyone. Thank you, Dr. Sanjay, for the wonderful opportunity that you had offered me. Thank you, Dr. Suhani and Dr. Dilip, for setting up the stage to make it appropriate that the mandatory of core needle biopsy, even in the low resource setting. So now we see how we do biopsies, core needle biopsy. So we have two set of devices which we have. The one is the spring-loaded gun or the true cut needle, where we had to insert multiple times to take the lesions, and the other one is the vacuum assistance. Just a second. Yeah. The other one is the vacuum assistant device, where we can just insert once and we can take a multiple chunk of tissues. Especially we use this for a microcalcifications. Now, my topic will be pertinent with the core needle biopsy alone. So this is a young lady with a BIRATS 4C right breast lump, which I'm going to discuss with. So the materials which are required for the biopsy is a local anesthetic infiltration and lignocaine gel or a sonography gel to assist in image guidance. This is the core needle biopsy gun which we are talking about. This is the barred gun device 14 gauge, which is around 2,400 to 3,000 INR. The needle in this gun, it can be replaced, which costs about 700 to 850 INR. And if at all in low resource setting, if we had to reuse it, the entire gun and the needle can be sterilized by ETO and can be used it for 4 to 5 times. The next is the 11 blade needle or the coaxial needle, which I use. I show it in the procedure, and few gauze pieces and a buffer 10% formalin solution to collect the specimen. This is the another true cut needle which we are getting in India. This costs around 900 rupees to 1,400. That depends on the company. It also gets a adequate core of tissue, provided you have a good expertise with the use of this. Of course, in a low resource setting, we can use this, a true cut simple device, which is available across the India. So now we see how we do the procedure. The patient is positioned comfortably with her arm raised above the head with a support underneath the shoulder to have a adequate tilt, and preparation of the surgical field is being done and draped. Local anesthesia is being infiltrated in the skin, the subcutaneous plane, and the biopsy tract in and around the tumor site to make sure the patient is comfortable during the procedure, does not having any pain. So you could see the local anesthesia drug is being infiltrated in and around the tumor site and along biopsy tract. Now I'm passing a 14 gauge coaxial needle. The tip of this needle is placed adjacent to the target area of biopsy. So here I'm positioning the coaxial needle adjacent to the area of target. Now the gun is inserted through the coaxial needle and it's fired. So when it is firing, the needle cuts a sleeve of 2 centimeter length of a core tissue, which you can see here. And that's the 10% buffered formalin. You could see a core tissue sinks to the bottom of the container, whereas a fatty tissue, it will float on the formalin solution. Having the coaxial needle in place, I'm inserting the gun again, just tilting the coaxial needle little, and I'm directing the needle through the another direction. So I have taken out minimum of 4 cores. Then coaxial needle is withdrawn, sterile dressings are applied. When do you say a specimen is appropriate? Minimum of 2 non-fragmented strips is required to determine the diagnosis. However, minimum of 4 cores are recommended to achieve complete concordance of pathological parameters like ER, PR, HER2/neu, and tumor grade from between the surgical specimen and the core needle biopsy specimen. So, majority of the guideline, it recommends a minimum of 4 non-fragmented adequate cores. So mostly this procedure is done on the OPD basis, and the patient can go home after the procedure. The pain will be mild, and that can be very well managed with the mild analgesics like paracetamol. I usually encourage them to wear a well-fitting bra for the couple of days, and a mild bruise on the skin is expected, and that will settle down in a period of 2 or 3 days. The most important thing is once you have taken the course, what are the things that has to be mentioned on the pathological request form? The identification of the patient, name with the CR number or registration number, the site, the location of the targeted lesion, and where from the biopsy specimen was done. Is it from the mass or from any architectural distortion or for a non-mass enhancement, or whether it is a microcalcification? And what is the radiological suspicion, BI-RADS 4 or 3, BI-RADS 5? Whether it's done by these image guidance or not, and what gauge of needle is used, and most importantly, how many number of courses being sent. Thank you. I'm happy to answer any questions. So just want to add, in a low research setting, even if ultrasound guidance is not there, make sure that this lesion doesn't have a solid cystic component with an ultrasound, basic ultrasound, where you can correlate the mammography with an ultrasound. And we can perform a blind coronal biopsy without an ultrasound guidance by palpation method, and ensure that the core that has been specimen sampled has a white non-fragmented tissue which sinks to the bottom of the container.
Right. Thank you. Thank you, Dr. Vishwak. Professor Anurag Srivastava wants to say something. Sir, please unmute yourself. Yes.
Yeah. So thank you. Thank you. So we performed a very nice presentation, sir.
Thank you.
We performed a randomized trial in AIMS comparing palpation guided core needle biopsy versus image guided core needle biopsy. And you know, with image guided core needle biopsy, our sensitivity, positive predictive value, and false negativity was 0, and sensitivity was 100%. Whereas when we did palpation guided biopsy, about 30% cases had to come back where the biopsy report was inconclusive and they had to repeat the biopsy. So I will strongly urge for all doctors to do image guided biopsy. You know why? Because first of all, a lesion may have some cystic degeneration in the center, so you will miss that if you do not do image guided. Number 2, there may be blood vessels. In angiogenesis occurs in inflammatory lesions and in cancers, and if you hit a blood vessel, on palpation guided, blind palpation guided biopsy, you cause a big hematoma. A 2 centimeter lesion grows to become a 5 centimeter lesion. And then you are perplexed how much to remove if you're doing a front surgery. So as far as possible, always go for image guided biopsy to get the highest yield. Thank you very much.
Ah,
The randomized trial, you can search in the literature.
Point well noted, sir. Point well noted. Yeah, absolutely. The image guided biopsy has the more positive predictive value, as you have mentioned, provided the surgeons should have that expertise. The second thing Dr. Suhani had pointed out, the co-needle biopsy itself is a coaxial needle. Why a separate another coaxial needle? Yes, of course. The another separate coaxial needle is not mandatory. I had shown the 11 blade, even just 11 blade is enough to just make a small nick where we can insert the cone needle, um, the gun needle itself. The coaxial needle is not a mandatory one.
Right, thank you. And I hope it is clear to all the delegates how to perform core needle biopsy. And obviously, if image guidance is available, then it is a luxury. You can always go for that. Otherwise, I think palpation guided is also good enough. But you have to learn how to do a good core needle biopsy. And Dr. Gunj is saying that can you give input on securing the stabs
Exactly.
with a suture after biopsy? Is it necessary? And can that be used as a mark in future when planning BCT?
So, not necessarily suturing is required for a small stab site or the entry point of the needle. If at all, if you have a steri strip, just a simple steri strip would suffice. Even if that is also not available, just a normal regular dressing is enough. That small stab wound will automatically get healed in a couple of days. And earlier, we have this logic of excising the biopsy scar also along with the surgical specimen when we contemplate surgery. But nowadays, it's not mandatory to excise the biopsy site or the scar site along with the surgical specimen. And the other question is, how do we take coronal biopsy in microcalcification, which not seen on ultrasound? Yes, we take it the guidance through stereotactic. We do it under mammography guidance. We go for a coronal biopsy. If expertise is there, we can go for a vacuum assisted biopsy of the microcalcifications under stereotactic. Provided you should take the specimen also, you should look for the microcalcifications in the specimen sampled in under the X-ray. And one more thing, just want to add on, if we are doing a coronal biopsy for a non-palpable lesion or for a screen detected non-palpable lesion, always consider placing a marker or an ultra-radio opaque marker at the site of biopsy when you take a core needle biopsy. So that would help us to locate the tumor site when we are contemplating surgery.
Right. So just to clarify again, that you don't have to suture the stab site. Simple dressing is fine, which can be removed after 24 hours, and patient can take normal bath. And neither any antibiotic is required after core needle biopsy.
Yeah. And answering to Dr. Vidya, ma'am, yeah, of course, the markers are costly. What we use here in our center or in a few of the centers in India, we use the titanium clips. The titanium clips are cheaper, which we use for bracketing the tumor cavity for facilitating adjuvant RT, right? So we use those titanium ligature clips. We open the clip and then we place it in the tumor site for localization, either at the neoadjuvant setting or for localizing a non-palpable lesion.
Thank you. So now next, I have a small presentation on a low-cost biopsy technique, since we have been discussing about the cost of core needle biopsy. So we developed it here in Jabalpur when some 5-6 years ago, when the facility of the core biopsy gun used to be costly, but now as we have discussed that the cheaper options are available, even we are using the coaxial automated biopsy gun only. But sometimes if it is not working, we resort to this technique, which we call core needle biopsy. So that time the core biopsy gun used to cost around 3,000 to 5,000 Indian national rupees. So we came with this low cost core biopsy technique, which is made of one 50 ml syringe, one 10 ml syringe, and a 14 gauge needle. And that is the core which you obtain from this gun. So here is a short video demonstrating how it is done. First, so preparation is same as Dr. Vishwak just showed. So now we insert the 50 ml syringe with 14 gauge needle first inside the lump. Then we put a 10 ml syringe between the plunger of the 15 ml syringe and base, and it creates a strong vacuum, and we with to and fro motion we obtain the chunks. Now what is important is to use a 14 gauge needle which is available on Amazon or other online platforms. You can get a wide bore 14 gauge needle, so that gives a good core. And with this, our sensitivity was around 92%. Specificity was good, and diagnostic accuracy was also satisfactory. So this technique has been used by like many radiologists and surgeons in Africa as well, and they have reported to us that they get good results with it. So the whole setup is less than 100 rupees, and for us, these syringes, they are like always in supply. So for our patients, it is absolutely free of cost. So thank you. I will share the full text of this technique in the delegates group. Next, once we have diagnosed that it is a cancer, now next critical dilemma is how to stage and when to stage, like do metastatic workup. And for that, we have Dr. Chandan Kumar Jha from AIMS Patna. So he will be speaking on staging workup, when and how. Over to you, sir.
Thank you, Sanjay. So, good evening, everyone. Sanjay, please confirm, is my screen visible?
Yes, it is visible.
Okay. So let us quickly go through this. This is again the basic topic, like triple evaluation, and Dr. Swani has already done half of the job. So okay. So many times at the start of your career, you tend to believe that staging is synonymous with metastatic workup, which is not the case. Staging basically means defining a T stage, a N stage, and a M stage for your patient, while metastatic workup simply means categorization of whether the patient is metastatic or not. So most of the information in the TNM can be obtained after your clinical examination and imaging examination is performed. And the tools for imaging we have already seen are mammogram and ultrasound, both of which uh, allow you complete information most of the time about the breast tumor and about the axillary involvement. Uh, in our parts of the world, many times we see patient coming with CE-MRI, it's contrast enhanced MRI of the breast, which is most of the time not recommended. There are clear indications for doing an MRI, which has already been explained. And there is a dictum that if you cannot perform MRI guided biopsy, please avoid doing an MRI, because then you will unnecessarily create false positive findings and you will make the patient more anxious than doing any good. How do we do the metastatic workup or systemic staging or metastatic screening? The choice should be, in our setup, most of the time, CECT chest, abdomen, and pelvis, along with a bone scan. If you have PET-CT available, you can go for it, 18 fluorodeoxyglucose PET. And now, of course, this FES PET has come for ER-positive tumors, but it won't be available at most of the places. So, AJCC 8th edition, which we use all around the world for staging of breast cancer patients, this staging is valid only for invasive and invasive carcinomas of the breast and ductal carcinomas in CT. Lobular carcinomas are no more considered a malignant lesion, and other cancers in the breast like breast sarcoma, breast phyllodes, and breast lymphomas are not staged as per this system. The next important thing to note is that AGCC 8 wants us to classify breast tumors slightly differently than the earlier system. All of us sitting anywhere in any part of the world should be using anatomical stage, but that is the minimum one should be using. Ideally, we all should try to assign a patient to assign a clinical prognostic stage to all of our patients. So what is the difference between anatomical and clinical prognostic stage is the use of biomarker, the grade and the receptor status, the ERPR and HER2. When you add the information obtained on anatomical staging with that of the grade and receptor status, you get a clinical prognostic stage, and which is a better prognostic stage. But in case the facilities for biomarker analysis are not available, as in many parts of the developing world, at least an anatomical stage should be assigned to a patient. Pathological prognostic stage is again very accurate prognostic staging, but it is useful only for the patients who will upfront have surgery, because then you are able to include the findings from the surgery and resected tissue. If the patient has received neoadjuvant therapy, either systemic therapy or radiotherapy, then this stage cannot be assigned to that patient. So how do we get to the anatomic stage? I think even for our MBBS students, we say that if you have to memorize the staging, PNM staging of one cancer, it has to be breast cancer. So I'm very sure all of us are familiar with this. There can be no way that we do not memorize this and go on to manage breast cancer patients. So I'm not going into the details. It will take another 20 minutes. So when you have got a T stage, N stage, and M stage for your patient, which you will come to just after clinical examination and imaging, you will get an anatomic stage group. And based on these anatomic stage groups, you classify your patient into early breast cancer, locally advanced breast cancer, and advanced breast cancer. And basically, this is done because most of the management or almost every management principles are classified according to the early locally advanced or advanced stage of the patient. Coming to the clinical prognostic stage groups, if you see the AJCC manual, there will be number of such tables. And what is important to know is that here we use the clinical T, clinical M stage, and we get a prognostic stage. Now, this prognostic stage may not be exactly same to the anatomical stage. Like for a T2N0 M0, anatomic stage will be stage 2A. But if you just put in the biomarkers and grade, you will see that it can differ. It can be staged from 1B to 2B. If the ERPR is positive, HER positive, and it is a grade 1 tumor, the same tumor will be staged as stage 1B. But if it is HER negative and it becomes grade 3, ERPR negative, HER negative, and grade 3, then the clinical prognosis stage becomes 2B. So that is why all patients, we should try to assign a clinical prognostic stage to all our patients. To know the pathological prognostic stage groups, one has to remember the pathological TNM. The pathological T status staging is almost similar to the clinical T staging. The nodal status differs slightly. Again, we have to remember this. So once the patient, the histopathology report and IHC reports come, you put in pathological tumor size, pathological nodal size on this side, add the grading information, HER, ER, PR information, and you get a pathological prognostic stage group for the patient. Now, there are a number of such tables. Not all of us are that smart to remember these, and actually, I do not find it useful to memorize it. So you can avoid memorizing those tables of clinical prognostic stage and pathologic prognostic stage. Another change that 8th showed, uh, 8th gave us that uh, when a patient who is staged as T1 or T2 N0 and any grade, negative HER status, positive ER-PR status, positive ER status, any PR status, then the pathological prognostic stage is 1A if you use the genomic profile or pathological prognostic staging. But if it is not required to use these genomic profiling for every patient to assign a pathological prognostic stage, it should be used only when available. And if the patient has low score on any of these genetic profiles, the other ones, even mama print, prosigna, whatever. If the recurrence scores are low, then these patients can be assigned a pathological prognostic stage of 1A. If these are not available, we go by our usual method of using PT status, PN status, grade, PR, and HER. And this can be used to determine appropriate treatment. So the other question is when to stage. So we have seen what is early breast cancer, locally advanced breast cancer, and advanced breast cancer. For early breast cancer patient, uh, at the time of diagnosis, we always stage breast and axilla to find T and N status. But if the patient is asymptomatic or there are no lab abnormalities like elevated alkaline phosphatase, elevated calcium, or the tumor is less than T3 or N1, or the axillary status is N0. Actually, we need not do any metastatic screening for such patients. And even after neoadjuvant chemotherapy or neoadjuvant systemic therapy in these patients, metastatic screening is not required. We can just do away with restaging of the breast and axilla before surgery. For locally advanced breast cancer, things are slightly different, where you need to do a full metastatic workup at the time of diagnosis, because many of these patients will have metastatic disease, asymptomatic metastatic disease. So what do we do for metastatic workup? We do a CT, contrast enhanced CT of the chest, abdomen, and pelvis, along with a bone scan. Or if the facilities permit, you can go for a PET-CT. After downstaging or after neoadjuvant chemotherapy, no need to again go for metastatic screening unless there are new symptoms or any other concerns, or the disease has actually progressed despite neoadjuvant therapy. Breast and axilla, of course, will need restaging. For metastatic breast cancer, of course, you do a metastatic workup at the baseline. And once the treatment starts, and if the patient is on chemotherapy, you restage every 2 to 4 cycles, or every 8 to 16 weeks if the patient is on endocrine therapy. If there are any new findings which suggest a progression or there is worsening of any symptoms, you again need to restage. During the follow-up of early breast cancer and locally advanced breast cancer survivors, no routine metastatic screening. If the patient is asymptomatic, we just need to follow clinically 3 to 6 months, every 3 to 6 months for 3 years, then 6 to 12 months for 2 years, and then annually. We do follow up with annual mammogram, which again is staging for breast and axilla. And new metastatic screening is initiated only if there are signs or symptoms which suggest a recurrence. Thank you.
Thank you, Chandan sir, for the wonderful presentation. Any queries in the chat box? We can discuss on that. So meanwhile, Dr. Anurag sir wants to give a comment. Sir, you can unmute yourself.
Huh. So, for the postgraduates, they should appreciate that on the first visit, when you see a patient who has, say, ulcerated fixed tumor, skin edema, podorange, satellite nodules, or a fixed node, you can only say it is advanced breast cancer. You cannot say whether it is locally advanced or metastatic, because to do that, you have to do metastatic workup. So on the first visit, if you have a T3, T4 tumor, and two nodes, also praclavicular nodes and three nodes, we can only write on the diagnosis advanced breast carcinoma. Get the histology and then do a metastatic workup. On the next visit after the metastatic workup, then only you can say whether we are dealing with locally advanced or LABC or metastatic breast cancer. The first visit we can never say that is LABC or that's my statement. Thank you.
Thank you. Thank you, sir.
Thank you, sir.
Chandan sir, meanwhile, I'll just ask you a question for the listeners. How do you assess the dimension of the tumor? By clinical assessment or by mammography, ultrasound, MRI guidance, or you take the PET scan image dimension? There might be some discrepancies among these three. Which of these three you would consider for staging TNM?
Actually, we know very well that clinical examination will almost always overestimate the tumor size. So usually you will go by one of the imaging results, unless usually there won't be vast discrepancies. But if there is discrepancy, I would go by the ultrasound side. That is the most accurate size determination tool, I believe.
Okay. So how do you balance cost effectiveness in metastatic staging workup?
Yeah, you mean to say whether you should go for a CT and bone scan or a FDG PET?
Yes.
FDG PET until few years, it was almost out of question for most of the Indian doctors and patients. Nowadays, it is available in some centers and cost might be equal, but obviously FDG PET has the advantage that you can get the staging done in just one examination. That is the advantage. So it depends. It depends on the availability and the preferences. I do not have access to PET scan, so I have to do a CECT and then a bone scan.
Okay, sir. Yes, sir. Dr. Anurag, sir, please. Sir, please unmute yourself.
Sir, you are not audible.
Yes, Dr. Anurag, sir, please unmute yourself. Dr. Anurag, sir, you are not audible. Please unmute yourself. Please unmute yourself.
Says host is not allowing.
Acha, okay.
Host is not allowing.
Now. You are unmuted, sir. Now you can go.
Okay. So some studies are showing that whole body MRI scan is equivalent to PET CT scan. And of course, there is no radiation. No isotope is given and no radiation.
Yeah.
So whole body MRI is a good substitute for metastatic workup in case PET CT is not available. Thank you.
Okay. So thank you, Dr. Chandan sir. We would go to the next topic. So one of the most debated dilemma in breast cancer management is choosing upfront surgery versus neoadjuvant chemotherapy. So while each approach has its advantages, selecting the right strategy in a right patient that depends on a few the factors, patient factors, tumor factors as well. So let us navigate this complex decision-making process together with Dr. Chitresh. Dr. Chitresh, sir, you can share your screen. Stage is yours.
Yes. Am I audible now?
Yes, sir. You are
Yes.
audible.
Okay. Thank you. Thank you, Dr. Sanjay, Dr. Dhananjay, and all the team of this bridge course. So the stage for me has been set up by Dr. Chandan because he has elaborated the staging at length. So I'll be discussing regarding the upfront surgery versus neoadjuvant chemotherapy. So this debate has emerged in early 1970. Before that, I'm not able to change the slide. I cannot change the slide. Dr. Sanjay, can anybody do it here?
No,
Yes.
since
So for all practical purposes, we divided the breast cancer in metastatic and non-metastatic. And among the non-metastatic breast cancers, inflammatory and non-inflammatory, and among non-inflammatories, early and locally advanced breast cancers. So for inflammatory breast cancer, surgery is the first, and most of the early breast cancer is being treated with surgery first. So the debate arises in the locally advanced breast cancer, where we should do the surgery first, or we should do the neoadjuvant chemotherapy first. So this was a dilemma because traditionally surgery was the first option. Whenever a breast cancer patient was visited to a cancer hospital, surgery was the first uh, strategy for managing the breast cancer patient. But after NSABP B18, the neoadjuvant chemotherapy was also, or treatment or therapy was also demonstrated that there was no difference in the outcome as far as the disease-free survival or overall survival was concerned. So the neoadjuvant chemotherapy was come into practice. However, some patients who have the complete pathological response after neoadjuvant chemotherapy show an improvement in the overall survival compared to those who did not have the complete pathological response. So whenever we take a decision and we try to discuss with the patient the tumor specific characteristics like T and histopathology, ERPR status, HER2 status, all these will play a major role along with the patient's overall health. Patient is fit for surgery or not. Patient preference also. Patient wants surgery first or chemotherapy after a long discussion, or sometimes the hospital setup. Both the strategies has their own advantages and disadvantages. If we perform a upfront surgery, so the advantages are very clear that it's a very, very satisfactory to the patient because the patient has the removal of the tumor in the early stage of the treatment. So they are very satisfied. They are not afraid that tumor is still sitting in their chest or breast. So rapid surgical intervention is very, very psychologically reassuring for the patients. And if we perform surgery first, we get the clear pathological data regarding the stage, which type of cancer, extent, and the ERPR or HER2 status. And some studies prove that if we perform surgery first, the recurrence rate are lower when we do the NACT first. And what are the disadvantages? Obviously, if we do surgery first, and if surgery is obviously more extensive because we have not downstaged the disease. So we compare with NACT and surgery. If we perform the surgery first, we always have to go for a more extensive surgery. And if there are complications after surgery, so the systemic treatment in the form of hormone therapy or chemotherapy are going to be delayed. And we don't know what is the response of adjuvant chemotherapy because till now we have not exposed the patient for adjuvant chemotherapy. So we don't know actually what is the response of the tumor because we have removed the tumor beforehand. So when you talk about the neoadjuvant chemotherapy, what are the advantages? The first and foremost advantages is the shrinkage of the tumor, downstaging of the T stage. So we can perform the breast conservation in most of the patient, and we have to do the minimum surgery for removing the tumor from the breast. And we can also assess the effectiveness of the chemotherapy, because we are giving chemotherapy before surgery, so we can really in vivo test that this tumor is sensitive to this kind of chemotherapy or not. And we can individualize the adjuvant therapy. Suppose if first line chemotherapy is fails, or it is not showing us is good response, so we can switch over to the second line chemotherapies. And the fourth advantage is the micrometastasis, which are not picked up by the PET scan or CT scan or metastatic workup. These micrometastasis or tumor-free cells or tumor-free DNA are circulating in the blood. So when we giving the neoadjuvant chemotherapy or systemic chemotherapy first, we are treating this micrometastasis at early stage and decreasing the chance of distant recurrences or relapse by giving the NACT first. And the fifth advantage is we also downstaging the lymph node in the axilla. So the need for doing the axillary clearance is going to be reduced. We can do the axillary sampling, or we can do the central lymph node biopsy if we downstage the lymph nodes. And what is the disadvantage? Disadvantage is the psychological issue, as I have already discussed, and delay in the surgery. Because after chemotherapy, there should be minimum 21 to 1 month gap, or patient should be now fit for the surgical fitness should be there. And sometimes after chemotherapy, patient surgery get delayed because of this fitness for surgery. Like we have to do the cardio checkup and the echo, and we have to get the surgical fitness. And second is there is a chances of resistance also. If we are giving NACT first, suppose if the tumor is resistant to the first line chemotherapy, the treatment timeline is going to be delayed and the surgery is going to be delayed. So there's a risk of developing a potential resistance. And sometimes if we do give the chemotherapy first, there is a shrinkage of the tumor, maybe in patchy fashion or in a fragmented way. So sometimes it is difficult to assess the surgical staging by removing the tumor, because sometimes the margin positivity or leaving behind some part of the tumor is there after neoadjuvant chemotherapy. And there's a high chances of positive margins after chemotherapy. So the recent data says, I'm quoting just one meta-analysis. So the recent data says that if tumor downsized by NACT, there is a high chances of local recurrence after breast conservation therapy. And for this high chances of positive margins or recurrence, we should do a thorough, careful tumor localization during the intra period, detailed pathological assessment in the form of frozen section biopsy or final histopathology, or there should be an appropriate radiotherapy. So there should be a multidisciplinary team approach when you are performing a surgery. And whatever about the neoadjuvant chemotherapy, endocrine therapy, or target therapy we want to discuss today, or we should go through, the ASCO guidelines has given a beautiful description of the neoadjuvant chemotherapy. So we should go for the ASCO guidelines if you want to study more. So which approach is right for my patient? It depends, as I have already discussed, breast cancer subtypes like highly aggressive tumors like HER2 positive or triple negative breast cancer. So I need NACT first rather than going for surgery. Tumor size and location. If tumor size is more, I want to downstage first. If tumor is at location where I want to downstage, like in the upper and middle quadrant. Nodal status, if nodal burden is high, I want to go for NACT first. And sometimes patient preference. Patient wants that I don't want chemotherapy at this stage because of the weakness and chemotherapy side effects of the chemotherapy. So sometimes we have to consider the patient's preference also. And there are some specific situations where the surgery and the neoadjuvant have a clearly preference over the other. Like in early breast cancer with the small tumors, most of the time we go for the upfront surgery. and patient in whom chemotherapy is not likely to be beneficial or more conservative surgical approach is possible without neoadjuvant chemotherapy, we should go for the upfront surgery. And if tumor is large, triple negative breast cancer, HER2 positive, patient is not fit for surgery at present, so the neoadjuvant chemotherapy should be given the preference. And last slide, last but not least, about the resource limited setting, because we are discussing the resource settings in this particular course. So in India and other the resource limited settings, the training and skill of the surgeon is of paramount importance before in choosing the surgery or the chemotherapy first, because all the surgeons who are operating breast cancer is not trained enough in doing sentinel node biopsy or in oncoplastic techniques. So sometimes they have to modify their treatment and they have to do the surgery first before the NACT. And the second point is the availability of the medical oncologist. Till now, at every center or medical college, medical oncologist is not available. So sometimes getting away the need of the chemotherapy or delaying the need of chemotherapy is compensated by doing the surgery first. So patient is also keen that my surgery should be done first, and then we'll look for the medical oncologist or chemo center where I can get the chemotherapy. The nuclear medicine facility is also not widely available, so the PET scan and the sulfur colloid or radioisotope is not available everywhere. So we have to tailor or modify our technique or this demand according to the availability of the nuclear medicine facility. Same is with the radiotherapy facility. Most of the center do not have the radiotherapy facility also. So if we perform a breast conservative surgery, so we always need a radiotherapy in the same breast. And if we do not have a radiotherapy facility, if tumor is small, so most of the time surgeon or the patient go for the modified radical mastectomy or surgery first, so that this chemotherapy, the need of the radiotherapy can be omitted. And same is true for the histopathology or ISC facility. Most of the primary health center or the low research hospitals where the surgery can be performed, but histopathology or ISC facility is not available. So sometimes we have to modify or tailor our decision according to the histopathology or ISC facility also. And the most important is the financial condition of the patient. If we can omit the radiotherapy, perhaps the financial burden of the patient can be reduced if we omit the radiotherapy. So sometimes for smaller tumors, we go for the surgery first in the form of the mastectomy. And the educational status. In India, most of the patients are not highly qualified. They do present late because of the low awareness and the educational status. So we have the apprehension in our mind. If we perform the chemotherapy first, are they educated enough to come in the follow-up with after every 8th day with the CBC reports? So we do the surgery first and then we plan the chemotherapy after some times. So thank you very much. I tried to cover all the pertinent point. If the audience have any question for discussion, please feel free to ask and discuss.
Yeah. Thank you, Dr. Chitray, sir. That's a wonderful lecture on a friend's surgery versus neoadjuvant chemo. I see a question in the chat box. I read out, if it is a triple positive, but T2N0M0, patient wants mastectomy, can we go for surgery first, then chemotherapy?
So the dictum is we have to discuss the pro and cons with the patient. And in this question, patient is asking for surgery first. So we have to respect the patient's choice. If patient is asking that what are the advantages and disadvantages for both the procedure, we have to explain. But if patient is opting for the surgery first, we have to go for the surgery first. There's no other option.
So I could see the another message is from Dr. Meskerem from Ethiopia. His observation was that like stage 3 patients were being offered upfront surgery where they don't get IHCs for most of the patient. So is it better to stick with neoadjuvant chemo for all stage 3 patients? That was his
So
query.
yes, yes. So if we have a ISC facility beforehand and we can identify that if it is a triple negative or ERPR negative HER2 positive, then we can guide our
Okay. So I think Dr. Chitresh sir, signal from your side is what we couldn't hear you. Meanwhile, uh, I would ask Dr. Raghavan Vidya, she would like to comment. Dr. Raghavan Vidya, please unmute yourself.
Yeah, thank you. This is clearly an example how in Tier 2, Tier 3, we do not use neoadjuvant chemotherapy, though we know the signs that neoadjuvant chemotherapy may be the best in certain situations due to patient factors or due to cost or due to availability or resources we're not able to implement it. And that's why we have such courses, which is clearly an example. Now, we are saying follow the golden rules wherever we can, but then we have to modify according to the local availability and local financial constraint of the patient, because this patient may not be able to come back to you at all if you're not offering her something which she's able to afford and which she's able to have. So that's also important. You don't want this lady going back with a large tumor progressing and not having any treatment. So this is the first thing. Now, the second thing, ideally, we know that HER2 positive neoadjuvant chemotherapy helps in survival. We know triple negative, absolutely beneficial. Then there are always grades of shade. Shade
I got
grade, do
disconnected.
not know where to use neoadjuvant chemotherapy. And I would also be cautious in saying it increases the local recurrence. If you're taking out large amount of tumor, the tumor bed, then the survival rate and the local recurrence is similar, but then will we be able to monitor this patient is the next question.
Yeah. Thank you, Dr. Raghavan Vidya, for that point. That's well noted. And when would you consider neoadjuvant chemo in a hormone receptor positive cases? Then hormone receptor positive, HER2 negative.
You're asking me?
Yeah, yeah.
I had put it in the chat only for locally advanced disease, both in the breast and axilla. Otherwise, they do very well with surgery and get on with the surgery. Don't waste time.
Yeah. So, okay. Dr. Rauf, would you like to give a comment? You can unmute yourself. Thank you, Dr. Vidya Raghavan. Thank you. Dr. Rauf, you can unmute yourself.
Meanwhile, Dr. Steve actually was racing about localizing. Steve, actually in India, in my knowledge, they localize with either simple clips or they use nice, costly clips depending on where they work, before or after or during neoadjuvant chemo. And most of the breast surgeons are well trained in ultrasound. So they localize these tumors using the ultrasound when they do the surgery, and they put wire or whatever they need. I'm sure some of them will be able to share, because he's asking me, do you guys put clips like how we do in the Western world routinely for breast cancer once we biopsy it?
Yeah, so what we do is for patients who have a non-palpable lesion when undergoing a core needle biopsy, we used to place a radio opaque marker, either an ultra clip or in low resource settings, we use a titanium clip, which we have mentioned. So sometimes for patients who are a candidate of breast conservation surgery after a neoadjuvant chemo, either before initiation of neoadjuvant chemo or after assessment, clinical response assessment with 1 or 2 cycles of chemo, we place radio opaque marker in the core of the tumor where the patients are contemplated for a BCS. And for a non-palpable lesion, yes, either at the upfront setting or at the post-neoadjuvant chemo setting, when we are planning for surgery, we localize the residual lesion or the non-palpable lesion with a wire, J wire. So we do that. Yeah. Thank you for that wonderful query. And Dr. Chitresh, your
Yes.
signal went off in between. You would like to add on anything?
Yes, I do agree with you, Dr. Vilsak, because we also follow the same practice. Because if we put the clip in every patient before starting the NSCT, there is a huge burden on the radiology. So we have taken a middle path. We follow in each after each cycle. If there is a chance that tumor can become so small that it is difficult for the palpation, then we put the clip. Otherwise, not. And most of the time titanium clip is suffice, and it is not costly. It is costing less than 100 rupees.
Yes, yes, absolutely. Thank you, Dr. Chitresh, sir.
Can I?
Dr. Rauf, could you unmute yourself?
Yes, yes. Thank you. Thank you
Yeah,
for
yeah.
Dr. Chitresh. Excellent talk. I just wanted to add a couple of points. One was about the benefits of neoadjuvant chemotherapy, especially in HER2 positive disease. Now, we did say that if there's a complete pathological response, it is prognostic. But then there is a lot of importance on if there is residual disease, both in triple negative and HER2 positive disease. If there is residual disease, then the oncologist changes treatment. Suppose they start with Herceptin and pertuzumab. If there is residual disease, they change it to Enhertu. Same way in triple negative disease, if there is not a complete pathological response, CreateX trial says that they could be offered capecitabine in adjuvant setting, which again improves survival. That was one. The other point I wanted to add was in terms of the size. Obviously, in neoadjuvant chemotherapy has got a lot to do with the subtype of breast cancer. In the recent St. Gallen consensus, they were trying to debate on reducing the tumor size to 15. Now, in UK, at the moment, the cutoff is 20 millimeters. Triple negatives, HER2 positive cancers, which are about 2 centimeters, are offered upfront chemotherapy. But then there is a lot of talk going on because of the benefit of changing the adjuvant treatment. So we want to see how the tumor is going to respond to neoadjuvant chemotherapy plus minus anti-HER2 treatment. So they are trying to bring down the cutoff size from 20 millimeters to 15 millimeters. Not yet accepted in UK, but in Europe, they're trying to go down that route.
Yeah, that's a well valid point. Like the prognostication and decision making of adjuvant therapy influenced by the CreateX and Catherine trial for triple negative and HER2 enriched tumors. Yeah, that would give us a prognostication. Absolutely, neoadjuvant chemotherapy would help us to plan decide the adjuvant therapy. And regarding the triple negative tumors, even the recent SABCS December 2024, we have the abstract presented with T1C N0M0. Triple negative, they found that the overall survival is better in neoadjuvant setting. So as you have said, like we are a little influenced by the neoadjuvant chemotherapy in especially in triple negative patients. So thank you for the wonderful lecture, Dr. Chitresh. Now we move on to the next session, breast conservation therapy and mastectomy. That represents the two paradigms in the surgical management of breast cancer. While survival outcome are often equivalent, the decision impacts the quality of life, aesthetics, and the psychosocial well-being. This key lecture will shed light on the evolving criteria and patient-centric approaches guiding this choice. I welcome Dr. Vidya Raghavan for this keynote lecture on breast conservation versus mastectomy decision making. Dr. Vidya Raghavan, she is a honorary secretary in Association of Breast Surgeons UK, and she's a consultant oncoplastic breast surgeon at Royal Wolverhampton Hospital NHS Trust. Dr. Vidya Raghavan, share your slides.
We know mastectomy was radical, started by Halsted many years ago, but now it has moved to breast conservative surgery and less mutilating surgery. The main advantage of breast conservation is preserving the breast better body image, and similar survival outcomes. The limitations include access to radiotherapy. Why preserving the breast? Because it's a desire of women to preserve the organ rather than mutilating. If you look at the national evolution, you can see in 1981, Umberto Veronese adopted the breast conservation surgery, and then it moved to oncoplastic surgery in 1980. In 1890 to 1948, you can see how radical mastectomy has moved on to simple mastectomy and evolution with time. Breast conservative surgery, less versus more. We want to conserve the breast at the same time, remove the cancer with good margins, and at the same time have a good cosmesis. The aim of breast conservation surgery is to remove the cancer with adequate margin. It could be between 1 to 2 millimeter if you're in the UK, or if in the US, it is tumor-free margin at the inked area. You can visualize the wide local excision or lumpectomy using X-rays, including mammogram, to assess the adequacy of excision. Further surgery is required if the margins are positive, which includes re-excision or mastectomy. Routine excision of the skin overlying the tumor is not indicated other than when the skin is involved or is very close to the anterior margin. It's very important to localize the tumor bed using titanium clips, which helps in the delivery of local radiotherapy according to the local protocol. So breast conservative surgery preserves the breast, better cosmesis, equivalent survival in early disease. The disadvantages, it requires radiotherapy, and there can be a small risk of local recurrence, and this is increased when there is no radiotherapy. It's so important that we do not offer a poor cosmetic surgery when we take out huge cancers and preserve the breast. So cosmetic failure is very important to be addressed, and this happens when there's loss in breast volume, choosing a wrong method, and not relocating the nipple areolar complex. This is an example demonstrating the smaller the excision, the better the cosmesis, whereas if the breast volume excise increases, we need some form of technique to replace this, and this could be volume displacement or volume replacement, depending on the level of care and expertise available. We're talking about low resource settings. Hence, level 1 oncoplasty will be more than sufficient in most of the cases following breast conservative surgery to improve the cosmesis. Mastectomy. Mastectomy depends on the patient choice, the risk considerations, the tumor factors, and the cosmesis. Mastectomy is removal of the breast tissue by definition. Advantage includes it eliminates the need for radiotherapy, suitable for multicentric disease, reduces the anxiety of recurrence to the patient. What are the limitations? It can be more invasive, loss of body image, having a major psychological impact, and what are the reconstruction facilities available and the options. Indications for mastectomy usually includes patients with large or multiple tumors in one breast, patients who are not good candidates for radiotherapy, patients with inflammatory breast cancer, those with genetic mutations that increase the risk of breast cancer, and those who had recurrent breast cancer, particularly after previous breast conservative surgery and radiotherapy. Assessment remains the crucial part. Depending on the patient factors, the oncological factors, the technical factors and the expertise available, and the affordability. Looking at the clinical decision factors, the tumor size related to the breast size remains a major component of deciding whether the patient can go for breast conservative surgery or mastectomy. Tumor location and multicentricity is also very important when we're looking for the options. The presence of genetic mutations such as BRCA genes clearly indicate the need for mastectomy to reduce the chance or to decrease the incidence of breast cancer. Previous radiation exposure is again a problem for breast conservative surgery, as a patient cannot be exposed to large amount of radiation and we need to opt for mastectomy. Patient comorbidities would need to be taken into consideration when deciding between the two types of surgery. Patient-centered factors are very important. Looking at the psychological impact, particularly the body image, the fear of recurrence. Cultural beliefs, particularly about femininity and body integrity, is very vital when looking at the options. Reconstruction availability and affordability should also be looked in, which varies from autologous reconstruction to implant-based reconstruction. Personal preference and values is vital in the center of all this decision making. Socioeconomic and contextual factors are very important. In high-income settings, we find that more breast conservative surgeries available due to radiotherapy access. In low-resource settings, we find higher mastectomy rates due to limited resources. Insurance coverage and financial constraint influence the choice. What is the key evidence? Lumpectomy after radiotherapy. Clearly, there is a big difference. And if you have to remember one paper, will be the NSABP06, which clearly shows that wide local excision or lumpectomy with radiotherapy is equivalent to mastectomy. And this is a very important finding, which has changed the concept of breast surgery. So clearly, the randomized trial has shown equivalent long-term survival for early stage disease between mastectomy and breast conservation with radiotherapy. Modern series and meta-analysis continue to support the oncological equivalence for appropriately selected patients. So looking at the Indian context, we know the breast conservation rates vary completely different in India, anywhere between 11 to 34%, and in the older series is much higher. The challenges include late-stage presentation, limited radiotherapy access in some region, cost, logistics, socio-cultural preferences. The surgeon attitude and the patient attitude plays an important role in deciding the type of surgery. Oncoplastic techniques and increasing multidisciplinary care are improving the feasibility of breast conservative surgery in India, which is good news. Looking at the breast conservative surgery uptake in India, it seems to be very low, about 20% compared to the Western countries, which is more than 60%. Looking at the quantified barriers to breast conservative uptake in India, you see the most important is fear of radiotherapy, the adverse effects of radiotherapy, the fear of recurrence, and follow-up and concern by the surgeon. So the surgeon's attitude and the patient attitude influence the type of surgery. The remaining includes the facility availability, the cost, and the perception. This is a paper taken from data, it's a very interesting read. Patient-centered and counseling elements will be important, particularly looking at the survival equivalence for selected early-stage disease and the role of radiotherapy. We have to discuss logistics, include radiotherapy schedule, travel, cost, and support system. Discuss appearance, sensation, sexual and psychosocial impact, and patient values. Use of decision aids, particularly family desires, and document shared decision is important, but the most important is patient-centered care. The global perspectives. The Western countries preferred for breast conservative surgery, whereas if you look at Asia and Africa, mastectomy most commonly preferred due to access. Patient advocacy movements are influencing the choices to some extent now. Shared decision making should be the norm. Patient must be involved in the surgical decision making. Decision aids and counseling are critical, and a multidisciplinary team approach improves outcomes when available. So to conclude, both breast conservative and mastectomy are effective surgical options. The choice will depend on the clinical context, psychosocial, socio-economical, and cultural context. Shared decision making, ensuring optimal patient outcomes, should become the norm. So recommendations for Indian practice includes early detection to increase breast conservative eligibility, to strengthen radiotherapy access using a regional hub and spoke model, hyperfractionated doses for 5 days of radiotherapy versus 15 days will make a big difference. Train surgeons, particularly level 1 oncoplastic techniques, multidisciplinary team when available, and ensure informed patient-centered care to help in decision making. Practice will be a good practice includes good local regional control and lower recurrence rate for the disease. For the surgeon will be low complication and a good cost message. For the patient, it will include good quality of life, better psychosocial well-being, better sexual well-being, and a high satisfaction. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Vidya Raghavan. That's an excellent keynote lecture. Especially you have pointed the importance of shared decision making, and you have highlighted on the socio-economical and psychological well-being of the patients, which usually gets unnoticed or unbalanced when we decide on the surgical planning. That's a wonderful talk. Any questions or any queries we can?
Thank you very much. Thanks for the invite and enjoyed being a part of the group. I'm happy to take any questions, or otherwise you can put it in the chat and we can address it.
Yeah.
It's all gone quiet now.
So, okay. So, I could see a question: how to assess margins during breast conservation surgery?
Okay, a simple method would be to get an X-ray of the specimen. We have Faxitron in UK, in Europe and things. Some centers in the India has got it. If you don't have, send it to the X-ray department, they'll do an X-ray of the specimen, and that'll be a very good idea about the margin assessment. Some centers in India has got frozen section, which I know, and that'll also be a good one. Otherwise, you have to wait for the histopathology.
Yes. So,
And there are new techniques for tumor-free margins, which are coming up, but they're all costly. So we'll have another session on it.
Okay. So, what we used to do for a non-palpable lesion or for microcalcifications where we have done a wire-guided surgical excision, we send the specimen for a specimen mammography. That will also give us a clear picture of how far the margin is from the microcalcifications or from the wire. We place clips on the superior and lateral edges of the specimen so as to assess the margins in a specimen mammography. Of course, not many centers have a frozen section histology. What we do is, in that case, we excise the cavity margins separately if you don't have a frozen section. We excise the tumor, then we excise the cavity margins on all sides. Entire specimen will be sent for the final histopathological examination.
I would probably advise against doing cavity shave routinely. I would say just do excision and specimen mammography. And if the margins are closed, just take those margins, because we have to be very careful of the cosmetic outcome. We don't want to take huge chunks of tissue and leave a huge breast, which is very deformed.
Yes, yes. So especially on the margins which we feel that is closer, we can take that part of the cavity margin shape for a final histopathology. So the another question is, what is better, a poorly done BCS or a well-performed mastectomy in a patient that qualifies for BCS? I think the next talk is on
After
that.
coming to this course, I don't think any of you will do a poor breast cancer surgery. I'm sure
Yes.
your delivery of care will be very good.
Okay. So for any other queries, I think we can ask them to leave it in the chat box. Thank you, Dr. Vidya Raghvan, for the excellent talk. We'll move on to the next session. So it's oncoplastic surgery simplified, techniques feasible in small centers. The oncoplastic surgery that bridges the gap between the oncological safety and aesthetic outcome in breast cancer surgery, the query that has been put forwarded now. So while advanced centers may have access to complex reconstructive techniques, many small centers can also perform a meaningful oncoplastic solutions that improve patient satisfaction without requiring a high-end resources. So in this keynote lecture, we'll focus on practical, simple, and effective oncoplastic techniques that are easy to adapt and safe to implement in small or resource-limited setting. The keynote lecture is by Dr. Sumohan Chatterjee. He's a consultant surgeon at Manchester University, NHS. We can share, yes.
Greetings from Manchester. I hope you're enjoying the day. I'm not going to talk about how oncoplasty evolved in breast. If you remember, it all started with Halsted and radical mastectomy, and this was a standard of care for a long time. Since then, we've moved on, and not only the mastectomy has evolved, so has our ways of reconstruction. However, that doesn't mean that everybody needs a mastectomy or even a reconstruction. Things started to change in 1970 when we started to do less to achieve more. And quadrantectomy, lumpectomy, wide local excision, what we now know as breast conservation surgery, started to come on its own. And the main challenges were not only to treat the cancer, but also to maintain the natural shape of the breast. However, it soon became apparent that we can get bad results, barred big deformity, badly done operations, which resulted in half the breast missing, and especially after radiotherapy, causing a lot of distress to the patient. And why is this? And this is because not only we damage the blood supply when we cut out parts of the breast without thinking what that means, but fibrosis and post-radiotherapy changes makes things worse. Therefore, a badly done wide local excision breast conservation surgery is not in the best interest of anyone. Therefore, this led to what we know as oncoplastic breast surgery. And this all started nearly 30 years ago, where people started thinking about how can we improve the cosmesis. And oncoplasty is a very clever mold of word where you have the Greek word of the cancer and plastic to come together to not only treat the cancer, but also maintain the shape of the breast. And clearly, the goals were simple. The simple were promoting breast conservation surgery, which we now know that is a better way of treating and can get better outcome, but also maintain a shape of the breast without compromising on the risk of local or distant recurrence. And the drivers of change were not only the surgical team, but it mainly came from the patients who wanted better outcome. Therefore, the oncoplastic approach, which is now becoming standard of practice, and is a very, very acceptable thing in low resource settings. If you have access to radiotherapy, this is a better way of treating breast cancer. And therefore, it has multiple advantages. You do not cause body image issues by doing mastectomy, and you can also improve your cancer outcome. We know that mastectomy is linked with 30 to 40% morbidity due to infection, seroma, chronic pain, scar. However, we can achieve much better results and better quality of life by using breast conservation surgery. To me, everybody undergoing breast conservation surgery is suitable for oncoplastic technique. And we come to the levels that is needed depending on how much breast tissue you need to remove to be able to use it in your practice. The surgical challenges are planning of the incision so that you can do it in a way without affecting the change in shape. The nipple areolar complex needs to be in the center of the breast mound, so that is very important. And how do you fill up the gap that has been created by removing the cancer and the margin around it? Therefore, what I would consider for every patient is a discussion with the patient to understand what they need and how do we achieve it depending on where the cancer is in the quadrant of the breast or the size of the cancer versus the size of the breast shape. And this is why meticulous planning is extremely necessary. So it is not the size of the tumor which should make the difference. It should be the excision volume which should determine how you do it. Therefore, less than 20% of the breast volume is easy. More than 20% needs high surgical skills to correct. Tumor locations, the upper outer quadrant, there's a lot of breast tissue to use to mobilize and fill in the gap, therefore is the easiest. Upper inner quadrant, however, is challenging. Also, what we need to know is in very fatty breasts, too much glandular mobilization leads to poor outcome due to fat necrosis. Therefore, it's very important to understand the vascular anatomy of the breast and where these vessels run from. Therefore, how can you keep these vessels to supply the residual tissue that you're going to leave behind? Therefore, the perforators, understanding it is very, very important. And the best time to learn where these perforators are is when you're doing a mastectomy. And you can keep an eye and look out for these. They're pretty constant, and therefore I would encourage everybody to look for the moringa septum when they're doing a mastectomy and lifting it up from the pectoralis major muscle, and also keep looking for the chest wall perforators. We prefer the Crystals line because that is where you get the best outcome, and therefore you need to know which way these tissues planes are. Radial scars are very good for the 9 o'clock and 3 o'clock tumors. The areas which are difficult is anything below the nipple in the lower pole because you can lead to bird beak deformity. It's important to understand the aesthesis of the breast, and this is based on drawings, which was based on a famous painting which is in the Uffizi Gallery in Florence called Venus of Urbino. And these drawings give us a good idea of how to reshape the breast, especially when you're doing bilateral surgery. It's very important to remember the level 1 and level 2 that Krishna Clough from Paris very famously talked about. And again, that 20% mark is where you have to understand. And this is a guesstimate that you have to create in your own mind so that you can understand what the patient needs. For the level 1, it's a simple technique. You have to do dual plane mobilization. You have to plan where your scar is. We prefer to use scars around the areola or at the margins of the breast. And then you have to make sure the nipple areola position is not disturbed by your surgery. The common techniques are glandular remodeling, round block mastopexies, and grissoti flaps. Then we move on to the level 2, where we call the therapeutic malplasty, where we not only reduce the size of the breast to change the position of the nipple, but also reshape the breast. The pedicle for doing this will depend on where you are dealing the cancer with. So the superomedial and the inferior are the two commonest pedicles which are used, but there are multiple pedicles. As you get to know these things better, you will learn to use them. Once you understand how to mark up a wise pattern malplasty, it is quite a good operation to do with very predictable results. So if you're going to reduce the size of the breast much smaller on one side, think you have to do bilateral, otherwise the patient will be lopsided. The V and the L and the J plasties, this is a cheat sheet that we use, and this is a good indicator of how you can use this for various quadrants of the breast, and therefore not only maintain the shape of the breast, but also take the cancer out. As you can see, this lady had quite a large tumor, and we can remove it with healthy margin and reshape the breast. As with any operations, there is possibilities of complication, so you need to warn the patient about it. But the common ones are nipple areola complex, which is quite rare if you can respect the blood supply of the breast. Fat necrosis is more common, and the delayed wound healing in the T-junction, if you're doing a wise pattern scar, is one of the things to look out for. Poor cosmetic outcome, if you do not do it right, especially after radiotherapy, can be a challenge to correct. Therefore, if you're doing this kind of operation, you need to keep your own data, quality assurance, not only about the cosmetic outcome, but also reoperation rates and long-term cancer follow-up. The areas where we find it difficult are patients with high BMI, smoking and diabetes, with other comorbidities, especially anything which affects the blood supply, like connective tissue disorders. How safe it is in younger patients, we're increasingly getting more confident in using it in younger patients who do not have any BRCA gene mutation. When do you do the contralateral symmetrization? In our practice, we do both sides together because that effectively means one operation for the patient. And if you've got two teams to operate at the same time, then you can reduce the operating time as well. There are other things you can do if there are complications or cosmetic defects, for example, like modeling or even using chest wall perforator flaps to fill in defects that you have created inadvertently. There are some guidelines which have been published by the Association of Breast Surgery in the UK, and these are worth reading. Therefore, reminding everyone that the mantra is de-escalation, and breast conservation surgery in a low resource setting is a very good way to de-escalate as long as you've got radiotherapy available. Please make sure that cases are discussed very carefully in your multidisciplinary team meetings with radiology and oncology team to give the patients the best results. I hope you enjoy the rest of the day and improve your practice after attending the day. I look forward to your feedback.
That's a wonderful talk by lecture by Dr. Sumohan Chatterjee. However, he's not connected. We can discuss any questions. Yeah, Dr. Raghavan.
Look, I'm happy to take any questions if you have for Sumon's talk, because
Yeah.
the most important take-home message is level 1 oncoplasty at most places is sufficient to restore defects of the breast. And level 2 and level 3 are more complicated, associated with more problems. So you got to be well trained before you take it up.
Yes. So I request that delegates to put forward their queries in the chat box so that we can discuss it here. It's basically for all the delegates who have participated, who are enthusiastically attending the meeting today. Could you please put your queries in the chat box so that you can achieve the full benefit out of this course?
Yes, I think this talk was wonderful after Dr. Raghavan's talk on BCS versus mastectomy. Kind of this completes a full circle. And as you rightly said, that level 1 oncoplasty is something that which should be learned by all surgeons who want to practice breast surgery, in my honest opinion. And I have messages in my like our in our delegates group and personal messages also from multiple delegates how to master level 1 oncoplastic breast surgery. So Raghavan, Vidya ma'am, Sanjeet sir has also joined. Please chip in so that we can give clear message to our delegates.
Yeah, hi Sanjay, how are you? I was listening from the start events. I was joined from 3:30 p.m. It's a very nice talk from everyone.
Thank you, sir. So kindly, like we definitely have your video, and Dr. Regis has joined, and we have his videos also on oncoplasty. But how to master, how to proceed with learning oncoplastic breast surgery?
So I think it's we need to think from the planning. So it's not about surgery alone. So what I will stress that you do proper clinical examination, see the breast ptosis, breast density, read the mammography well, and then go for the planning. So planning is very important. What you are trying to do, discuss with the patient as presented by Dr. Vidya, that it should be a mutual discussion and you finally decide the procedure with the multiple options you have. Learning oncoplastic breast surgery, I will say that it is a stepwise approach. So you need to start somewhere. So you first attend some workshop. So look, the general surgery training in India, we see very few center doing oncoplastic breast surgery. But once you are doing in surgical oncology, I feel that now there are good center in the India who are doing good oncoplastic breast surgery work. So you see the planning, you see the tumor board, attend some workshop both nationally and internationally. Now we have ample of option of workshop around the world. So even in the India, we have ample of the workshop, the oncoplasty workshop. Same for the UK, North America, everywhere. And then do observe some technique with some masters if you have the time, and then start the procedures. It generally take 1 year to 1.5 years after your general surgery to tuned up to going for the oncoplastic breast surgery. I will not say that you start by seeing 1 or 2 YouTube video because there's a lot of planning involved in the oncoplastic breast surgery. So think for 1.5 years the learning pathway before starting oncoplastic breast surgery.
Rightly
That's
said that.
my submission.
Rightly said. Starting is the first point to overcome the challenge. Once we have started, then automatically we will get into this practice of this oncoplasty technique. So,
Gaurav, hello, I see you. Do you
Yeah.
have any input? You want to give anything from Indian perspective? Thank you, Sanjay. This is very useful. I think Gaurav is muted.
Yes, so yes, I fully agree with your observation that now we have many institutes within India which are doing oncoplastic breast surgery, and anyone who is interested should definitely visit these centers. And there are short observerships and fellowships also at SGPGI Lucknow, TMC Mumbai, TMC Kolkata, and other centers also. Like we also had observer from Nepal recently. So I think there are multiple options available now where you can see oncoplastic breast surgery, and then from there you can start it.
Shall we move on to the next session?
Yes.
Okay.
So Vishwak, I have sent my recorded videos.
Acha,
They
okay.
played, so it's okay for me because I have just put in 15 minutes what I can do for the level 1 oncoplasty.
Okay, sir. Okay, sir. So nice of you. So we'll move on to the next session. Today's master video session is on breast conservation surgery, the first master video session. We'll walk us through the key steps, the technical nuances, and decision making involved in performing the safe and effective breast conservation surgery by Dr. Sanjit Agarwal. Dr. Sanjit Agarwal is a senior consultant in breast oncosurgery in Tata Medical Center, Kolkata. And Dr. Sanjit, sir, yes, please.
Bridge team for giving me the opportunity to present, starting from Professor William Halstead for thinking of surgical treatment of the breast cancer, to Sir Bernard Fisher and Umberto Veronesi for introducing the conservative management of the breast surgery to us 25 years back. So we all know that our knowledge was in 2005, that modified radical mastectomy or mastectomy with breast conservation surgery with good randomized controlled trials, and the meta-analysis of the randomized controlled trial, that breast conservation surgery has comparable local control and overall survival was equal. But in 2015, we had many population-based study, and it was first presented by the Professor Sisling that mastectomy is even breast conservation surgery is even better than mastectomy for the overall survival, and it was adjusted for the tumor stage and the nodal disease. Similarly, multiple studies was population-based is published between 2015 to 2021 that breast conservation surgery, even for the adjustment of the stage and the hormonal receptor status, it has better overall survival in the population-based study. So at present, the breast conservation surgery is nowhere inferior to the mastectomy when we think for the local control and overall survival. But in the lower middle income country or even in the developed country, we need to think that are we giving good cosmetic outcome by doing breast conservation surgery? So we all know if you do simple BCS, we end up after radiotherapy with a deformed breast. So we say that we have done breast conservation surgery, but ultimate outcome is not good. So what is oncoplasty? We are combining oncology surgery with some plastic surgery principle and try to give better cosmetic outcome. What are the type of the oncoplasty surgery? Level 1 oncoplasty, level 2 oncoplasty, depending upon the volume loss, what volume you are removing from the breast, and a concept of either displacing the breast tissue to cover the breast conservation or wide local excision defect, or finding some tissue from the local area, from the lateral chest wall, or from the abdominal wall, or from the dorsum of the body or the backside flaps, to replace the volume by placing some tissue from outside of the breast. That's not as a replacement. So if you have done very good breast conservation surgery, but if it is a visible scar, generally the patient liking is not too much because they can see the scar in the breast. So try to place your scar either in the axillary region, inframammary region, and periareolar region. And what we follow in a simple breast conservation surgery now is the basic 6 step of the oncoplastic breast surgery to cover the defect with displacement technique. Level 1 oncoplastic surgery, the concept is two, either glandular mobilization, it means you are mobilizing the breast gland, not the skin, or the dermoglandular mobilization, where you are mobilizing the breast in block, including the skin and the glandular tissue. So this is glandular mobilization, where we are undermining the skin and mobilizing the breast to cover the defect. That's known as glandular mobilization or dual plane mobilization. And these are the procedure which is based on the glandular mobilization. The dermoglandular mobilization is mobilizing. You have removed the tumor with the 1 centimeter around breast tissue, and you are mobilizing the whole dermal plus glandular tissue, whole breast tissue rotation to cover the defect. That's known as dermoglandular mobilization. And these are the oncoplastic procedure which is based on the dermoglandular concept. So what are the basic 6 steps? So suppose there is a tumor here in the right breast. At 3 o'clock periphery of the breast, you decide to remove the tumor with the periareolar incision. Then you undermine the skin or mobilize the skin, the mastectomy plane, that is known as the skin undermining. Third is the NAC undermining. If you feel that NAC will be deviated towards your volume of the defect, after closure, try to undermine the skin. That's known as NAC undermining. Then identify and control the tumor by the hand or the suture. Then remove the tumor plus 1 centimeter tissue known as wide local excision. And then if required, mobilize the breast tissue at the level of the pec major. That's known as dual plane mobilization. So first step we have mobilized with the skin, and second at the level of pec fossa, and close the defect with the glandular mobilization known as glandular approximation. So this is the small video of glandular mobilization and how we do is simple level 1 oncoplastic breast surgery for a smaller tumor. This is left breast, and we are having 1 into 1 centimeter tumor at 11 o'clock. So we are trying to explain the basic 6th step of the oncoplastic breast surgery. So first, you need to define the tumor. So this is the tumor here. We have decided that we'll do with the round block. And these blue lines are to explain that how much skin undermining we need to do. 8 o'clock to 12 o'clock. Skin undermining will excite this tumor with the boundary, and then we'll close like this in a radial closure. Sentinel was done by the separate small axillary incision. Defining incision. So in this patient, here is the tumor. And we have decided that we will take round block. So these are the 2 rounds, one first round and second is the second round. And we'll do the oncoplastic surgery with the round block incision. So we have done the round block deepitalization. Tumor is here, 1 into 1 centimeter in the left breast at 11 o'clock. And we'll undermine the skin from 8 to 12 o'clock. And this is very important step as second step in any oncoplastic, simple level 1 oncoplastic breast surgery. The important thing here is to go in the mastectomy plane. Incision deepen to raise the flap. So staying in mastectomy plane is very important here. So you can see here I am just in the mastectomy plane. And if you go deep here in the breast parenchyma and losing mastectomy plane, what will happen that you will lose the vascularity of the breast pedicle, what you are defining to close. And second thing is that your pedicle will be not thick enough to close the defect well. And this is under mastectomy plane. Here it's up to 8 o'clock and here is up to 12 o'clock. Fourth step is the NAC undermining, and it's not always required. If the tumor is in the periphery, you can leave the NAC undermining. But in this patient, tumor was very close to the NAC.
So if you will not do NAC undermining, NAC will be pulled towards the defect you close. So if the tumor is very close to NAC or in 3 centimeter circle of the NAC, you should do this step to avoid NAC deviation. And in this NAC undermining, you need to be careful for the two things. First thing, you should not be close to the tumor, feel the tumor multiple times. And second thing, the NAC should not be very thin. So you need to balance between the tumor margin and the NAC vascularity in the NAC undermining. Tumor localization is very important. In this patient, it was 1 into 1 centimeter vaguely palpable tumor. So we are doing USG localization. Tumor localization can be done by the 3 ways. One is clinical palpation, if you can feel the tumor. Second is in this patient, you are doing USG localization. You can see the tumor there very nicely, you can see here. So we will see that we have seen this tumor by the USG localization. And third way is hook wire localization. So both USG guidance and the hook wire localization for impalpable lesion. And if it is palpable lesion, you can do by the clinical palpation. We're doing wide local excision now after USG localization. So here important thing is to go from the anterior to posterior, complete in-block excision with a margin.
Wide local excision was done in a stepwise manner. First on the inferior side, then the superior side, then the medial side to deliver the tumor on the surface.
So now we have detached the breast tissue from the inferior surface, superior surface, and the medial side. And now we are going towards NAC. I can vaguely feel the tumor and we'll do the side towards the NAC and excising is completely. So we have marked the specimen for the specimen mammography. So this is short superior, long lateral, and loop anterior. If you are sending for a specimen mammography, mark with the clip because in the specimen mammography you will see the clip, not the threads. So what we follow that short superior single clip, long lateral double clip, and loop anterior triple clip. So these are the two pillars. This is superior pillar. Because we have done the skin undermining well beyond the tumor. This was 1 centimeter tumor at 11 o'clock, and we have gone superiorly towards 12 o'clock and inferiorly towards 8 o'clock. So this is superior pillar. You can see it's a good full thickness pillar, and this is inferior pillar. And you'll see the breast on this side also that there is a skin puckering or not. If there is a skin puckering, you go beyond that and release it. Now you need to know the concept of biplanar mobilization. What is biplanar mobilization? We have done the skin undermining in the mastectomy plane. In this, it's coming well with the single plane mobilization, means mobilization of the breast pillar from the skin. But if it is not coming well, then you can do dual plane mobilization. What is dual plane mobilization? Mobilization from the pec fossa. So here you can see the pec fossa here, the pectoralis muscle and pec fossa. So what we will do here, we will mobilize the breast pillar from the pec fossa also. Here you don't bridge the pec fossa because supply the chest wall perforator come in from the pec fossa. So don't go towards the muscle. And this is the way you can do biplanar mobilization, means mobilization from the pectoralis major muscle. So not breaching pec fossa here, and this will give you the additional mobility for the closing both breast pillar for the defect. So in here you can see it's nicely closing here. So these two pillars are coming together. Washing of the cavity is also important to remove all the fat cells from there. Because if there will be a loose fat cell, it will create a fat necrosis. And there is a chance of the infection and the bad cosmetic outcome. So washing of the cavity, multiple wash and clear it is very important. Now we'll apply the clip in the cavity. The clip has two roles. This is posterior surface on the pec major muscle. This is inferior margin. So we have mobilized the pillar and we are keeping it in the center. So from superior to inferior, and in this whole cavity, so we'll put in the center of the pillar. So this is inferior cavity margin. This is medial side. This is superior side. This is on the left breast for the orientation. Clip has two roles. One is it will guide radiotherapist to push this cavity. And second, if any margin is coming as positive, then you can identify that clip on that side of the pillar. Once you have opened the cavity and do the cavity shape from that specific, if inferior margin is coming as positive after 2 weeks of the pathology report, you go inside, try to identify this clip and take a shape from this area. The clip has two roles. One is surgical role and second is the helping radiotherapy colleague for giving boost of the cavity. This is specimen mammography. This is superior single clip. This is lateral, and this is the lesion here. So this is the one view, and this is the next view with where now we are closing in two layers. The first is inside. This is with vital 20. So one in inferior pillar, one in superior pillar, and closing it first inner layer and then outer layer in the breast parenchyma. And after that, we will take one outside. You can take multiple sutures to close the defect as per the need. Envelope defect.
So to complex informed decision making, understand breast size, ptosis, tumor location, breast density, and citipated vidocal defect. And if you are starting it, start medical photography, read about it. Take boost of the long term.
Can I present
Try
my
to
slide?
maintain the data of patient reported outcome and aesthetic outcome.
Dr. Sanjay.
Right.
Yeah, I think I will present the last 1 minute part if you will allow me, because there was some audio video discoordination in the last part.
Okay. Okay.
Okay. Give me 1 minute time. You can see my desktop.
Yes.
One second.
This is left breast.
So this is the application of the clip here. If I am applying clip on all the side. So this is inferior side. This is inferior clip, and placing it in of that side of the pillar or of that. So this is inferior surface, and then we are on the medial surface, single clips. These are Liga clips. This is superior surface. So you need to apply clip at least on the 5 surface, and if your radiotherapist want, you can apply it on the anterior surface also. So there is a difference of the difference of the applying of the clip. Some center apply 1 clip, some center apply 2 clip. So you need to discuss with your radiologist colleague and discuss what they want for the clip applications. It's a mutual discussion with the radiotherapist. So once you have done this clipping, then you can close it in the 2 layer. So this is a specimen mammography. As I said, short superior single clip, long lateral double clip, and the loop anterior. This is the tumor here. So it's all around margin free. And there was some speculation on one side you can see, and this is the another view of the specimen mammography. Now how to close? So we close, you can close in 1 layer or 2 layer depending upon the thickness of the breast. So generally better to close in the 2 layer, put one suture inside to close the breast pillar and one suture in the outer surface. So you can use multiple suture or one suture depending upon the amount of the defect you are closing. So first you close the inner surface and then you close the outer surface with, I am using here Vicryl 20. Depending upon your choice, you can use any absorbable suture here for closing the pillars. So this is the outer surface closure for the breast pillar closure after wide local excision. This is complete closure. You can see the whole breast was opposed to each other after the tumor excision. Second is the skin undermining. So skin undermining is generally in the mastectomy plane. Then NAC undermining if required. Then the biplanar mobilization if required. And the final closure of the breast pillar to close it and approximate it well so that the after radiotherapy there will be no dimpling there. It's a well covered wide local excision and the defect. This will resymmetrize the round block again with multiple skin suture with the wagon wheel here, and this will look finally like this after the closure. So to conclude, I will say again what I said. It's a complex informed decision making. Understand breast size, ptosis, tumor location, anticipated wide local excision defect. See the mammography well, because radiological help is very much required for doing any simple, even simple breast conservation surgery, both mammography and ultrasonography at least. And in a very high dense breast, if MRI facility or contrast enhanced mammography facility is available, better to use that to see that you are not missing any multifocal or multicentric lesion. And if you are starting a thing to add these three things, read about medical photography, see the post-op short and long-term outcome, take the pictures both pre and post-op and post-radiotherapy, at least for 3 or 4 sequence of the picture, and take the patient-reported outcome and aesthetic outcome data to measure what you are doing after 5 years. Thank you very much, and I'm happy to answer any question.
Thank you. Thank you, Dr. Sanjit, sir. That was an excellent video demonstration of oncoplasty technique. It's interesting to see nearly 40% of participants responded that the biggest challenge in attending this course was they couldn't get a coffee. That's what they have responded. Yet I must say that this master video session was so excellently presented that it stimulated our central nervous system just like a strong cup of coffee would. Truly an engaging and enlightening experience that had kept us fully awake and focused. I could see a few questions in the chat box. What is the role of suction or any other drain after oncoplasty? Do you charge the suction drain?
So the level 1 oncoplasty, you don't need any drain as such. For the axilla, if you are doing sentinel again, the drain is not required. But if you have done axillary clearance, then generally drain is required. For the level 1 oncoplasty, generally drain is not required. For the Liga clip size, I will say that I use 200 micron, but you can use different size. Some people use even the stapler, what we use for the cavity marking to reduce the cost. So all depends upon what your radiotherapist wants. So discuss with radiotherapist before venturing into the breast conservation surgery, because radiotherapist preferences are also very variable. One radiologist will say that, radiotherapist will say that you apply one clip on one surface. One radiotherapist will say that you apply 2 clip on one surface. One will say that you apply only on the posterior side, not on the wall. So it all depends upon the radiotherapy planning, how you are applying clip. What we generally use, as I said, 5 clip on the each of the surface, superior, inferior, lateral, medial, and the posterior surface.
Yeah, This another question from Dr. Stephen Kai. He did uploaded about the excellent video and presentation. Any reason you chose the round block versus periareolar incision in this patient?
Because there was a small extension there towards the superior surface. So I was not sure how much superior I need to go in this patient. So I choose the round block. And second, tumor was close to the periareola and it's extending towards superior surface. So you can do with the periareolar also in this. But what I felt that you have seen that in the 1 centimeter tumor superiorly, I have removed a lot. So I was anticipating a wide local defect. And I was anticipating that I may have to go more superiorly, so I have chosen round block. But you can do the simply with the periareolar incision also in this case, if you are not anticipating any type of speculation going towards the, or if you're not anticipating wide volume defect with the periareolar incision.
Okay. Okay. So, any other comments or queries?
Someone asked about Liga clip size. Have
Yeah,
we?
that Sir has mentioned LT200. The next question, if we are using Weiss pattern for therapeutic mammoplasty, do we put clips then also or no need of putting clip?
So clip is always required if you're doing breast conservation surgery. So there is no question of not applying Liga clip or any clip what you are using for the breast conservation surgery. But where to apply clip in therapeutic mammoplasty is a challenge. So what I do, what I say that if you're doing therapeutic mammoplasty, excise the tumor, apply the clip first in the tumor cavity and then do the reduction. So you are sure that you have applied in a proper cavity. If you feel that one of the cavity is continuous with the Weiss pattern excision, so then you will not apply. Suppose there is a tumor margin, inferior margin is continuous to your reduction pattern. So you have excise at least 10 to 12 centimeter inferior margin on that side. So then you apply on the muscle surface rather on the 10 centimeter away the inferior surface or any surface which is continuum with the cavity and the reduction plan. So clip is required. Apply it just up to tumor excision. And if there's a continuum of cavity towards that reduction plan, apply it in the muscle rather than the 10 centimeter away cavity that radiotherapy will radiate more.
I just want to add a comment, like you can invite your radiation oncologist also sometimes. They also would be interested in seeing how we are placing the clips, just to understand how to give boost to those areas. Sometimes they do come if we invite them to the OT.
So what we have done, Dr. Viswak, now what we are doing, we are making a pictorial representation of our reduction plan and we send it to the radiotherapist so they can see. They can come for one or two cases, but generally the therapeutic mammoplasty is so much different and you really do different for the different patient. But ultimately, I personally feel that the planning is really challenging for the radiotherapy and therapeutic mammoplasty. And if there is a theory that if the margin is too much, so suppose in therapeutic mammoplasty you have done with a tumor localized in the Weiss pattern zone and the margin all around is more than 3 centimeter or 4 centimeter, we really need to think as a group with the surgeon radiotherapy that do we need to boost this cavity if the margin is so huge?
Yes, yes. Like is Dr. Gautami, she wanted to have this explanation again, why periareolar versus round block.
Yeah, so look, the periareolar or round block selection of the incision depends upon multiple factor. Suppose tumor is very, I think Dr. He has put the right question, Dr. Steven, that why I have chosen round block incision, because this could have been done by the periareolar incision. So if the tumor is close to NAC, so if your tumor is very close to NAC, you can do simple periareolar incision and a small tumor you can excise. But you feel that if the tumor is 3 to 4 centimeter away from nipple areola complex, then you need a wider exposure. So probably perioral incision going and undermining the skin all around with a small perioral incision will be difficult. Second choice, suppose you have a patient and very small tumor, even close to NAC, but NAC is also very small. Sometimes we see a 3 centimeter NAC. So keeping a wider area of exposure, we take a round block incision. So perialveolar is generally, in a nutshell, if I want to say, the tumor should be close to NOC, where you can use perialveolar, a small tumor. But if tumor is away from NAC 3 to 4 centimeter, round block will give you a better access to the skin undermining all around and do the wide local excision defect.
So thank you, sir. Thank you so much. Thank you so much for that excellent video demonstration. It's always a pleasure to witness your expertise in person as well as in offline as well. Thank you so much, sir.
Thank you very much. Thank you very much.
Thank you. So we would move on to the next session. Dr. Pooja Ramakant, Associate Professor in Endocrine and Breast Surgery, King George Medical University. She will moderate the further sessions.
Thank you, Dr. Vishwat. And it was very nice to see Dr. Sanjeet Agarwal's video, very nicely demonstrated. So with that flow, we move ahead for the next master video, which is by Dr. Regis Polinelli. So we look forward to see the next interesting video.
Hello, for me, it's a pleasure to be here with you. Do you see me? Yes?
Yeah, we can hear you and see you
Okay.
well.
Nice. Congratulations for this initiative. I think it's very important for those interested in oncoplastic surgery. I think it's something very important nowadays for the new generations. I don't envision breast surgery without oncoplastic surgery anymore. Many patients don't need oncoplastic surgery, but for those who need to prevent some deformities, it's very important and it should be available, and it's very often in our practice. And I'd like to show some videos about oncoplastic surgery. Dr. Sanjay asked me to display something very basic, something very useful, the techniques that I use more often. And so I will share my screen. Just a minute. Okay. And so we will talk about oncoplastic surgery. There are many options for oncoplastic surgery. There are volume displacement techniques, volume replacement techniques. Both are useful. The most common techniques are volume displacement techniques, usually mammoplasties, could be the round block technique as shown before, but more often here we use the superior pedicle, the inferior pedicle, and if it's difficult to raise the nipple, we can change the superior pedicle into a supermedial pedicle. I think these are the most useful techniques. But also, if we have a small small breast, patients without pitosis, it's very often we use volume replacement techniques with the LICAP, ICAP, MICAP, and LTAP, and other perforated flaps, and other types of technique that is not my topic here, but there are many options. I think this should be available, and any breast surgeon should learn how to deliver these techniques when needed for the patients. Why is so important to try a conservative treatment and to prevent deformities and to avoid mastectomy? Mastectomy with breast reconstructions is always an option. We can always do a mastectomy, but we published last year, 2 years ago, our experience with patients that finished all the stages of breast reconstruction, and patients that did conservative treatment with oncoplastic surgery were much more satisfied than those that underwent complete breast reconstruction with implants or myocutaneous flaps. Also, there are much less complications in conservative treatment with oncoplasty. The local recurrence was similar, and patients needed less surgeries to complete reconstruction with oncoplastic surgery than with total breast reconstruction. And so there are many advantages, and it should be available for the patients. In this publication, if we see here, the most common techniques were mammoplasties. We applied this in 53% of the cases, and in 21% of the cases it was glandular rotations. I think I'll show just these three techniques. They are the most important, the most useful techniques, and there are many other options. We'll have maybe some opportunities in the future to show other techniques, but I think these are the most important. And it was curious because when I was learning oncoplastic surgery, my masters taught me that if I only knew mammoplasty, I could solve more than 95% of the cases. But here it was 53%. There are other options. And also in the case of mammoplasties, I used the geometric compensation in 12% of the cases. It's a different kind of mammoplasty to extreme oncoplasty, locally advanced tumors. And I always used it very often in 12% of the mammoplasties. Well, the glandular rotation, I think it's the most basic technique. If you only do a basic quadrantectomy, you have this kind of deformity, radiated scar, some asymmetry in size, and the nipple will be displaced toward the scar. And a good option is to do a parallel incision or a parallel incision and to do a skin undermining and do the resection in a vertical way. It's like the round block technique that was shown before, but we don't need to do the 360 degrees incision unless we need to move the nipple up to raise the nipple. Usually I don't do this. I only do the parallel or the parallel incision, and I think it's better than doing a round block technique. I only use round block technique when I need to raise the nipple. And here is one example. We do a parallel incision, and the glandular incision is vertical, as you see here in this picture. And here the result after other cases. It's good. We can also use the vertical incision as if it's in the lower poles. And there are some curiosities to some ways that is better to do the reshaping of the breast. If you place the stitches very superficial, we don't have any layer in the deep area, and with time there will be some sinking in this area and some deformity. If you place the stitches very deep, there will be some bulking in this area. But if you place the stitches not too superficial and not too deep, it will close very well, and we won't have to detach to undermine a lot the breast. There's other tips also. If you this displace the lower poles, they have less tissue, and the deformities are more apparent. And there's the perforator vessels. We can damage the perforator vessels, and so we have some deformities. It's better to do the undermining just in the upper poles and not in the lower poles. And it's very important to avoid large underminings, because if you undermine too much, you damage the vascularization, and with time we have this kind of deformity. This is the patient below is a patient 2 months after this glandular rotation. And here, at 2 years after radiotherapy, and you see that the breast was retracted because of fat necrosis, and she had an asymmetry, and it's important to limit undermining. If the patient has a fatty breast or if it's an old lady, it's better to do a radiated scar. Don't undermine anything, and then just displace the areola 2-3 centimeter to the contrary side of the scar. Here, an example of this pirareolar incision. We very often use immediate fat grafting. It's popular in Brazil. We do liposuction, and we can inject fat in the glandular flaps if we need to have more volume. I'll show you how we do it. I think it's one of the most common techniques here. This patient had two tumors in the left breast. It was a multifocal tumor. She underwent neoadjuvant chemotherapy. I was planning a perioral incision, and here the two tumors will be resecting in a radiated way. Here the donor sites. We use the abdomen, the axillary glands, and the sentinel node biopsy, the Klein tumescent solution for the liposuction, and then the radio-guided localization. We placed 2 clips before chemotherapy and the vertical glandular resection. We marked the specimen for the pathologist, and there were some multiple foci of tumors. Here, how we process the fat. We used a sieve to have it more concentrated and place it in 10 cc syringes. And then we do a retrograde injection of the fat in the glandular flaps. Just small quantities of fat because it's a graft, and if you inject too much fat, you must have some fat necrosis, and so it must be very gentle and very small quantities in a large area. So we replace the volume. We replace twice the volume we removed, and then place metal clips for boost orientation. I think it's mandatory in all breast conserving surgery, as radio oncologists asked us. We do the perpendicular correction in the mid. You see that we don't need to undermine too much. If you place the nipple, the stitches in the intermediate deep depth, we don't have a retraction. And here you see that we have the same, although we did a large resection, we had the same volume at the end. And so it's a very common. If it's a small tumor, we don't need to do lipofilling. But if it's a large resection, a good way to replace volume is with lipofilling. I think it's some of the most basic and useful techniques. And the other techniques, the most common techniques are the superior pedicle if you have a tumor in the lower poles, and an inferior pedicle if the tumor is in the upper poles. And round block we only use for a small breast without pitosis, and mainly when I need to rise a little bit the nipple, because if you don't need to rise the nipple, usually through the pirareolar incision, it's possible to reach the tumor without many difficulty. I'll show a case of superior pedicle. I'll just go a little further just to show the markings. Well, we'll mark the midline and then the inframammary fold. The markings are very important. And also I mark the middle of the breast. We divide the breast in two halves. And then we place my finger in the inframemory fold, and I see point A. And then I mark a referential line from point A, perpendicular to point A, and then the Bisenberger maneuver. I gently rotate the breast to one side and the other, and draw a line from point A to this referential line, inferior referential line. And I mark 9 centimeters from point A. It will be points B and C to the horizontal line. I repeat the rotation of the breast, the Bisenberger maneuver, to mark this horizontal arms. Now in checking symmetry, if the one breast is larger than the other, the triangle will be larger than the other. It's very important to be gentle in these maneuvers because you don't want to remove too much skin. If you remove too much skin, you have tension. There will be a higher risk of complications. These are the skin incisions. We deepithelialize the Schwarzman maneuver, deepithelialize the superior pedicle, and then we remove the lower poles. If we have a tumor in the lower poles, you can remove everything here. Of course, it's for large breasts and ptotic breasts. And then I bevel the glandular resection under the retroareolar area, and we do a wedge, a very narrow wedge under the areola. This is important to have space in the upper poles to raise the nipple. And if you also have a tumor in this area, you can remove the tumor, also with a superior pedicle. And the superior pedicle here in Brazil is a superior, medial, and lateral. We don't cut anything around the nipple. And we do this 2 or 3 stitches in the breast pillars to increase projection, to have a more beautiful and projected breast. We close the angles of the mammoplasties, and then we estimate again the sagging skin. At the end, I want to have perfectly adjusted skin, but without tension. That is our aim here. We depithelialize, close the pillars. And here's the T-junction point. I do a deep superficial, 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 deep stitch. And then I mark the vertical pillar 6 centimeters from the inframemory fold. And the areola border, the upper areola border, 2 centimeters above point A. And depithelialize this area. And then we do some cardinal and ordinal stitches to have a perfectly round areola. And then we do the contralateral mammoplasty. It is the same technique, check symmetry. And here the result 2 months after surgery. And so it's a very useful technique. Patients here in Brazil are very satisfied, very happy when she can do a mammoplasty. I know that in India, some patients don't want to touch the other breast, and it's more important to have a good symmetry than have a beautiful breast on one side and a different breast in the other side. And so you should apply these techniques only if you do a bilateral the symmetrization, because otherwise we will have asymmetric breasts, and it's not the aim of oncoplastic surgery. And the other technique, very often, I think it's more often included than the superior pedicle, is the inferior pedicle, because most tumors are in the upper poles, and so it's good to have an access to the upper poles. I'll show an example. In this case, I used, it was a small tumor, but the patient had large breasts. She wanted a breast reduction, and she had some pitosis. She wanted to correct pitosis. And it was a luminal tumor, great ptosis, small axillary accessory glands. We also correct this these accessory glands with liposuction. And in this case, I placed radioactive iodine seeds to mark the lesion. Here, the inframemory fold, the middle of the breast, as I showed before, point A with my finger in the inframemory fold. I check symmetry. It's important not to place this point A too high, because if the nipple is too high, it will be difficult to correct the nipple, and it can appears in a bath suit. The Bisenberger maneuver, we gently rotate the breast from one side and the other. 2 centimeters above point A is the areola border. And here I'm doing a pre-marked areola because I have the tumor in the upper pole, and so I will draw the areola and remove this area. I think it will be easier. Usually I do pre-marked areola, post-marked areola, but in this case I prefer the post-marked to have a better access to the tumor. And then the areola marker. Now I'm drawing the areola, the new areola, following the marks. And then I'm drawing the inferior pedicle. The inferior pedicle should be at least 6 centimeters in the base. Its base width should be at least 6 centimeters, but it could be more than this. In this case, I left 8 centimeters. Now I'm doing an incision to do the radial guided excision. And here we place some stitches for the pathologist. We do frozen section in this case to see if margins are clear. I use the same incision to reach the nipple and to take the two sentinel nodes. They were negative. And then I'm doing the symmetrization. Why I wait for the frozen section? Doing the inferior pedicle. The inferior pedicle, it's important to bevel in its base to preserve better the vascularization. Base with, as I said, at least 6 centimeters. We're doing the breast reduction. We can reduct. We're also doing the axillary accessory breast liposuction. It's important to place some stitches in the base of the inferior pedicle. We attach it to the thoracic wall. It's Dr. Liacir Ribeiro's maneuver to avoid pseudoptosis. One of the problems with inferior pedicle is pseudoptosis. If we do these stitches, we prevent ptosis. The pedicle won't wait in the lower poles anymore. If we retract, if there is some retraction in the inframemory fold, we can release it to have a perfectly round inframemory crease. We close the angles. We close the pillars, approximate the pillars to have an increased projection, and then we check the sagging skin to avoid tension. In this case, we didn't need to correct, but sometimes yes. And then when I have the pathologist report, the margins are free. I'm doing a Percy string to approximate the tissues to use the intrabeam for the immediate radiotherapy. In this case, we scheduled a partial radiotherapy, the inferior pedicle, and then we can do after radiotherapy, we can do the breast reduction as in the other side. I'm reducing a little more the tumor, in the area of the tumor, doing a wider incision to have a better symmetry, and then the subdermal intradermal stitches. And here the result 2 months after surgery. And so we don't have accessory axillary glands anymore, and no ptosis, and very good symmetry. And that's the beautiful of the inferior pedicle, have a good access to the upper poles. And very important is to avoid doing this kind of technique after radiotherapy because radiated tissues have a poor vascularization. We have some research showing that if we try to do this kind of techniques after radiotherapy, there is a much more higher rate of complications and poor aesthetic results. And so it's important to try to do this from the beginning, to talk to the patients and to organize everything before radiotherapy. And patients should have access to these techniques. Not all patients, many patients don't need this kind of technique, but for in case that we envision some kind of deformities, it's important to prevent it. It's better to prevent than to try to correct them. Just to promote, we organize hands-on and online course. There are attendees from many countries. It's 11 months. We operate together over 100 patients, and it has immediate simultaneous translations into English, Portuguese, and Spanish, and so it must be interesting for some of you. We also organize some cadaver labs. And I would like to invite you to get to know oncoplastic.com. It's a free website. I created this in the beginning of the pandemic to help alumni and other colleagues interested in oncoplastic surgeries. There are hundreds of oncoplastic videos there, and it's all free. There are also some classes, and I hope you enjoy, and I hope there are many breast surgeons trained in oncoplastic surgeries to offer the patients these beautiful surgeries, and I think it's very important for the patients.
Thank you, Dr. Regis, for this beautiful presentation and for highlighting the importance of symmetrization. And a lot of claps have come from the audience side, so that's a good point that everybody enjoyed your talk. And there are a few questions for you in the chat box. Please answer them. So with this, we move ahead for the next speaker. So still the claps are coming. That's good. So after seeing the oncoplastic breast surgery, we move towards the enduring role of a good mastectomy, still a standard of care for the right patient. We invite Dr. Rishikesh Parmeshwar to give this talk. So that is also a relevant talk in today's era. Thank you. Thank you, Dr. Regis.
Thank you. I will answer the questions in the chat box.
Sure, sure. Thank you.
Good evening, everyone. Can you hear me?
Yes, we can hear you, sir, very well.
All right.
And
Okay. Thanks for inviting Dr. Sanjay. It's a beautiful and very meaningful initiative, and I hope that it continues in future. I think it's quite relevant. So let me just share my can you see my presentation?
Yes, we see it.
All right. Okay. Okay, so I'm going to talk about the role of mastectomy. And we have heard so many presentations emphasizing breast conserving surgery. So I have a disclaimer that my presentation is in no way a message of preference of mastectomy over breast conserving surgery. It's just finding a role in different setting and different circumstances, and how do we apply those principles. So we have heard so many talks about equivalence of breast conserving surgery when combined with radiotherapy. And we have plenty of data. I mean, these two studies mentioned NSABP 06 proved beyond any doubt that breast conserving surgery with radiotherapy is equivalent in terms of overall survival. But then the recent Swedish study, and that has also been mentioned by Sanjit and others, that there is some evidence that the overall survival with breast conserving surgery combined with radiotherapy actually has a better survival compared to mastectomy. And it's quite obvious that it is, it has lower surgical morbidity, quicker recovery, and all the other benefits. So the initial breast conserving surgery outcomes had very little aesthetic considerations. And because of the fact that more and more breast conserving surgery were being done, there were attempts to avoid mastectomy. And it is quite important that anyone who wants to do breast surgery or thinking of doing breast surgery must know these three, landmark, contributions. So one paper by Krishna Clough defining level 1 and level 2 oncoplastic techniques in around 2010. Everyone should have that. It's such a useful, and that's the reference below. And then once you are more, we are confident with level 1 oncoplastic procedures, then therapeutic mammoplasty and the technique described by Douglas and Mr. Macaulay, the Nottingham group, is also very useful paper to read. So these are all techniques in evolution, and that led to decline in mastectomy rate by half in the UK in the past 20 years. The mastectomy rate used to be 50 to 60%. And we are now extending the indications of breast conserving surgery, central tumors, Paget's disease. There are no more current indications. And there's some evidence that, we can remove larger tumors by means of therapeutic mammoplasty, and they are oncologically safe. So what are the contraindications of breast conserving surgery in current situation? I think there is a general consensus that a very high tumor to breast volume ratio, where you can't use neoadjuvant chemotherapy, then it's reasonable to offer mastectomy because that we can't compromise oncological safety in preference to just doing breast conserving surgery. And then we all know inflammatory breast cancer, there is no evidence of safety of any breast conserving surgery attempts. And there is very little debate that it shouldn't be offered to those who have contraindication to radiotherapy, whether that's as a result of previous radiotherapy with cancer treatment or radiotherapy for other reasons, or maybe some disease, particularly some collagen diseases where you can't give radiotherapy, and certain gene mutation where risk of second malignancy is high with radiotherapy. Extensive DCIS is not, by definition, anything more than 40 millimeters would be considered as extensive DCIS, but that's not absolute contraindication. It used to be. But we can do breast conserving surgery, but it is a relative contraindication depending upon breast size. And obviously you have BRCA gene mutation. Although, there is still a debate whether doing mastectomy offers any definite survival benefit once the diagnosis has been made. So the contentious areas where people apply breast conserving surgery, and that's where I try to emphasize that, do we have enough evidence to at least, make attempts to do breast conserving surgery in locally advanced breast cancer and in multicentric disease, for example, multiple wide local excision. It might make sense, for example, if you have 2 grade 1 5 millimeter cancer screen detected in 2 different quadrants, then it seems an overtreatment to do mastectomy. But if you have 3, 4 areas of high-grade disease, would you do multiple wide local excision? So it has to be a well thought through decision, not compromising patients' safety in terms of oncological outcome. And we must be cognizant that the mastectomy rate varies, and we can't apply rules from one country to other because there's so much of variation. If you think about different countries have different presentation stage. And even within the countries, there will be variations. Some remote areas in developed countries might not have the same access to different services as some of the cities. And if you take example of UK where I work, and the whole population of UK is about 70 million. That's less than 1/3 of one state of India. And there is one health system in the UK, which is NHS, and there is no cost implication to the patient. But even today, the mastectomy rate varies. And that could be anything between 25 to 50%. Having said that, there are very few outliers where the mastectomy rates goes above 40%. But the national mastectomy rate in the UK is about 30%. So it's not that it's a problem of developing country or where there's problem of access to service. The difference exists everywhere. And as we discussed earlier, these are the reasons why the rates vary. And we must think of access to radiotherapy. And we remember, 10, 15 years ago, we still used to have discussion, patients coming from very remote area, they will choose to have mastectomy because they couldn't afford or they couldn't manage to go to the regional radiotherapy centers. The two points written there in the red, the cultural and the wrongly held beliefs are extremely challenging, and that's where we should focus. And that's where we come in. Even in India, I think that is a big challenge. And I'm sure all of you are trying very hard to get the message across, health education, health campaigns for patients to understand that breast conserving surgery is safe because patients come with their own story. They know who in their friends, relatives had certain treatment and what the outcomes were. And surgery, the surgical expertise is important, but the surgical dogma shouldn't have a place to say that, I think mastectomy is better. It shouldn't be the case. There is plenty of evidence that we should do breast conserving surgery where it is safe and applicable. So I think there are a lot of reasons, and we should think of our own circumstances, and we need to address all of those to reduce mastectomy rate. And the two fundamental pillars of breast conserving surgery is the availability of the radiotherapy and clear margins. And we should ask, can we give timely radiotherapy? Is it available? Is the patient going to be compliant? Is there any problem of cost affordability? And if the answer is no, then one should question, is breast conserving surgery safe in those given circumstances? And then same goes for operative consideration. If there's very large tumor and then you don't think you can get a safe margin and yet maintain the aesthetics of the breast, then we shouldn't just do breast conserving surgery for the sake of doing breast conserving surgery. It should have a good outcome. And we've seen how different techniques can be employed in getting good results. And it has been repeated a few times that, it's not always good for patient. A badly performed, a bad choice of breast conserving surgery with complex mammoplasty can lead to horrible outcomes. And, fatty breast, comorbidities, smoking, diabetes, and all should be considered. And if there are questions marked around these factors, then, we need to question, is breast conserving safe in the given circumstances? And of course, then we have to think of, other factors. And it seems a bit conservative, but I think as doctors, as professionals, we have to think critically. Breast conserving surgery and radiotherapy data goes back to 25, 30 years. That's not the case with oncoplastic, complex oncoplastic breast surgery. And certainly not in the case of what we call extreme oncoplasty. Extreme oncoplasty should be, in my opinion, be reserved for those who have done plenty and then have the experience to make that complex decision where it can be applied. But otherwise, it should not be something to just try. And there are challenges of margin assessment, and some of the delegates did ask these questions. So those are real problems. And if you're doing it, you should have a system where you can communicate, orientate the specimen properly, mark the margins in a way that you could go back and take out the correct margin if there's any positive margin. And think of the complexity and some of the problems patients can get, such as fat necrosis. Nipple necrosis is very rare. It has to be something really something gone wrong for nipple necrosis to happen, but can happen. Asymmetry. If you're doing therapeutic mammoplasty, we have to agree that the other side will need doing something at some stage. Whether you do that at the same time or later on, there are pros and cons and then arguments both for and against. And as I mentioned, a badly performed oncoplastic breast surgery can be worse than a well-performed mastectomy. So all these factors need to be truly considered. And in summary, I would say that breast conservation is a gold standard. And my talk was in no way to give a message that mastectomy should be taken as an easy approach. We should challenge, does this patient require a mastectomy? Ask that question every time. What is the justification of doing mastectomy? Neoadjuvant chemotherapy should be considered in almost all triple-negative breast cancers and HER2-positive cancers because the excellent PAT-CR rate, and you can get away with doing simple level 1 oncoplastic surgery in fairly large tumors post-neoadjuvant. And if you're thinking of extending boundaries of breast conserving surgery, one should have the experience and decision-making process in place so that you can make it in a safe way and not compromise oncological as well as surgical outcomes. And breast conserving surgery is in no way a defeat. As I mentioned, 30% of patients, even in the UK, and mastectomy rate in many of the developed countries can be fairly high because of personal preference of the patient, which mustn't be ignored, because at the end of the day, it is a shared decision making. But mastectomy certainly is the right choice in the right clinical setting. Thank you very much. I hope I kept to my time.
Yes, thank you so much, Dr. Rishikesh. That was very nicely demonstrated. You gave good examples from the evidences about the mastectomy and highlighted the justification for doing it. We agree that it is not for promoting mastectomy, but we should know which armamentarium to use when whatever is needed. So what are your views on role of prophylactic mastectomy? Are patients asking for that, or that has come down in UK? How is it?
Interestingly, the incidence of and the request of contralateral prophylactic mastectomy is on the rise, and there more and more patients are coming. But as a policy, as the guideline, we do not offer that. We discourage patients because there's a very good Cochrane review on contralateral prophylactic mastectomy, and there's no benefit, certainly no survival benefit for these patients. And if someone insists on account of family history, I mean, it's different if you have a proven gene aberration, then this is a simple decision. But in absence of a proven genetic mutation, we do not offer. And if someone insists and we think that it is affecting patients' mental health, for example, or for example, quality of life, a very large breast unilateral mastectomy, we of course will try to encourage them to have reconstruction or reduction instead of mastectomy. But sometimes we do make that decision. But the process is that they need to go through a psychological assessment and have that decision supported by a level 4 clinical psychologist. And once that has been done, then they can have it. But it is something we face on a routine basis. But as a guideline, we don't encourage and we don't recommend it.
Sure, thank you. Well noted. So with this, we thank you for your excellent talk and we move ahead. From now the breast, we move towards the axillary management. So I invite Professor Gaurav Agarwal, sir, Professor and HOD Endocrine Surgery Department at SCPGI for the key lecture on evolution of sentinel node biopsy with methylene blue and fluorescent green dye.
Yeah. Good evening, everyone. Am I audible?
Yes, sir. Good evening, sir.
Yes. So good to be connected with this set of friends. And thank you, Sanjay, for this initiative and for involving me with this. I wish to share this presentation. Is my slide visible to you?
So yes, sir. Now it's visible. Yeah.
Great. So I had initially hoped to be speaking after some bit of discussion on axillary management, which would have kind of prepared the audience for this talk. However, I can very well introduce some bit of axillary management to the audience as well as we go along. The talk I'm asked to do is on low-cost practical or pragmatic sentinel lymph node biopsy protocols in breast cancer that have been developed and perfected at SCPGI over last 2.5 decades. So, as many of you would know, that we were the first institute in the country to start sentinel lymph node biopsies for breast cancer patients, followed soon by other colleagues from other institutions in the country. But we did play a role in establishing the role of sentinel lymph node biopsy in breast cancer patient at a time when majority in the country believed that these kind of so-called optional procedures have no role or no place in our country. Our program of sentinel lymph node biopsy, though led by the Department of Endocrine and Breast Surgery, could take off or could materialize essentially because of some key collaborations that we could garner with departments of nuclear medicine, pathology, and radiotherapy, radiation oncology, etc. So it is entirely the credit of this whole team that we have been able to achieve what we have. So before I start with discussing the sentinel lymph node biopsy, this is something all of us are aware. Our countries looks at a wide spectrum of breast cancer patients, from the so-called good patients who have early breast cancers not screen detected, the bad patients with locally advanced, and the ugly ones which have fungated or even metastatic cancers. So the stage and the biology of the diseases vary so widely that one size cannot fit all. Our scenario is certainly a disparate spectrum. While locally advanced cancers continue to be a problem for us, yet many patients are now being diagnosed in early stages too. Many of our patients are quite well informed. Of course, there are numerous others who are totally ignorant. But there is no dearth of information today and skills. Patients expect, and doctors or physicians and surgeons want to deliver the world-class treatment. However, such world-class treatment comes at a cost, and this cost is not readily uh, uh, it cannot be met readily by the society. So there is a need for innovation. Firstly, to promote awareness and early diagnosis. and to promote access to high quality diagnostic and treatment strategy for Indian patients without incurring the high cost that usually such contemporary treatment strategies come at. While we have to innovate to bring upon or bring in low cost innovations, we have the responsibility of validating the applicability of such innovations to Indian patients, both with early stage as well as locally advanced breast cancers. So one of our initiative, which started in 2001, or about 2.5 decades ago, was to create this SGPGI breast cell program, which besides conducting numerous awareness and early diagnostic initiatives, also took upon itself to bring in innovative, newer diagnostic and treatment paradigms to our patients and coordinate various breast health initiatives and training initiatives in our institute. So in the year 2000, after two decades, this SGPGI breast cell program conducted its 2000th public awareness event. These all such events which range from very small to large ones, either online or in person. But indeed, a lot of them have been conducted, including a TED talk given on breast cancer awareness by me. Our SGPGI breast cell program has concentrated its attention or focused our efforts on creating awareness to bring in a culture of early diagnosis, which we believe can save lives in breasts. And such events or such initiatives, coupled with other initiatives across the country, both by government and non-governmental organizations, are bringing in earlier stage diagnosis. Now, in recent years, more than 50% of the patients that we treat have early stage cancers, and that is certainly a very welcome change. So, to list some of the initiatives which we have undertaken at SGPGI, these include awareness and early diagnosis, creation and implementation of cost-effective yet robust management protocols for breast cancer, low-cost radiopaque markers usage for aiding post-neoadjuvant chemotherapy breast conservation, use of intraoperative aids to implement a single-step oncologically complete breast conservation surgery, such as intraoperative frozen section or imprint cytology, and low-cost specimen radiography. And then the one which I am supposed to talk about today at length, which is evolution of low-cost lymph node biopsies using in-house prepared low-cost blue dye and radiopharmaceutical, and later using fluorescein-guided sentinel lymph node biopsies, again implementing it as a single-stage surgery or single-step surgery by using intraoperative aids. So let me now discuss a little bit more details about this low-cost sentinel lymph node biopsy. The need for this, developing the sentinel lymph node biopsy, a low-cost sentinel lymph node biopsy, started with a thought of challenging the dogma to provide a frugal yet robust, cost-effective, pragmatic alternative for various therapeutic strategies that our patients require. Besides innovating them and initiating them, we felt the urgent need to provide scientific proof of validity of these, both in terms of safety of these strategies as well as efficacy or non-inferiority compared to the gold standard. And at the same time, these had to be cost effective and cost saving to be relevant to our society or to our needs. And this feasibility study of use of low cost radiopaque markers to mark the tumors either at margin or at the core, undertaken long ago, was one such frugal innovation where we used silver wire loaded onto a lumbar puncture needle to mark either the margins or the core of a tumor which helped us achieve safe post-neoadjuvant chemotherapy breast conservation surgery. And this resulted in routine use of low-cost markers in our patients, and this resulted in low-cost, safe, effective, and complete post-neoadjuvant systemic treatment breast conservation, especially in patients with complete or good response to neoadjuvant chemotherapy. We have recently moved on from the usual intraoperative specimen mammography, which is difficult to perform and relatively more expensive, to use of a 5 milliampere radiography machine for this purpose. And we have found that majority of our needs for intraoperative specimen assessment with radiography can be met by this lower cost specimen radiograph rather than using the mammogram. So now, as far as the low-cost sentinel lymph node biopsy is concerned, just to introduce to the postgraduates who are connected, that sentinel lymph node biopsy is the current gold standard for determining the nodal status of a patient who has clinically node negative axilla at the time of surgery. These may be patients with early breast cancer who are undergoing primary surgery and have no palpable or enlarged nodes, or those who have received neoadjuvant systemic treatment, and then following that they have a node negative axilla. Why we do sentinel lymph nodes and not the staging axillary lymph node dissection, which used to be the norm 2 decades ago, is because sentinel lymph node biopsies have much lesser morbidity compared to ALND. And over the years, numerous studies beyond doubt have proven the fact that sentinel lymph node biopsies do not compromise on cancer cure or control of the cancer. Is the survival in patients who have been managed with sentinel lymph node biopsies no inferior compared to ALND patients. The premise on which this procedure works on is the systematic, stepwise lymphatic drainage of any body organ, and it's the axilla or the hold on. I'm sorry, that's my dog barking here. Sorry. So it's in the axillary drainage of the breast is also equally systematic. It drains into the axillary nodes, and the first set of axillary nodes into which the lymph from the breast goes, or from a tumor-bearing area of the breast goes, is what we call as the sentinel lymph nodes. So here at SGPGI, we started the sentinel lymph node biopsy program sometime in late 1999 with some borrowed material. We were gifted some patent violet dye by friends working abroad, and then we could get on loan from a equipment manufacturer a gamma probe and use technetium sulfur colloid, which was uh, was being used by our nuclear medicine colleagues for, say, like liver studies. And then we moved on to preparing our own in-house blue dyes. We procured patent violet, which was of analytical grade, which were reconstituted, filtered, ampulated, and sterilized, and then later moved to methylene blue, again buying the analytical grade methylene blue and preparing it for use in human studies. The reason for all this was because the usual stuff that we required, the radiopharmaceutical and the blue dye, were not available in the country. And if we had to import them, it would come at a huge cost. And these were major hurdles in offering sentinel lymph node biopsy back then in 99, 2000, 2001. And that led us to uh, doing in-house production of these blue dye and the technetium antimony colloid, which we thought were low cost alternatives to the radiopharmaceutical and blue dye, which are commercially available with very great difficulty. So we started using these dyes using standard protocols, including appropriate injection site and timing of injections, and using the gamma probe to assist plotting the roadmap to central lymph nodes. Of course, one can argue gamma probes are not low cost. These come at a significant cost. So our nuclear medicine colleagues also prepared a prototype of 1 lakh rupee gamma probe, handheld gamma probe. Sadly, that never uh, could graduate into commercial production, but we did have a plan to reduce the cost of this gamma probe too. So we were well and truly performing sentinel lymph node biopsy using blue dye and radiopharmaceutical to try and find the blue and hot nodes using low cost material. The cost of our radiopharmaceutical and the blue dye were dismally low, or rather, uh, uh, so the cost of technetium and antimony colloid that our radiopharmacy produced was less than rupees 100 per patient, compared to $40 at that time. At the conversion rate that was prevalent at that time, it was approximately 1,800 rupees per patient for technetium sulfur colloid. And the methylene blue that we created or reconstituted on our own, again, used to cost less than 10 rupees per patient, compared to one vial of lymphozurin, which was the cost available, but the availability of this dye was very problematic. We could not procure that readily. The cost at that time was $31 per vial, or about 1,500 rupees per patient. Uh, of course, then later on, we started looking at trying to avoid all radiopharmaceutical altogether, so that we can do away with the need for a gamma probe and the radiopharmaceutical. Also, we were very careful, very aware of the fact that our patients are very unlikely to accept a two-step or two-stage operation. Patients who would be found to be having a metastatic sentinel lymph node would require a reoperation, and that itself will be a big no-no for our patients. And it was impossible to convince our patients for such a operation. So we utilized intraoperative aids, intraoperative frozen section histology or imprint cytology of the sentinel lymph nodes. And in case the sentinel lymph nodes were reported to be metastatic, in the same sitting, we would then complete the axillary dissection, so that we don't have to bring back the patients to the operating room at another date and increase the cost of their treatment. Besides, we also use the low-cost consumables, drapes, and sterile gloves rather than custom-made consumables for sterile covering of the gamma probe and other material. So, as I said earlier, we had a mandate not just to innovate, but also to provide scientific proof of both safety and efficacy of these low-cost innovations. So we started our first sentinel lymph node validation study in the year 2001. And this was 120 patients, T1 to T3 N0M0 patients, or clinically node negative axilla patients, where we used a combination of low-cost dyes which were produced in-house using subareolar injection of technetium antimony colloid and performing preoperative lymphoscintigraphy and methylene blue. Uh, the sentinel lymph node identification rate and the false negative rate. These are the two critical outcome measures that we have to use or have to look at while evaluating any sentinel lymph node biopsy procedure. And this can be done only in validation studies. And the meaning of validation study is that you would do a sentinel lymph node biopsy. However, irrespective of the histology of the sentinel node, whether it is metastatic or not, you would complete the axillary dissection and then compare the histology of the sentinel node that you have removed with that of the whole of the axillary lymph node dissection specimen. So there would be some patients where you would fail to detect the sentinel lymph node. So that's a technical measure or technical outcome measure of the quality of sentinel lymph node identification procedure. In our first validation study, the overall sentinel lymph node identification rate using the combination of methylene blue and technetium antimony colloid was a high 96%. And majority of our patients had a level 1 or central group sentinel lymph node biopsy, and the mean number of nodes identified was 1.5. Comparing the histology of the sentinel lymph node with the whole of the axillary lymph node dissection, we found a false negative rate of 2.1% and a true negative rate of 56.2%. So the meaning of this information is, the implications of this information is that had we used this histology of sentinel lymph node biopsy as a guide to was choosing axillary lymph node dissection in patients who have substantial lymph node metastasis, then 2.1% of patients who had a metastatic disease would have escaped an axillary lymph node dissection, meaning they would be undertreated. However, 56.2% of our patients who did not have any metastasis, based on the negative or non-metastatic sentinel lymph node biopsy, would have been spared of the unnecessary axillary lymph node dissection, and so the potential morbidity that it brings along with itself. So this in our study did have a very low morbidity of just minor allergic reaction in 4 out of 80 patients, and no major anaphylactoid reactions or in any adverse outcomes. Now here I must also mention that while evaluating the quality or validity of sentinel lymph node biopsy for breast cancer, the yardsticks which have been taken by majority of the prospective trials starting from Almanac was a minimum 90% of sentinel lymph node identification rate and no more than 10% false negative rate, which means that we have to identify at least 90% of the sentinel lymph nodes or sentinel lymph nodes in at least 90% of all patients being evaluated, and no more than 10% of all patients who have metastatic disease can escape identification based on the sentinel lymph node biopsy. So this was our first validation study, which kind of established the utility or validity of our technique with sentinel lymph node biopsy. This was published in Journal Japan Surgical Society in 2005. But then we still had this problem of, we used to be asked this question that we are using in-house produced radiopharmaceutical and not the radiopharmaceutical which is usually advocated for such a procedure. What is the scientific validity of that? So we then conducted a prospective randomized trial comparing the sentinel lymph node biopsy performance using our in-house produced low-cost radiopharmaceutical, that is technetium antimony colloid, with the sentinel lymph node biopsy performance using the commercially available radiopharmaceutical, that was sulfur colloid. And this was a prospective trial where we wanted to compare the sentinel lymph node identification rate, the false negative rate, and the cost, and compare them between these two groups. So this was 1:1 randomized trial using the patients who had T1 or T2 and 0 early breast cancers. They were randomized into group 1, which received technetium antimony colloid guided sentinel lymph node biopsy, and the group 2 equal numbers where we used technetium sulfur colloid for doing the sentinel lymph node biopsy. And methylene blue was used in all the patients, and validation sentinel lymph node biopsy was performed. And then the results of this trial was that the sentinel lymph node identification rates were very similar between the two groups, irrespective whether the low-cost in-house produced technetium antimony colloid was used or the commercial technetium sulfur colloid was used. We were able to identify sentinel lymph nodes in more than 90% for sure. In the sensitivity of the disease or the sensitivity of sentinel lymph node biopsy was equally high in the two groups, and the false negative rates were very comparable. just 6.3% in the study group and 7.7% in the control group or the sulfur colloid group. So this study, this prospective control trial could establish the fact that accuracy of sentinel lymph node biopsy in early breast cancer patients undergoing primary surgery was similar or comparable using the low-cost in-house produced technetium antimony colloid as with the commercial technetium sulfur colloid as radiopharmaceutical. So, and while these were equally effective, the cost was 15 times more economical using the in-house produced low-cost radiopharmaceutical. For early breast cancer patients, we were reasonably well confident that our techniques are working, and I'm aware that based on such results and of course other trials, other studies, many centers in the country started performing sentinel lymph node biopsies, but the question still remained, how do we take care of the axilla in patients which constitute a large proportion of our patients, the patients who had large operable cancers or locally advanced cancers, many of which would be treated after neoadjuvant systemic treatment. By the way, until that time, when we started these studies in 2005 or so, there were not many studies or trials focusing on post-NSCT sentinel lymph node biopsy. So we initially performed a study in large and locally advanced breast cancer patients who underwent primary surgery, but then later also performed a comparative validation study in patients with stage 3 cancers, locally advanced cancers, who underwent primary surgical sentinel lymph node biopsy versus post-NSCT sentinel lymph node biopsy. And to introduce this issue to the vast majority of our postgraduates, there are certain specific concerns with the post-neoadjuvant systemic treatment sentinel lymph node biopsy compared to primary sentinel lymph node biopsy, where the patient undergoes sentinel lymph node biopsy and later on undergoes rest of the treatment. In patients who have undergone neoadjuvant chemotherapy, there is a possibility that efferent and afferent lymphatics of the sentinel lymph nodes may get fibrosed and blocked, and so they may be skip metastasis, and the sentinel lymph node biopsy may not be as robust, as accurate as it is in the primary setting. So to take care of or to evaluate this situation, we conducted this study, and the reason why we had to do this was because a large proportion of our patients continue to be diagnosed in locally advanced or large operable stage. Quite a few of these patients, after having undergone an SCT, they achieve axillary PCR, or roughly about 1/3 at least, who are N1, they can be converted to N0, YC-N0. So these patients are candidates for sentinel lymph node biopsy rather than axillary dissection. And so these can be, at least a certain proportion of these patients can be spared of axillary dissection. So in this prospective non-randomized study, where we enrolled 120 patients who were YC-N0 at the time of surgery, we excluded patients with multifocal, inflammatory, ulcerated, and these kind of cancers. And these patients were put into one of the two groups. Group 1 patients underwent primary surgery, which means they were CN0 to begin with. And group 2 patients, 70 in number, were T3 or T4, who were either N0 and N1 as index, but they were YC-N0 or clinically node negative at the time of surgery. And then we compared the sentinel lymph node identification rate and false negative rate between the two groups. So overall, in our two groups, the sentinel lymph node identification rate in patients who were undergoing primary surgery was acceptable at 94%. However, in patients who were undergoing post-NACT sentinel lymph node biopsy, the identification rate was very dismal at 82%. However, when we looked at the subgroups in patients who had T3 disease to begin with, Irrespective whether they underwent primary or post-NSCT sentinel lymph node biopsy, their sentinel lymph node identification rates were quite good at 93% plus. However, patients who had T4B disease or N2A or worse nodal status, their sentinel lymph node identification rates were dismally low, certainly not up to 90%. Similarly, in context in regard to the sentinel lymph node false negative rates, in group 1, primary sentinel lymph node biopsy group, the false negative rate was lesser than 10%. But within this group again, it was the T3 disease which had low sentinel lymph node false negative rates. T4 disease, patients with locally advanced cancers, the false negative rate was quite high. In group 2, which means patients who had neoadjuvant chemotherapy, the false negative rates were higher than 10%, unacceptably high. And however, it was the T3 disease, which were N0 and N1 at the beginning of, or as the index stage, they were having low sentinel lymph node false negative rates, but patients with locally advanced cancers, T4 or N2A or worse nodal status, they had dismally high, unacceptably high false negative rates. So from this study, what we could conclude that in patients who we also looked at what were the predictors of our unidentified sentinel lymph nodes or false negative sentinel lymph nodes in these patients. And we could conclude that sentinel lymph node identification rates are unacceptably low and false negative rates are unacceptably high in patients undergoing sentinel lymph node biopsy when the patients have T4B or locally advanced cancers or N2A or worse nodal status. Post-NSCT sentinel lymph node biopsy is as accurate as primary sentinel lymph node biopsy in patients with T1 to T3 and N0 to N1 disease, but not similar in patients with locally advanced cancers. So this was a study which established the validity of use of low-cost sentinel lymph node biopsy techniques in locally advanced or post-NSCT cancer patients. However, we still were cognizant of the fact that use of radiopharmaceutical and gamma probe is not going to be easy for majority of Indian centers. Nuclear medicine facilities are not there for majority of places. And even for us, logistically, it is complex to have a patient in the hospital a day prior to surgery for having their radiopharmaceutical injection. And so we looked at other options which did not require radiopharmaceuticals and nuclear medicine facilities. So we looked at
What if, sir, can you please summarize?
Sure. So this is the last
Thank
part.
you.
Then as the last effort to reduce the cost and improve validity of these sentinel lymph node biopsies, we looked at possibility of use of fluorescein as a fluorescent dye, which is a low cost, and using this with a blue LED light rather than ICG and near infrared or ICG detection systems, which are extremely expensive. And in this validation study on 65 early breast cancer patient who were clinically node negative, we could achieve very good sentinel lymph node identification rate using fluorescein alone or in combination with methylene blue. We compared these sentinel lymph node identification rate and false negative rates of this low-cost fluorescein-guided sentinel lymph node biopsy with radiopharmaceutical guided sentinel lymph node biopsy, and we found they were quite comparable. So the fluorescent guided sentinel lymph node identification rate of more than 90% and false negative rate of less than 10% using fluorescein plus methylene blue were comparable to that of radiopharmaceutical plus methylene blue. And we think that fluorescein can well replace the radiopharmaceutical for sentinel lymph node biopsy in combination with methylene blue dye without the need for radioactivity and at a fraction of the cost. So the impact of these low-cost sentinel lymph node innovations has been that we are now able to routinely apply sentinel lymph node biopsy in early breast cancer patients and in selected locally advanced large operable or locally advanced breast cancer patients undergoing post-NSCT surgery. And this is not just us at SGPGI, but I am aware that numerous other centers, many who have either trained with us or even otherwise, are using similar low-cost alternatives to offer sentinel lymph node biopsy to their patients, and we are able to offer a single stage complete axillary surgery for majority of our patients without adding substantial cost. So I must acknowledge my colleagues, faculty, and residents at various times who have worked on these projects or these trials. My colleagues in nuclear medicine, specifically Professor Sanjay Gambhir and late Dr. Shivatkar, who was a nuclear pharmacist who produced these low-cost radiopharmaceutical pathology colleagues and radiation oncology colleagues who have helped us evolve these low-cost but practical and robust or accurate sentinel lymph node strategies for offering to our patients. Thank you very much. If there's time, I'm happy to take questions.
Thank you, Gaurav sir, for showing us the journey of evolution and innovations for low-cost in-house dye, and that has generated few questions which are in the chat box. I shall be grateful if you answer them in the chat box.
Certainly, yeah.
Thank you, sir. So with this background, we move ahead with the master video, which is by Dr. M.J. Paul sir, who's professor in endocrine surgery department at CMC Vellore. So after this, knowing about sentinel node biopsy, we shall be seeing the technique with methylene blue dye alone.
Okay, hello, Pooja, can you hear me now?
Yes, sir.
And you can see me as well, okay.
Yes, sir.
Okay, the screen is visible? Is it?
Yes, sir. Clear.
Okay, and okay, thank you very much, Sanjay and team, for organizing this very useful session. I hope a lot of people are learning from it. Yeah, sorry, I was expecting Goons to come in now, sir. I was a little unprepared. So my topic is basically the use of methylene blue dye alone in central lymph node biopsy in early breast cancer. Safe, simple, and cost-effective procedure in resource-constrained settings. And as has been alluded to and has been developed over time, we had isosulfan blue, methylene blue, carbon nanoparticles, then ICG, the colloids, the radioactive substances, and now MagTrace as well is being used. So there's a lot of options. But when we are in resource constrained settings, we need to look specifically at the logistics, the costs, and the efficacy. And this is what is unique about methylene blue is it's easy to use. It's probably the least expensive of all the items. It has a very good safety profile, and it's available in most places. I did see I think our Ethiopian colleagues are not getting it in Ethiopia, so we'll have to find out how we can help them there. So we went through the almost a similar process that Dr. Gaurav had mentioned. Initially started with isosulfan blue, but then import and cost was a factor, and adverse reactions as well. We've had one anaphylaxis with that. Then we looked at radiocolloid because we have a nuclear medicine department, but again, logistics and cost increased the cost quite a bit. So we got the idea, why don't we just use methylene blue as a single technique? It had been described, but was not widely used. If we look at the cost factor, isosulfan is about 9,000 for a while compared to methylene. You can get it it was 80. Now I think about 150 is the lowest price. Whereas if we use ICG, again, it's around 2,500 per patient, including the equipment. And
Please do the full screen. It's not full screen.
okay.
Sure. Yeah, no.
Okay. So there's a general apprehension when I speak to doctors about using methylene blue alone, and this is the reason. There has been recorded events of tattooing and necrosis. And when we looked at the literature of the reports, what we can see is that this is because it was not used in the correct way. You can see here there's a very large volume of dye that has been injected into the dermis, which is what causes this problem. And it's very simple to avoid this. And I must say, in the last 15 to 17 years that we've been using it, we've not had any necrosis. So when we looked at the reports, you can see this one said 3 to 5 cc was injected intradermally and deep parenchyma. So that is definitely too large a volume to be used for methylene blue. This is another report which said that we experienced 2 skin necrosis, and they had mentioned that they were also using 3 to 5 ml. And then we decided to lower the dose to 2 cc, and then we did not have any necrosis thereafter. And in fact, initially we were using about 1 to 2 ml, and over time we've actually reduced that now to a very low quantity of only between zero point 0.1 to 0.3, and it works quite effectively. So I'll share that in the video. We had a publication already in the first 250 odd cases, but now we recently did a review of the entire data set from 2011 to 22, and that's 762 patients. And we found an identification rate of 96.03. So the harvest rate, the positivity rate was 28, and we had to go on to low level sampling in 31 cases. So that one important point for all training surgeons is whenever you use a sentinel node technique, whatever technique you use, there will be the odd case where you will not be able to identify. So you have to have low level sampling as a backup procedure. These are the Indian publications on central node, and you can see from isosulfan blue and a combination of methylene blue and technetium. And the last 2 studies are methylene blue only, including ours showing 96 and 100. So the identification rate really is not a problem. And in a way, my thought is if you've got one highway or some roads leading up to the node, then whatever car or vehicle you use, you're you're going to either get there or something is going to block you. So we'll look at the details during the video. So the mean follow-up, we've had some chronic arm pain, but no lymphedema or axillary node recurrences. And this is an interesting article that came up from the ABSI, a practical consensus statement, which did a survey of the surgeons and found that this was actually during the meeting when they had the audience and expert discussion. So when asked whether they would use blue dye alone, 86% of the audience said yes, and 63% of the experts. So the attitude has definitely changed, I would say, in the last 5 to 10 years. So our recommended technique is you actually need only 0.1 ml for the intradermal injection, or you can put 0.3 just deep subdermal. So now I use a combination of 0.1 intra and about 0.1 to 2 subdermal. So that's all you need. It's a very small quantity. And you use 2 or 3 sites. The older the patient and the more obese, you need a slightly higher volume to overcome the resistance, and gentle massage for 4 minutes. This is just a picture showing. Now I'll move on to the video. Yeah, Pooja, can you see the video now?
They started share. Yeah, now started.
Okay. Okay, so this is a case where this is the injection technique showing we use just a 26 gauge needle, and at the edge of the areola, 0.1 goes intradermal. What we've learned from the ICG technique is that the intradermal works much better than the subdermal. And a very small quantity intradermal is quickly taken up into the lymphatics and will go into the axilla. So here we used 2 sites. 0.1 intradermal and another 0.1 to 0.2 subdermal. That's my current technique. So that's all, very small amount. And now we just to show the quantity, I'll just increase the speed a bit again. So this is massage, and this is the case of mastectomy, so we can see the lymphatic channel well. Still, a majority, around 60% of our cases, mastectomy cases, as many places in India will find. Slowly, the uptake of BCS is increasing. But there we are following the blue lymphatic, I hope you can make that out, into the axilla. The advantage of isosulfan, definitely it's a much stronger blue color and it's taken up preferentially into the lymphatics, whereas methylene blue has water solubility, so and the color is not as strong as isosulfan. So definitely as a dye, isosulfan is better, which is why it was used initially. But cost, logistics, and adverse reactions have unfortunately restricted its use. I think many people all over the world have now shifted to methylene blue. So there is the node in the low axilla. We can see that the lymphatic leading to the lymph node. Sometimes the lymphatic may not be visible, but often in this case, especially when you do a mastectomy, you can see it. So here I have an additional technique. Like when I learned imprint cytology while working abroad, we used to cut the node and then press it on a slide and do the imprint. So I've adapted that because imprint will pick up very fine met, and that may not actually change the management. So you can do an intraoperative assessment. So here's now a second blue node just adjacent to the first one. So here you could actually palpate a small, you can see a white blob at the lower end of the node. So, and the blue dye is in the middle level. And there you can see the metastasis, the white met, which around which the blue dye is on the edge of it. And you can feel the grit of the cut with the node. So it's an intraoperative technique, very simple if you're in a place which doesn't have the path support. So you can see it's a long lymph node, a very elongated. The hilum is well seen, the fatty hilum in most of it, but the bottom edge has a lymphatic metastasis in the lymph node. It's intranodal, not grossly extranodal. So, yeah, it's just to feel the grit. So that's the final specimen. Now, I'll just quickly also show you wide local and central node, just so that we can get both. Here, as before, there's a small primary in the upper part of the breast. We do a perioral excision for this, like was shown earlier, or level 1 oncoplasty. So here again, two-site injection, intradermal and 4-minute massage. So that's the axillary dissection. Now, one advantage of a gamma probe is you can target your dissection, therefore the incision can be a little smaller. But I think the difference hardly makes much difference to outcome. So there we can see the blue lymph node now. So you open the axillary fascia and you can actually see the lymphatic blue channel as well as you trace it proximally. So what I want to say is, if you had a lot of my colleagues working in the periphery have actually asked me. So that's the blue node. And adjacent to that, we'll take out two other palpable nodes. So we have at least three for the central node sample. It's the final specimen. So I'll end with that. And any questions, please go ahead. Yeah.
Thank you, Paul sir, for showing us with methylene blue dye alone technique. It works really very well. And there are a few questions in the chat box. Gaurav sir has answered few. You may add to the discussion with that. So thank you, sir, for showing us the master video. So with this, we move ahead to the auxiliary management, the decision making. And I invite Dr. Goon Jory from UK to present her talk.
Thank you, ma'am. Am I audible?
Yes, yes, very clear.
Okay, ma'am. I'm sorry, I'm in a car and I'm on the move. So I'm speaking from the car. I'll turn on my camera once I finish my talk.
Sure,
And
sure.
I think Sanjay's got the control for the slide.
Sure.
Thanks, Sanjay. Thank you for having me on the course, and I'm very happy to be part of it. I think we're overrunning a bit, so I'll rush through my slides. My brief, like for everyone, was to keep it very basic and provide management algorithms for auxiliary management. Most of it has been covered by Gaurav sir and Paul sir, so they're very tall shoes to fit into and tall order to follow, but I will try. I've intentionally tried to steer away from controversies and areas which are contentious, mainly because there is lots of that in auxiliary management. But I'll summarize what is the standard of care and take it from there. So staging of axilla traditionally has always played a very central role in the treatment of breast cancer. And it's long recognized the usual route of spread of breast cancer to the rest of the body. And the importance initially was laid on an anatomic staging, which I think Chandan sir had also mentioned. And the intention was to predict the prognosis of disease and guide systemic treatment after surgery, and also decrease the disease burden by local clearance, or rather regional clearance of the disease. But gradually over the years, and as has been highlighted by previous speakers, we are seeing a paradigm shift in how we address the axilla, just how we've changed the management of breast from Hallstadian era to breast conserving surgery and oncoplastic breast surgery. And that has happened in axillary surgical management, mainly because it's the tumor biology now which predicts the prognosis of disease, and it's not just down to the axillary lymph node or the number of lymph nodes involved. And removal of axillary disease or clearing the axilla is no longer considered necessary for therapeutic or regional control, simply because we've made advances in systemic treatment and adjuvant treatment beyond surgery. So we really are in the era of personalized treatment plans. And the emphasis should be on survivorship and quality of life. So why this shift? One, as highlighted previously, sentinel lymph node mapping was made possible, and Gaurav says very nicely, and Paul sir very nicely enumerated all the techniques that they sort of mastered from scratch, and made sentinel lymph node biopsy possible even in limited resource settings. Another major change was the recognition, the morbidity and lifelong risk of lymphedema that axillary lymph node clearance brings with it. It's to the tune of 1 in 5, so 20% of patients will have lifetime risk of a permanent morbidity that they will have to live with for the rest of their lives. And in comparative studies, it's to the tune of 15 to 25% versus 3 to 8% for a sentinel lymph node biopsy. Also, advances in imaging like axillary ultrasound has helped in clinical staging of axilla. Next slide, please. So this is just a slide to show what features on ultrasound, which is an extension of clinical examination. And I know some of us feel that surgeons should be performing ultrasound, which is indeed very helpful. But I think when it comes to axilla, it becomes more technical, and especially when it comes to looking at things like fatty hilum, cortical thickness, irregular margins, and then eventually biopsying or FNA of the lymph node. So I think axilla is one area where everyone will agree, as long as you have a core biopsy from the breast. The intention is to get a core from the axillary lymph node as well. But in case of axilla, a positive FNA is also considered substantive evidence to proceed with your treatment or a clearance if you're going for upfront surgery. But I'll come to that later. Next slide, please. Thank you. So without going into any details, I think I've already summarized. So we started with the era of axillary lymph node dissection, and then eventually with several landmark clinical trials, it was noted that there was no significant difference in locoregional control, disease-free survival, and even overall survival between sentinel node biopsy and axillary clearance in patients with a negative or a clinically N0 axilla or a negative sentinel lymph node biopsy. So a lot of unnecessary clearances could be avoided, and patients could live a better quality of life and upper extremity function after surgery. So this essentially applies to early or operable breast cancer, and I think it has been established beyond doubt that sentinel lymph node biopsy is the standard of care for clinically N0 axilla. Next slide, please. So this is just a snapshot of the studies, but I will not go into any details. I've essentially summarized. So T1, T2 tumors with clinical N0 or 1 to 2 positive sentinel lymph nodes. We'll come to that later. But all of these trials within their study and long-term follow-up showed no difference in overall survival, disease-free survival. And both arms, in fact, sentinel lymph node biopsy showed lower risk of locoregional recurrence in some trials as compared to axillary clearance arms. Eventually, there's a discussion between radiotherapy to the axilla versus clearance, but I'll discuss or I'll touch upon it later. So this is the simplified version of a staging algorithm of axilla, or how one can approach a patient with early breast cancer or a T1, T2 tumor. So clinically, you would examine the patient and either feel some palpable nodes, or as a part of your routine assessment, any patient detected with a breast cancer would have an axillary ultrasound as well. So in our practice, axillary ultrasound happens at the same time, but sometimes if a patient's presented with a symptomatic lump and a clinician can feel lymph nodes, then you would refer the patient for an axillary ultrasound for further assessment. So clinically, which is based on either your clinical examination or ultrasound, if you can feel, if you cannot feel any suspicious lymph nodes, or you cannot see any suspicious lymph nodes on the ultrasound, then sentinel lymph node biopsy is the standard of care, and there is no controversy as far as this is concerned. The further assessment starts. So next slide. So if we move to clinically node positive, so this is a lymph node. So a T1, T2 breast cancer with a lymph node either positive on FNA or core biopsy would be considered an N1 axilla. And in that case, depending on the tumor biology, so it is again not down to the lymph node positivity, but it is down to the tumor biology. So say T1, T2 with an N1 axilla, but a luminal A, so estrogen receptor progesterone positive and negative HER2/neu, would again go straight to surgery and have an axillary clearance. Whereas a patient with a more adverse biology, say a HER2 positive or a larger tumor more than 2 centimeters or a triple negative, would be for systemic treatment first, and then you would reassess at the end of systemic treatment and then decide what to do with the axilla depending on the response to systemic treatment. Again, if the core biopsy is negative to begin with, then you would proceed straight to a sentinel lymph node biopsy. So I'll come to post-neoadjuvant treatment options later, but Gaurav sir has touched upon them already. Next slide, please. Thank you. So for a clinically negative axilla or a CN0, you've done a sentinel lymph node biopsy. And again, after surgery, the histology has come back as node negative, so your sentinel lymph nodes are negative. Straightforward answer is you don't need any more treatment for the axilla. That's surgery complete. If you have a positive sentinel node, then most of the guidelines agree that you don't need to clear an axilla which has 1 or 2 positive sentinel lymph nodes. Now, I understand it could depend on the resources that you have, because you would certainly have discussion about axillary radiotherapy or adjuvant treatment with the patient. And if these resources are not available, then one's hands are tied. But in an ideal world, you could avoid a permanent morbidity in these patients. More than 3 positive sentinel lymph nodes would go straight to an axillary clearance, and I hope most of my colleagues will agree with it. But in case of micrometastasis, isolated tumor cells, or 1 or 2 positive sentinel lymph nodes, you don't need to proceed with axillary clearance if you have the resources. So this is a snapshot of the guidance, which more or less agree with what I have said. Few things differ between USA, UK, and Europe, but more or less, I think the takeaway is that for a clinically N0 axilla in a T1, T2 patient, sentinel lymph node biopsy is the standard of care, and one should try and achieve that in all resource settings, which we've seen is achievable from the previous 2 speakers. Next slide, please. Thank you. So I will not go into the controversies or de-escalation, but historically, if a patient had positive core biopsy from the axilla at the time of diagnosis and then went on to have neoadjuvant chemotherapy, historically they would, whenever they come back for surgery, they would have an axillary clearance irrespective of the response in the breast or the axilla. Now, this domain is still evolving, and a lot is dependent on what you have available with you, what modalities you have to assess response, and what resources you have in terms of performing a sentinel lymph node biopsy after neoadjuvant chemotherapy. I think Gaurav has gone into quite good detail, and I don't think I can top that. But I think the bottom line is, if there is residual nodal disease, so either on imaging, whether you do an ultrasound for follow-up or an MRI post-chemo, if you have imaging evidence of incomplete response, then they go straight to axillary lymph node clearance. However, if you have complete imaging response, these are candidates who could be considered for sentinel lymph node biopsy and targeted axillary dissection if the positive lymph node has been marked at the time of diagnosis. Again, a lot of trials are going on as far as these possibilities are concerned, and even within the UK, there are centers who still stick to the old paradigm, and any patient with a positive node post chemo would go straight to lymph node surgery or lymph node clearance, whereas most of the centers have adopted targeted axillary dissection and a sentinel lymph node biopsy, just to highlight that post chemo sentinel lymph node biopsy has to be a dual tracer or dual agent sentinel node biopsy, whether they were N0 or N1 at the time of diagnosis. Next slide, please. So these are just some special circumstances of whether or not to do a sentinel lymph node or whether or not to manage the axilla. So quite straightforward. For a pure DCIS, if you're doing just a lumpectomy, then there is no indication for a sentinel lymph node biopsy unless it is a mass forming DCIS, or there is a high suspicion on radiology, in which case a second site biopsy is advised with an intention to upgrade. And you can consider sentinel lymph node biopsy in an MDT setting or an MDT discussion. With a mastectomy for DCIS, most guidelines would agree at present that sentinel lymph node biopsy at the time of mastectomy is recommended. However, there are ongoing trials which are voting for delayed sentinel lymph node biopsy if you find invasive cancer following mastectomy for DCIS. Next slide, please. I think we can skip this slide, but it's mainly showing avoidance of axillary surgery completely, and for a clinically N0 axilla with normal ultrasound in patients with T1 tumors, you can just keep them on observation or surveillance. But I will not go into these details. There's another section of patients, so elderly patients with good prognostic disease. So say a T1 or a T2, a T1 with a grade 1 or grade 2 cancer and a normal axilla, you can offer omission of sentinel lymph node biopsy. In fact, the ASCO guidelines and the NCCN guidelines also support this. However, anyone with a grade 2 or a grade 3 but T2, a sentinel lymph node biopsy would still be the standard of care. So slowly the movement is towards omission of axillary surgery, but I don't think we are there yet. Next slide, please. So this is just a snapshot of the ongoing trials about omission of sentinel lymph node biopsy in elderly patients. Happy to share it with the delegates. Next slide, please. So besides the axillary management, these are some of the practical tools that I find very helpful in my clinical practice, and they are very helpful when it comes to shared decision making, because despite the guidelines and the trials and department policies, there will be that odd case where you will be in the gray area, where a lot of it would be dependent on what the patient says, and you will not be in a position to make black and white recommendations. So when you're deciding between patient with 1 or 2 positive lymph nodes, and it's a young patient who's not really sure whether she's thinking she wants to have axillary clearance, but she doesn't know if there'll be any more positive lymph nodes. So the Memorial Sloan Kettering nomogram, these are all online freely available tools. So you just have to enter the patient data, whatever they ask in terms of histology, age, and all those things. And it gives you a percentage of what are the chances that the patient has more residual positive lymph nodes. I find this helpful in some patients who are struggling with decision making. Age gap tool again compares breast cancer treatment in elderly patients. So whether if you're not sure whether you want to operate or put them on primary endocrine, or whether they'll have benefit from chemotherapy. And I think Predict tool is quite popular and most of us use them. So this is just something I wanted to share, but thank you. And yeah, greetings from Southampton.
Thank you, Goonj, for so nicely covering the management for the axilla and how it has evolved and how are the different practices in different parts of the world. And now we are reaching to a stage where it is N0, means no axillary dissection also, as you have highlighted. And thank you for sharing the tools. That will be useful. And I hope people use those tools. So I don't see any questions in the chat box. Maybe they crop up later. So
That's fine.
thank
I'll
you a
just
lot.
slept through it.
Thank you for joining. So we move
Thank
ahead.
you.
So now we see the Mexico experience for sentinel lymph node biopsy with methylene blue dye alone. I invite Dr. Santiago Sherville to share his experience.
Hello, everybody.
Hello, all good. Thank you. We hear you nice and see you well.
Thank you. Okay. Does it work? Let me share my. That's it. Is it working fine?
No, I'm just seeing your screen with the S letter. I don't see your PowerPoint and
Um, uh,
have you clicked share button?
yes, I've done that, but uh,
And now
is
something
it
is starting, I think. No, we went back to
no?
the. Maybe you have to give permission to allow Zoom to access it.
Sure. Okay.
I think maybe you can share your slides to me, or I am sharing you my email ID. Meanwhile, we will
Oh,
proceed with the next presentation.
let me check if I can.
So, Pooja ma'am, let us proceed with next presentation. I will
Sure,
share well slide next after this.
sure. Thank you, Dr. Sanjay.
I'm sorry, I don't know what happened.
We will just have your talk after this next talk.
Okay.
Just check it out. Thank you. I invite Dr. Amar Deshpande to talk on intraoperative margin assessment. What is the gold standard and what's the optional luxury? So that's an interesting article topic to hear about.
Good evening.
Good evening, sir. Yeah,
I'm just trying to share my presentation.
sure.
Uh, Sorry, I'm having similar problem. Perhaps Dr. Sanjay has got my presentation. Perhaps he can share that.
Yes, I will share, sir. One
Please,
second.
please. Thank you. So I'll start talking till then.
Sure.
I'm just going to thank Dr. Sanjay for inviting me to present this very important topic, which is margin assessment, and whether it's absolute necessity or it's a luxury. Um, Frankly, we all know that margin assessment on table is necessary. That is because we want to achieve oncological clearance and want to reduce the risk of re-excisions or further surgeries and getting a good outcome. And currently, the consensus is to get the margin clear so that there is no tumor at the inked margin for invasive tumors, and for DCIS with breast conserving surgery less than or more than or equal to 2 millimeters. That is generally recommended. So basically, how we can do the intraoperative assessment of these margins. Next slide, please. So we all know what is a margin. It's the amount of breast tissue between the tumor and the specimen edge, that is the inked surface of the specimen that we take out. And the pathologist would give us whether these margins are positive or negative or close. And specimen orientation should be done to get that. And there are several uses of that. Pathologists would like the specimen to be orientated so that they can tell us which margin is close exactly. And intraoperative assessment with radiology, we need to clip the margins, and you have to have your own protocol. Our protocol is to put one clip anteriorly, two clips superiorly, and three laterally. For the pathologists, and where we are not using the specimen mammogram, were short superior stitch and long lateral stitch. Next one, please. So why should assess? Why should we assess the margins intraoperatively? And earlier somebody asked this question: how to assess? So perhaps I would be able to answer that question as well as why to assess. So obviously we want to reduce the re-excision and conversion to mastectomy. If we have already got a tumor which we can't get a clear margin of, then we are going to consider doing a mastectomy or a larger oncoplastic surgery, so that you take a larger chunk of breast tissue away. Avoiding further operation means we are saving the cost as well as a further surgery for our patients. And we know that if the margins are positive, then there is a very high risk of local and distant recurrence. There are a couple of studies that have been done. It's basically to see how the positive margins affect the outcome. Next, please. So we'll just go to the techniques, and there are simple techniques that we can use to assess the margins. There are some fancy techniques coming up, which I would mention. However, they are costly, and there is really no need of those. Next slide, please. So grossly, what we would do is, in the palpable tumors, you will palpate and see whether there is a good margin of normal breast tissue around that palpable lump. Gross margin we will use as 1 centimeter, and a simple technique is to put your finger beyond the edge of the tumor and use your excision around beyond the finger breadth, and that will give you 1 centimeter margin. And it is very, very important to palpate the cavity wall after you excise the tumor, because sometimes you feel nodules or some areas that are suspicious in the cavity wall, and in those cases you need to take the cavity margins. Some people do the cavity margins excision as a routine to even minimize the chances of needing a further surgery. Next one, please. So imaging-based techniques, we do specimen radiography for smaller or the tumors where there are microcalcifications or non-palpable tumors. And it is, as I said, important to orientate that specimen well, so that if you need to do further excision, then you can do that based on what you see on the image. Ultrasounds can also be used for some tumors which are not which are mammographically occult and not palpable, or very small tumors. And these, I have used it very rarely. There are other 3D specimen tomosynthesis or CT scan techniques, which I have never used, to be frank with you. However, in some cases, in some places, they are used and they are supposed to be higher in accuracy. I wouldn't know that because I have not used them. Next one, please. Frozen section. Frozen section is a luxury available to us at Tata Memorial Center. However, I have rarely used it for margins. I've used it mainly for lymph node assessment. And if the lymph nodes are positive, then we will proceed with further surgery of lymph node clearance, or put them on one of the trials that we have. Touch or imprint cytology is something that I have actually used in Warwick, where I did my training years ago. And there, the sensitivity of imprint cytology was about 80%. So again, we got a 20% patients where it may not be accurate. In any case, all these pathology-based techniques, we need a lot of resources. I'll come to that later on. All these techniques are being used, and people using these techniques vouch by them. However, they are expensive. They need a lot of investment, and the results are variable. Again, I have not seen many people using these techniques, and I have certainly never used those. Next, please. Next slide. Yeah. So what are the adjunctive surgical strategies? Routine cavity margin shaves, as I said, some people do that routinely, and that that minimizes the risk of needing further marginal excision. But the trade-off there is that you take more tissue out than necessary, and that can affect your ultimate cosmesis. Of course, you need to think about oncology first. However, you need to take adequate amount of breast tissue, not too much, not too less. And orientation is very important so that your pathologist can give you an idea if any of the margins are closed. So we know that frozen section is sensitive. However, the sensitivity varies and it is more operator dependent. Specimen radiography is more accurate and it can give you a good idea. However, it's the non-calcified DCIS, if it is present at the margins, you may not be able to see that. So again, there is some degree of false negativity as well. Cavity shave margins, as I said, you are taking more breast tissue. And other methods, again, the results are, they are still experimental, the results are variable, and they are very expensive. Next one, please. So we got a meta-analysis by ABC TCG, and that clearly shows that we need to get a clear margin. However, no cancer cells at the edge of the specimen are acceptable. I have not gone into too many details because of the constraints, the time constraints. Next one, please. So what's considered a clear margin? Once again, a clear margin used to be a centimeter before. This is microscopic margin I'm talking about. Then we came down to 5 millimeters. Then we came down to 2 millimeters, 1 millimeter. And now we consider for invasive breast cancer, no ink on the tumor. And Monica Moro's paper has actually got all that. Once again, I would recommend reading this paper, but I have not gone into details again because of the time constraints. Next one, please. So this is the most important thing. Your hospital or even NHS hospitals would not would see the cost effectivity of any new intervention or investigation that we would use, and therefore all these things need a lot of investment in the form of human resources as well as the capital investment. So that consideration always comes into picture. We got simple methods which we can use to get the margins as accurately as possible. Next one, please. So there are limitations, as I said, with DCIS, which is non-calcifying, multifocal tumors, the skip lesions, and all these things may leave the cancer while you think that it is out from your intraoperative management, intraoperative assessment. Even specimen mammograms may show that the tumor is completely out, but they may have a skip lesion somewhere else. Next one, please. So what are the future directions? Yes, artificial intelligence is kind of dominating everywhere. And some of the presentations we make are with the help of artificial intelligence as well. Disclaimer, I have not used it. So all these new techniques are being evaluated. Once again, they are going to be expensive, at least to start with. And whether we need them or not is a question. In our case, we don't use frozen section. We don't use any of those expensive techniques. But our margin re-excision rate is about 2% at TMH, so TMC, Mumbai. And that is without using all those fancy techniques. It's just palpation and specimen radiographs where necessary. Very rarely we use frozen section. I mainly use it for margin assessment for phylloides tumor and not breast cancer. So essentially, the key takeaway is oncological safety we should achieve, and we should make sure that the margin is clear. Again, adequate amount of breast tissue is what we should remove. Next one, please. So these are the references that I have used. And I would just say that the best margin is the one that we confidently leave behind, clear, documented, and justified. Thank you.
So thank you, Dr. Amar Deshpande. Very nicely, you demonstrated the role of imaging, pathology, AI, and how the future is going towards.
Thank you.
And for sharing your experience from TMC. So indeed, that was valuable. So I don't see any questions in chat box. Maybe they crop up later.
So, thank you.
I think, and we move ahead. So is Dr. Santiago's slides ready?
I think so. Let's see. Can you share the presentation? Can you see it?
Please go ahead.
Okay. So thank you so much for this invitation. I'm Dr. Sherwell from Mexico, and I'll speak a little bit about our experience using methylene blue for sentinel lymph node biopsy. Well, in Mexico, breast cancer, as it is in the rest of the world, is the most common cancer and is the most frequent cause of cancer-related death in women over 25 years old. So we have a really bad problem with breast cancer in Mexico. One in 8 women will have breast cancer, and we have the median age of presentation is 51, and we also have 13% of patients with breast cancer are under 4 years old. So the other problem that we have is that around 50 to 60% of the patients with breast cancer are diagnosed in locally advanced stages. So we know that we will have an adverse prognosis, and the treatments will be more radical, and the treatment will be it will cost a lot higher. So why is that? Why do we have this problem? Because there's a lack of information in the population. We have limited access to screening and diagnosis, and we have a low rate of population with medical and insurance, and the public system is saturated. So this will cause that the treatments, the diagnosis and the treatments are delayed a long time. So even though that we are located and we have a private breast cancer center in Mexico with all the resources, because of the lack of access to public hospitals, we have a significant number of patients with limited economic resources in our hospital. So that's why we have to adapt all the techniques so we can deliver a good medical care to this population who are who don't have all the economic resources. So as we know, the methylene blue is mainly used in the medical area. It's in Mexico. It's highly available. It has a really low cost, and we know it's lymphophilic. So that's why we can use it for the sentinel lymph node biopsy. So the cost it's quite different. This slide shows about the cost for the different methods that we can use for the sentinel lymph node biopsy, and we can see that the methylene blue is the cheapest one, and the technetium is about, in Mexico, the cost for each patient is 10 times greater than the methylene blue. That's why we started using this technique. So what are our numbers? We use 1 to 2 milliliters of supraareolar injection. We use a pre-medication to all patients before the injection. We give a 5-minute massage, and we wait between 15 to 20 minutes period for diffusion. What we have learned is that we have to wait a little bit longer with a methylene blue compared to a patent blue. So we recorded all the patients from 2019 to 2024, T1 to T3 and 0 patients. We don't care if they received, we include all the patients if they received adjuvant or neoadjuvant treatment. And we just, for these patients, we just used the methylene blue alone. So we have 211 patients who have undergone to sentinel lymph node biopsy just with a methylene blue. The accuracy rate is 91%, which is very comparable to other techniques. What we have noticed is that we have a little bit higher rate of accuracy in patients who undergo to surgery first, and the average lymph nodes detected is 1.4. So, and what we have, the last point is that we haven't had any allergic reaction with methylene blue, so it's really good for us. The methylene blue, we can say that it's highly effective for sentinel lymph node. It has a really low cost, and it's highly available in our country. So we encourage some other centers to use this method, so the patients don't have the need to go to an axillary dissection. Very important for us, we have to have a longer diffusion time. It's safe. We don't have any significant reaction, and it can be used as a single method for sure. It's accessible for all patients, and it's really accurate. So this we can assume that it's a really good method for sentinel lymph node. Finally, I would like to show this painting. It represents the first mastectomy in Mexico. It was painted in 1777, and it's really interesting how the things have changed over the time. I will be glad to answer some questions. This is the city where I live, and thank you so much.
So thank you, Professor Santiago. That was very nice, and I can see claps raising up. And for the nice painting also, that is a historical painting for the mastectomy, how we show it has evolved. And thank you for sharing your experience. Like similar to India, you have told that it is quite safe, low cost, and as Dr. Paul also told, he also uses 1 to 2 ml. So you also highlighted the value of using just small amount. So that was quite good experience, and I think that encourages more surgeons to use methylene blue single dye alone for the sentinel node. So I don't see questions in the chat box. I see series of claps coming up. So
thank you so much.
Enjoyed your talk. Thank you. And now we move ahead for the key lecture on overview of guidelines for resource limited settings. I invite Professor Cheng Hariep to deliver her talk.
Hello.
Hello, good evening.
Can you hear me?
Yes, I hear you well.
Yes, I've pre-recorded my lecture. For those who don't, hello? Lecture on overview of guidelines for resource limited settings. Clinical practice guidelines is a systematically developed statement to assist practitioner and patient decisions about appropriate healthcare for one or more specific circumstances. There are many therapeutic options in the management of breast cancer. Team management is emphasized, and it requires a surgeon, radiologist, pathologist, oncologist, breast cancer nurse, genetic counselor, plastic surgeon, and occasionally other specialties such as gynecologists, geneticists, or psychologists. Treatment should be based on the best evidence available. Breast cancer treatment changes rapidly with new discoveries, particularly in the area of therapeutics, and hence regular reviews of the guidelines are required, usually every 2 years. Many international guidelines have been developed, such as the St. Gallen's Guidelines, NIH Consensus, and the best known are the NCCN guidelines. However, these are developed in high-income countries. How applicable are they to low and middle-income countries? Let us talk about the NCCN guidelines, which are followed by many cancer centers. NCCN stands for the National Comprehensive Care Network. The NCCN guidelines are composed of recommendations based on the best evidence available at the time they are derived. But it is essential that they be continuously updated and revised to reflect new data and new clinical information. The aim of the NCCN guidelines is to assist oncologists in making the major clinical decisions encountered in managing their patients. Of note, NCCN has now developed resource-stratified and harmonized guidelines for countries with different resources. Why do LMICs need separate guidelines? Guidelines need to be culturally sensitive, economically feasible, and acceptable to the public. Do treatment guidelines in developed countries be equally effective in developing countries? For example, most clinical trials on new treatment strategies, particularly in new drugs, are carried out in high-income countries in a mainly Caucasian population. Would they be as effective in different ethnic populations? As well as cultural and ethnic differences, there are many problems facing the healthcare system in LMICs. Public facilities, which provide the bulk of secondary and tertiary healthcare services in most countries, offer services of poor quality. The composition of health services offered and consumed is suboptimal. Providers cannot be enticed to urban and to rural and urban marginal areas, leaving large segments of the population without adequate access to healthcare. And the referral system and coordination in the delivery of care is inadequate. The concept of resource stratification first started with the Breast Health Global Initiative in 2005, and these resource stratified guidelines were published in 2006 in the Breast Journal. The Breast Health Global Initiative strives to develop, disseminate, and foster the implementation of evidence-based, economically feasible, and culturally appropriate guidelines for international breast health and cancer control to improve breast health outcomes for middle and low-income countries with limited healthcare resources. Based on this concept management of breast cancer, depending on the resources available, we divided the resources into 4 levels. At the basic level, which may apply to low-income countries, there must be core resources absolutely necessary for any breast health program. At the limited level, which may apply to low-middle-income countries, there are second-tier resources or services which would produce a major improvement in outcome. At the enhanced level, which may apply to high middle-income countries, there are third-tier resources or services available that are optional and may produce minor improvements in survival. At the maximal level, which may apply to high-income countries, there are highly level resources which may not even be affordable in high-income countries. We will go into this resource stratification later. In 2016, the NCCN also published a framework for resource stratification, which was based on the initial work done by the BHGI for providing and improving global quality oncology care. Based on this NCCN framework for resource stratification of NCCN guidelines, the resources available are described. We go into basic resources, core resources, enhanced resources, and the NCCN guidelines, which are those that are for the high-income countries. Okay. Basic resources is also defined as when there are essential services needed to provide the basic minimal standard of care. Core resources include services provided in the framework for basic resources plus additional services that provide major improvements in disease outcomes, for example, survival, that are not cost prohibitive. At the enhanced level, services provided in the framework for core resources and additional services that provide lesser improvements in disease outcomes and or services that provide major improvements in the disease outcome but are cost prohibitive in lower resource settings. The NCCN guidelines are evidence-based, consensus-driven recommendations based on services available at centers of excellence in the United States. They include services from the framework for enhanced resources and additional services that provide minor improvements in disease outcomes, interventions that are cost prohibitive in lower resource settings, and or services that do not provide improvement in disease outcomes but are desirable services. Now, with the stratification of sets of guidelines for different resources, does this mean that we are endorsing substandard care for women with breast cancer? Not really, because if we follow NCCN guidelines in a low resource setting, we might not even get started on treatment. With resource stratified guidelines, every woman with breast cancer will have access to the best possible care at the resources available to the healthcare professionals in that setting. Now, what are the principles for guideline development? All women have the right to access healthcare, but considerable challenges exist in implementing breast health care programs when resources are limited. All women have the right to education about breast cancer, but it must be appropriate culturally and targeted and tailored to the specific population. What are the strategies that need to be considered? The more advanced the cancer diagnosis, the poorer the survival and the more resource intensive it is to treat. Hence, efforts must be made to reduce the stage at diagnosis. At this point, I have to mention that one of the targets of the recently published breast cancer initiative is to have 60% of breast cancers diagnosed at stage 1 and 2 to be able to improve survival from breast cancer. Each country must build programs that fit its unique situation. Development of cancer centers in some low-income countries can be a stepping stone to providing high-quality care to at least some women. Collecting data on breast cancer is imperative for deciding how best to apply resources and for measuring improvements in outcome following programmatic change. Now, this is an example of resource stratified guidelines for local regional treatment. At the basic level, which are for the really low-income countries where there are likely no radiotherapy facilities, modified radical mastectomy will be the standard of surgical care. At the limited setting, where radiotherapy facilities are available, breast-conserving surgery can be carried out. Sentinel lymph node using blue dye is feasible. And I have to mention here that Professor Agarwal has just given a key lecture on low-cost pragmatic sentinel lymph node biopsy in breast cancer, developed and evolved at his center over 25 years. At the enhanced level, sentinel lymph node biopsy using radio tracer can be carried out. At both the enhanced and maximal level, oncoplastic breast surgical techniques have been developed, and immediate breast reconstruction with various methods are available. This table is from the BHGI publications. This table from the BHGI publications gives the strengths, weaknesses, and the required resources for each surgical treatment. All of us who train in surgery and in an LMIC are taught to do a modified radical mastectomy early in our surgical career. It is rapid, can cure early breast cancer, and does not require any advanced technology. The only weakness is that without reconstruction available, it is disfiguring. Only basic resources are required. We just need a surgeon, an anesthetist, a scrub nurse, and an operating theater. Breast conserving surgery with axillary dissection is also a rapid surgical treatment. However, it is more technically demanding, especially in achieving clear margins, and it is important to choose the patients appropriately. It also requires post-op radiotherapy. Hence, it is important to ascertain that the patient is agreeable to radiotherapy and has access to radiotherapy facilities. The required resources are the same as for modified radical mastectomy, with the addition of radiotherapy facilities. Sentinel lymph node biopsy with blue dye provides accurate identification of the sentinel lymph node and minimize morbidity in women with negative axillary lymph nodes. However, it needs an experienced sentinel lymph node team, and there may be a rare allergic reaction to the dye. Required resources are the same, that is, an operating theater, a nurse, and more experienced surgeon. And for sentinel lymph node, pathology is more intense, requiring serial sectioning of the sentinel lymph node to identify micrometastasis. Sentinel lymph node using radiotracer has the same strengths as for blue dye, that is, accurate identification of the sentinel lymph node and minimize morbidity in women with negative lymph nodes. However, it requires a more experienced team and also special handling of the radiotracer. And very important additional required resource is a nuclear medicine facility. This is a study done by the IAEA, that's the International Atomic Energy Agency, on access to radiotherapy in low and middle income countries in Asia. As you can see, there are many countries with limited access to radiotherapy. In Malaysia, which is a high middle income country, 78.9% of the population has access to radiotherapy. When I was a young surgeon working in the university hospital, I started the breast clinic in 1993. And that was when we just got our first mammogram machine. I was not allowed to start a breast clinic until we got one. We did not have radiotherapy or an oncology unit. So I was practicing at very basic level, doing mainly modified radical mastectomies and the odd breast conserving surgery when the patient could pay for radiotherapy in a private hospital nearby. And because there was no oncologist, I had to give my own adjuvant chemotherapy, which was essentially just the basic CMF, the cyclophosphamide, methotrexate, and 5-fluorouracil. Tamoxifen was not provided free, so I could only give it to women who could afford to buy it outside. But we did not have any money for immunohistochemistry, so we could not do the ER, PR, HER2. So which was the standard in those days, was we would provide tamoxifen to women if they could afford it without the benefit of knowing the estrogen receptor. And in some parts of Malaysia, this is still happening because we will have hospitals which do not have all the facilities. Of course, that was 30 years ago. Now I work in a hospital with maximal resources. We have external beam radiotherapy, intraoperative radiotherapy, PET-CT scan, breast MRI, stereotactic biopsy, immediate breast reconstruction, oncoplastic breast surgery, genetic counseling and testing, every modern systemic therapy available, pathological investigations, which include even NGS, that's the next generation sequencing. Even within the same country, doctors are practicing at different resource levels, from basic to limited to enhanced to maximal. Now, let us talk about the impact of guideline adherence on breast cancer survival. Most studies are done in high-income countries. In the EU, a systematic review published in 2020 showed that adherence to guidelines was associated with increased overall survival with a hazard ratio of 0.67 and a disease-free survival with a hazard ratio of 0.35, representing 138 more survivors and 336 patients free of recurrence for every 1,000 women receiving adherent treatment compared to non-adherent treatment. Adherence to treatment guidelines was associated with higher costs, but adherence to follow-up guidelines was associated with lower costs. What about the impact of guideline adherence in a resource-limited setting? We published this study in 2022 in JCO Oncology on the association between adherence to clinical practice guidelines for adjuvant therapy for breast cancer and survival in Malaysia, which we consider a resource-limited setting. This was a cohort of 3,100 Malaysian women with non-metastatic breast cancer diagnosed between 2010 and 2017. Adherence to the Malaysian Clinical Practice Guidelines for Management of Breast Cancer, second edition, was measured. In those days, we only had 2 editions of the guidelines. Now we are actually onto the 3rd edition. Guideline adherence for adjuvant chemotherapy, radiotherapy, hormone therapy, and targeted therapy were 61.7%, 79.2%, 85.1%, and 26.2%, respectively. It is noted that only 26.2% of eligible patients had access to trastuzumab during that period. You must remember that period was 2010 to 2017, because trastuzumab was very expensive then, and patients had to pay out of pocket since it was not provided free. And this study was done mainly in a public hospital. Now that there are biosimilars available, access has improved, but it is not good enough. In a recent survey, only about 46% of patients have access to trastuzumab. Compared to patients who were treated according to treatment guidelines, overall survival and event-free survival was substantially lower in patients who were not treated appropriately. The corresponding hazard ratios for mortality was 1.39, 3.83, 4.39, and 3.15 for chemotherapy, radiotherapy, hormone therapy, and targeted therapy, respectively. So this study shows that adherence to treatment guidelines that have been adapted for resource-limited settings may still provide effective guidance in improving breast health outcomes. In conclusion, the of guidelines are to provide evidence-based recommendations for the optimal care of women with breast cancer and women at risk of breast cancer with the aim of improving breast cancer overall survival. Although I have talked mainly about surgical treatment and adjuvant therapy for breast cancer, we must remember that guidelines cover all aspects of breast cancer, from early detection and screening, investigations and diagnosis of breast cancer, local and systemic treatment, survivorship, and palliative care. These are the Breast Health Global Initiative guidelines. The pillar 1 is health promotion for early detection. So the target is to have 60% of invasive breast cancers diagnosed at stage 1 and 2, evaluation, imaging, tissue sampling, and pathology completed within 60 days, and 80% of patients undergo full courses of multimodality treatment and successfully return home. This is the 60-60-80 target.
So thank you, Professor Cheng. That was very nicely elaborated, and you showed the real ethos, how the guidelines have stratified the recommendations based on the resource available countries and resourceful available and resource restricted countries. That is very useful for all of us. So I can see claps rising, Dr. Swagata said. So I don't see any questions much in the chat box. So thank you for being with us. And you were in some hotel and you had issues with login, but still you kept yourself logged. So we are grateful for your valuable time you have given to us.
Okay, thank you very much.
Thank you. So with this, we move forward towards another key lecture. So now after sentinel node biopsy, we move towards axillary lymph node dissection. So what are the indications? So I invite Professor Stephen Kai to share the valuable inputs. Thank you.
Hi, can you see my screen?
Yes.
Wonderful. So good evening, everyone in India and the United Kingdom, and afternoon if you're signing on in the Americas. My name is Stephen Kai, and I'm a breast cancer surgeon in New York City, caring for a very underserved population of Chinese American over the last decade. It is truly a privilege for me to be part of this amazing symposium organized by Dr. Sanjay Yadav. I think between Dr. Yip's lecture and Dr. Jory's lecture, you can probably skip my lecture. I have no disclosures pertaining to this talk, except that I do believe breast surgeons should be trained and certified and perform breast ultrasound to benefit their patients pre, intra, and post-operatively. My goal in this talk is to share the evolution of axillary management from the past to the present and looking ahead at the future. Like Dr. Jory did an amazing job describing the current state of axillary management, avoiding some controversies. I'll dive straight into some of these controversies myself and how we're dealing it in America, and how some of the centers have been adopting some of these newer suggestions. As many of you remember, we have gone from a maximally invasive past consisting of radical mastectomy, modified radical mastectomy, and to a lot of times completion axillary dissection. Was truly the norm in 1970s and the 1980s. However, the revolution started with several landmark studies. One of these studies, B04, as Dr. Jory alluded, was a landmark study in the history of breast cancer treatment. After 25 years of follow-up, the study found no significant difference in long-term outcomes, including overall survival and disease-free survival among the various treatment groups. Specifically, it showed that for clinically node-negative patients, total mastectomy with or without radiation was just as effective as radical mastectomy. And for the clinically node-positive patients, total mastectomy with radiation was as effective as radical mastectomy. The trial showed that less extensive surgery, which was also less disfiguring, had fewer side effects and could achieve the same survival outcomes. And Z11 trial showed that also carefully selected group of those that are T1, T2 clinically node-negative breast cancer patients, 1 and 2 positive sentinel lymph nodes undergoing breast-conserving surgery and whole breast radiation, a complete axillary lymph node dissection was no longer necessary. Therefore, prompting for omission of axillary lymph node did not compromise survival or increase the risk of regional recurrence. AMRO's trial showed that for women with clinically node-negative breast cancer, and a positive sentinel node, axillary radiotherapy was just a safe and effective alternative to completion axillary lymph node dissection. Axillary radiation therapy provided comparable axillary control with a significant reduction in the risk of lymphedema and other morbidities associated with extensive surgeries. These three landmark trials have paved the way for surgical de-escalation in the modern breast cancer surgery. So now let's talk a little bit about the present. These are the three main groupings of surgery. I'll do total skin or nipple sparing mastectomies, plus or minus sentinel lymph node biopsy. Rarely I'll do a modified radical mastectomy. Breast conservation surgery plus or minus sentinel lymph node biopsy is the bulk of my practice. And I do a fair amount of targeted axillary dissection, which Dr. Jory also alluded to. I'm not going to bore you with the guidelines because they don't apply to every single country, but we often do follow these NCCN guidelines, especially in America. But since the last guidelines were published, there were many studies that have propelled us to de-escalate even further the need of axillary staging. And 9343, which addressed the need for adjuvant radiation after lumpectomy in early stage hormone receptor positive breast cancer in elderly, included a small subset of patients who received no axillary surgery or radiation. In this patient cohort, only 3% developed ipsilateral axillary recurrence compared to no recurrences in the patients who received radiation without axillary staging. Due to the low axillary failure among those who had omitted nodal surgery or radiation therapy, authors suggested that sentinel lymph node might be safely omitted in this population. Another landmark study that helped de-escalate the need for axillary staging was RxPonder. Results built upon the findings of previous trials like Taylor RX and had helped further personalized treatment. Prior to this study, having a positive lymph node sentenced the patient to chemotherapy. The findings provided a clear evidence-based reason to spare tens of thousands of postmenopausal women with node-positive breast cancer from side effects, cost, and the commitment of chemotherapy. One of the byproducts is that we no longer needed that positive nodes to know whether that hormone receptor postmenopausal women benefited from chemotherapy or not. Over the last couple of years, we have seen two landmark studies pave the way to further de-escalate axillary staging. Both of these trials looked at no axillary staging in the clinical and node negative small breast cancers when breast cancer therapy is chosen. The Sound and Enzema trial, as Dr. Jory had alluded to, paved the way for ASCO to update their guidelines this spring with a landmark statement based on these can be omitted for selected patients with negative axillary ultrasound who are greater than 50 years, unifocal invasive ductal carcinoma smaller than or equal to 2 centimeters with Nottingham grades of 1 to 2, hormone receptor positive, HER2 negative, intending to receive adjuvant endocrine therapy. No suspicious lymph nodes on axillary ultrasound or only one suspicious node, and biopsy is benign and concordant. Undergoing breast conservation surgery followed by whole breast radiation in patients greater than 65 years. This is what I do in my practice, not guidelines, but evidence-based practice. For my hormone receptor positive, HER2 negative invasive ductal breast cancer, I actually use the postmenopausal status rather than the age to tell whether they would qualify to forego the sentinel lymph node biopsy. They all have to have planned whole breast radiation. But these small lymph nodes, luminal A, clinically and by ultrasound image, node negative patients that are in low to intermediate grade, I would talk to them about potentially foregoing that sentinel lymph node biopsy. Just like Dr. Yip alluded to, this is only applicable when we do have a very high or enhanced or resource area. The choosing wisely is still applicable to all these set of patients. And the key is really having that MDT discussion with my radiation oncologist, with my medical oncologist, and even to a certain degree to our social services, because access of care becomes an issue, especially in low resource area in the urban setting like where I practice this. And that shared decision making, believe it or not, despite the guidelines and evidence that we do present our patients, that shared decision making becomes so crucial. I've had patients that opted in to have that sentinel lymph node removed, despite what I suggested. So it is really, really important to understand where they're coming from and what their thoughts are. Now, as we have de-escalated from sentinel lymph node biopsies, so is axillary dissection still needed in 2024? And as guidelines has shown, my answer is really no. If you look at the NCCN guidelines, and this is the latest update from April 2025, in the non-neoadjuvant setting, where there are no palpable lymph nodes or limited axillary lymph node involvement, based on imaging confirmed by needle biopsy, marker placement is the most suspicious lumen we still perform. Axillary dissection when the central lymph node is not identified or central lymph node is positive and Z11 or Amherst criteria are not met, the axillary lymph node dissection is still done in that setting. In the setting of clinically suspicious palpable lymph node, significant axillary disease burden, matted lymph nodes on imaging or preoperative systemic therapy being considered, and suspicious nodes on exam, on imaging, ultrasound guided biopsy should be done as well. And if it's positive, as you can see on this lower part, and there's no preoperative chemotherapy plan, axillary lymph node dissection is still being performed. And if there is preoperative chemotherapy performed or being undertaken, if the node remains clinically positive, axillary lymph node dissection is performed. And if the node converts to clinically node negative, then we can go ahead and do a sentinel lymph node biopsy or a target axillary lymph node dissection. These are the guidelines from American Society of Breast Surgeons, for which I'm a member of the international committee, just like some of you. But this have not been updated since 2022. But for palpable lymph nodes that are clinically node 2 or 3 stage on presentation, it is still indicated to have an axillary dissection. And then in clinically node negative with positive sentinel lymph node and ineligible for AMOS or the Z11 in the setting of upfront surgery, axillary lymph node dissection for these breast conservation therapy, greater than 2 sentinel lymph nodes positive, and for mastectomy patients with greater than 3 sentinel lymph node positives are still recommended. And for the palpably node positive, biopsy proven and ineligible for neoadjuvant therapy, axillary lymph node is also appropriate for those patients who are not candidates for neoadjuvant chemotherapy, just like the NCCN guidelines said. And for those palpably node positive post-neoadjuvant therapy, which I just mentioned, axillary lymph node is also indicated for patients who remain palpably positive following neoadjuvant. Now, for the node negatives that convert to node positive, for the upfront surgery, the oncologic outcomes of the axillary RT for patients with node negative disease are comparable with less morbidity for axillary radiation therapy. So this has not yet been demonstrated for the post-neoadjuvant setting. So the standard of care shows that axillary lymph node is indicated for these subgroup, but we are all waiting for the Alliance trial 11202 to start reporting, and I'll give you a little glimpse of that later on. And in terms of subtype of cancer, inflammatory breast cancer, there's really limited data on the performance of sentinel lymph node biopsy post-neoadjuvant therapy for inflammatory breast cancer, indicating low success and high false negative rates. So axillary lymph node dissection is still applicable in this setting. And for those with invasive local recurrence and clinically node positive palpable disease in the axilla, axillary lymph node is still indicated for those local recurring. And certainly for axillary metastasis from a cold breast primary, most patients with axillary metastasis from unknown breast primary are candidates for neoadjuvant therapy, but axillary lymph node dissection is appropriate for those who are ineligible to remain node positive in the post-neoadjuvant setting. So challenging the dogma of CN1 disease, a palpable disease, this group from Memorial Sloan Kettering, just uptown for where I practice, was presented their data at SSO this year, as well as it was mentioned during the American Society of Breast Surgeons General Meeting. In a select group of CT1, T2, N1 hormone receptor positive, HER2 negative, with low axillary disease burden as evidenced by ultrasound showing less than or equal to 3 pathologic nodes having upfront surgery, either the breast conservation surgery or mastectomy and sentinel lymph node were undertaken part of this trial. This is a trial with 7 centers or multi-center. It was not randomized, but it was prospective. Patients will undergo axillary lymph node dissection if there were greater than 3 positive sentinel nodes, or have extracapsular extension of tumor into axillary fat, matted nodes, or no positive nodes were identified. They failed to identify the CLIP node. In select groups of CT1, T2, clinically node positive palpable nodes, hormone receptor HER2 negative with low axillary disease burden as evidenced by ultrasound, showing less than 3 pathologic nodes. They had about 78 people that qualified to be part of the study, and the vast majority, 70%, end up not needing an axillary dissection, whereas 31% required axillary dissection, of which 5 of them turned it down. In terms of adjuvant therapy, the vast majority of them had nodal radiation, with 96% of them having cystectomy therapy. Among those with follow-up, with greater than 12 months follow-up, there were only sample size of 44. There were no local regional recurrence. 1 patient developed distant disease. In conclusion, this study showed there's some support of the use of sentinel lymph node biopsy among patients who are clinically palpable node positive in the upfront surgery for hormone receptor positive, HER2 negative, screened by ultrasound. They showed close to 70% of people avoiding axillary lymph node dissection. The limitations of the study was a small sample and limited follow-up. So as we await for other alliance study and the TAXA study for in terms of multi-center randomized control trials after the neoadjuvant setting, Judy Bowie was very nice to share her slide with me to show that, in her study, the Alliance 11202, 841 patients were randomized to have axillary lymph node dissection if they had a positive sentinel lymph node after either a sentinel lymph node or a targeted axillary dissection, and 895 did not undergo axillary lymph node dissection. Whilst we're still waiting to hear back from the recurrence, local regional recurrence, event-free survival, as well as overall survival. The interesting part is that out of the 841 patients, the vast majority, or actually 53% of them, had no more than just that 1 sentinel lymph node or that targeted axillary lymph node that was removed already. So there is an opportunity of sparing that 53% of those patients from further axillary surgery. And with that, I would like to just jump to the future of axillary surgery. Less sometimes could be more. Surgical de-escalation continues to impact the field of breast surgical treatment. Axillary surgery carries no survival benefit and similar recurrence rates in select breast cancer patients with select resources that are available to them. Axillary surgery has consistently shown to have a significant increase in morbidity when compared to radiation therapy, and it is really crucial to have that MDT discussion as to whether axillary staging will impact adjuvant therapy. And with that, I would just want to thank Dr. Sanjay for this invitation, and I would open the floor for discussion.
Thank you, Stephen Kai. It's very nicely you have covered the guidelines and the trials regarding the axillary management. Very comprehensively you have mentioned. And thank you for sharing the data and going towards the future of axillary dissection. And we look forward to this data to be published soon. So I don't see any questions in the chat box. So thank you for your presentation and thank you for joining. Though the appreciations are cropping up, so people have enjoyed your talk. So with this base background, what have been developed for axillary dissection, we move towards the surgical technique. So that is a master video. So I invite Professor Anjali Mishra ma'am, who's professor in endocrine surgery department at SDPJ, for her master video on axillary lymph node dissection technique.
So good evening all. Since I have pre-recorded my video, so I'll request organizers to play the same.
Sure, ma'am. Thank you. Good evening.
And he has asked me to share a master video on axillary lymph node dissection. The disclaimer which I have to make is that this video was not shot by a professional videographer. Dissection once was performed in majority of patients with breast cancer. Currently, the scope of indication for this surgery is shrinking, but whenever indicated, this needs to be performed, and a young surgeon desiring to pursue a career in breast surgery needs to be acquainted to perform this procedure and should master the one. I would not like to go into details of the indication as the same has been covered by previous speaker. Suffice here would be to say that there is no absolute contraindication for this procedure. So before going into the steps of axillary lymph node dissection, a bit about axillary lymph node anatomy. Axillary lymph node is a major basin draining lymphatics from breast. And anatomically, the lymph nodes are divided into 5 groups, including anterior, posterior, lateral, central, and apical groups. However, when speaking in terms of surgery, we divide axillary lymph nodes into 3 levels. Level 1 is located below and inferior to the lower border of pectoralis minor. Level 2 located deep to the pectoralis minor. And level 3 located medial and superior to the upper border of pectoralis minor. So what constitutes the axillary lymph node dissection procedure? Axillary lymph node dissection, as is true for any lymph node dissection, involves careful dissection, removing all the fat, fascia, loose areolar tissue along with lymph nodes from the axilla while preserving the vital anatomical structures. The boundary of this dissection is superiorly by axillary vein, inferiorly an angular vein, medial chest wall, and laterally latissimus dorsi muscles lateral border. Majority of axillary lymph node dissection performed parentally would include level 1 and 2 lymph nodes. And level 3 is dissected very rarely in cases of advanced breast cancer. An adequate axillary lymph node dissection specimen should include at least 10 lymph node in the specimen. And the important axillary structures which need to be safeguarded during surgery are axillary vein, artery, cephalic vein, brachial plexus, long thoracic nerve, and thoracodorsal neurovascular bundle. Whenever feasible, the intercostal brachial nerve should be preserved. Now coming to essential of the operation, this operation does not require any specific equipment and any routinely used detector would suffice. The OT team would include 1 assistant and scrub nurse, and along with the floor nurse, the team would be complete. Axillary lymph node dissection is usually performed under general anesthesia and if indicated under regional anesthesia. The patient is positioned supine on the table with the arm abducted and axilla is aligned at the edge of the OT table. In one arm is properly prepared and draped and included in the surgical field. The incision would vary depending on the situation, whether the procedure is a standalone procedure or is being performed as a part of breast conserving surgery or MRI. In cases of a standalone or in combination with breast conserving surgery, the incision could be at the inferior axillary hairline or posterior and parallel to the margin of the pectoralis major muscle. In cases where mastectomy is being performed, the axilla could be approached by a mastectomy incision itself. Now coming to video per se, in this patient, the axillary lymph node dissection was performed as part of modified residual mastectomy along with validation sentinel lymph node biopsy. Hence, the axilla was approached by a mastectomy incision. Here we can see the injection of methylene blue is being done. And other 2 parallel incision at the right end of the video are, one is lateral most, the lateral border of latissimus dorsi. Other parallel incision is at the posterior border of pectoralis major muscle and in between at the inferior edge of axillary hairline, depicting 2 other incisions which could be used in cases of breast conserving surgery or standalone procedure. So I will skip the mastectomy part and would start directly from the axillary dissection part. So we start dissection at the lateral edge of pectoralis major muscle, first clearing all the tissue, lymph node, fat fascia and between the interpectoral space, wherein broadest group of lymph nodes are situated. And here pectoralis minor muscle is coming into view. And with gradual dissection, it is clear. And once it is clear, then we open clavipectoral fascia at the lateral border of pectoralis minor muscle, while safeguarding the medial pectoral nerve. Thereafter, the sheath of axillary vein is being opened, and the dissection is done. We slowly dissect, cauterize, cut, and then sweep the tissue down, starting from the apex of axilla along the inferior border of axillary vein. Here I'm using harmonic for dissection, but any energy device could be used. And the dissection along with anterior surface of axillary sheath is being carried towards the lateral end of axilla. So same, dissect, cauterize, cut, and sweep the tissue down. Here, a glimpse of chest wall is coming into the view, and with dissection, intercostal brachial nerve could be seen emerging out of chest wall and running laterally. As I said, any energy device could be used, and I usually prefer to use cautery near long thoracic nerve, because if we are near the nerve, the twitch of muscle indicate that nerve is nearby, and that helps us in not only in identification but preservation of nerve as well. We have to be careful not to pull tissue too much down along the axillary vein. Otherwise, we end up denuding posterior and superior part of axillary sheath as well, which contributes to postoperative lymphedema. So the dissection is being continued along the inferior border of axillary vein, and the apex is already cleared, and gradually we are going towards lateral and inferior direction. So since in the initial part harmonic was used, the lateral axillary vein was taken care of with that only, and we could not see that very clearly. Now the long thoracic nerve is coming into the view, and dissection is being carried along the anterior border of subscapularis, and the nerve is being pushed towards chest wall. As we go down and towards posterior aspect, we try to identify thoracodorsal bundle, which contains nerve to latissimus dorsi as well. Yeah, again, in this case, we have cut the intercostal brachial nerve on medial side, but wherever feasible, we should try to save the nerve. So gradually, we are going down, dissecting along all the boundaries, medial, posterior, and lateral. Now the thoracodorsal bundle is coming into the eye. And the dissection is continuing all around the thoracodorsal pedicle. I'm sorry for the background noise. Once dissection is completed until the angular vein, the specimen is delivered out. And here is the marking. We just saw that lateral border of latissimus dorsi was getting taut. So regarding post-operative and aftercare of these patients, the discharge would be as per local policy. However, generally these patients are observed overnight and all of them would require analgesia at least for initial 3 to 5 post-operative days. The drain output is closely monitored and drains are removed once the output is 30 ml or less on 2 consecutive days. Resting the arm in a sling helped in reducing pain as well as lymphedema, and early physiotherapy is encouraged. Mobilizing the affected extremity within 42 to 72 hours after surgery helps reduce lymphedema rates. And these patients are always on post-operative surveillance for signs of lymphedema. The complication of this procedure includes seroma and wound infection in early part of post-operative period, and lymphedema, numbness, pain in arm, stiffness of shoulder, and difficulty of arm movement in later part of follow-up. At the end, I would like to acknowledge my junior colleague Divya for preparing and editing this video, and my heartfelt thanks to the organizer for giving this opportunity. Thank you so much.
So thank you, Anjali ma'am. It was a very nice demonstration of axillary dissection and plus all the anatomical landmarks which we need to know while doing this surgery, and also highlighting the complications which we have to be aware of. And lot of hearts and lot of appreciations are cropping up. So ma'am, everybody has enjoyed your talk. So
Thank you. Thank you so much for having me here, Pooja. Thank you.
Thank you, ma'am. So after this, we move towards the mastectomy part. So I shall be showing a mastectomy video. So I hope my video is well seen. So when Dr. Sanjay asked me to show a video of mastectomy, unfortunately, we had this patient who was posted in emergency and she presented with a fungating mass, as you all can see, and her hemoglobin was 5 and we had to build her up and she was in a depressed state. So we had to have psychiatric evaluation also. And so such lesions cannot be managed by chemotherapy and they need palliative care, which is in the form of surgery. So unfortunately, we still see such patients. So most important is the wound care. The painting and draping is very important for these patients because these wounds are infected. So we have to cover with a mop and we have to stitch this infected part so that that doesn't contaminate our surgical field. So we ensure that these patients don't have any post-op complications. So we have to be more careful. So if you have skin staplers, you may use that to ensure that there's no contamination, or you can use silk suture or nylon, whatever you want, for closing these from all the sides. So once you have fully covered this wound, then only we should start the surgery. So we ensure that there's no wound infection or flap necrosis in these patients because as such they are immunocompromised, they are in the bad state. So we don't want our surgical outcome to go wrong in any way. So we have to be extra careful while doing these mastectomies. These are difficult mastectomies, but I think if we get used to managing these patients, the routine mastectomies may be easier. So once we have covered it, we clean with the mop and we ensure that there's no leaking of wound and we put an extra layer of the drape so that we cover it again laterally especially, and we put a mop laterally so that whatever blood gets collected, that doesn't cause much contamination later. I have marked the clavicle on the upper side, sternal border on the medial side, then inframammary fold inferiorly and laterally anterior axillary line. So we draw these margins. We should not try to cross these limits unless and until needed. So we draw an ellipse and the superior flap. You see, I'm retracting the breast down. So we stretch and we then make a transverse line. So this is a modified Stewart incision. We can modify the angle of the ellipse depending on the mass we have. Lower down, there was more pode orange, so I've taken extra skin that needed. And you see this angle between superior and inferior flap is quite broad. Ideally, it should be this at less than around 60 degrees to avoid any dog ears happening, but we have to modify based on the patient. So we give the incision. You see white is the dermis, which we see after cutting the epidermis. So we go layer by layer. So below this white dermis, when we cut, we will see the breast parenchyma, which may be yellow in color. So once we start realizing the anatomical structures, as Anjali ma'am also in the previous case has highlighted, we understand the surgical anatomy and we have the tissue respect. So once we have given the full incision, so we can use monopolar cautery. So because this case was locally advanced and so there was a lot of new angiogenesis, lot of new vessels developed. So they are small tiny vessels, but they bleed and they damage your field. So you cauterize it well so that you can see now, once I've cut open the dermis, we can see the breast parenchyma, the yellow one, and we don't have to go beyond the parenchyma. So that is an important point. And small tiny vessels which come on your way, you can buzz it off. And we ensure that at the margin, we don't cause much trauma by cauterizing with monopolar. The heat dissipation is more than 1 centimeter laterally. So the inner margin we can cauterize, but outer side we have to be careful we don't cause any flap necrosis or the marginal necrosis. So if you have issues, you may use bipolar. Bipolar energy device, the heat dissipation is very minimal. So you see, first I tried using the monopolar, but it didn't work. So I'm using bipolar so that there's no flap necrosis or skin marginal necrosis happening. The other assistant can use the suction. So you see now I fully opened the dermis. So now we put the skin hooks for raising of the flaps. So the assistant has to retract well so that you see the edges well. And the plane is usually 7 millimeters thick, ideally for raising the flaps. And you see, I retract the breast down and the assistant retracts it up. So there's traction and counter traction. So I work in the white facial layer, you see. This is not a clear cut layer. Once we retract, we see with the experience and we work in this layer, and this separates the subcutaneous fat lobules from the best breast, which are the bigger lobules. So the subcutaneous skin, the subcutaneous lobules of the fat are small. So we make this plain and we ensure that flap is not too thin or too thick. Too thin flap will cause flap necrosis, and too thick flap will cause recurrence. So I've raised this flap laterally till the upper part. Now I'm coming towards the lower flap, and you say here I'm raising segment by segment because it was more bleeding on the inferior side. The lump was more confined to inferior margins. So this is another way of raising the flap. If the margins are quite good and we don't have much bleeding, we can raise flaps like superior flap I've raised together from one end to the other end. Otherwise, we raise in segments, we dissect little, then we put the skin hooks and we raise the flaps for that segment, and then we slowly move. So I think slow and steady works for this, and we keep feeling the flap so that there is no thinning of the flap. Thinning is seen when we see the white dermis when the flap is raised. If the flap is well covered with the subcutaneous yellow fat, then it means your planes are quite good. Here you see the moment I'm touching the parenchyma deeper, it is causing bleeding. So we have to remain in that plane. So once we have dissected, so I'm coming towards the lateral part and uniting the lateral end of the lower flap to the upper end. But as there was much bleeding in this part, so we have to work slow and steady. This patient's hemoglobin also was quite low, though we had arranged blood intraoperatively, but we wanted to avoid any unnecessary bleeding happening. So to maintain the plane, we have to use suction. Other ways, you can have a cautery which has got an inbuilt suction with it. That is also a good option to use. Sometimes we use that also, but it is slightly bulkier than this routine simple cautery machine. So once we have united it, we raise this part of the flap, and then lateral end of the raising of the flap is till the latissimus dorsi, the anterior border. So we have to be careful with the anatomical landmarks. Lower flap raising is till the inframammary crease. Below that, the rectus sheath will come. That is white in color, and the fibers are vertical. So once we see, we should not see the rectus ideally. So only in cases where you have to modify the flaps, you may see the rectus lower down. So lateral near suction, you can see the pink. The latissimus dorsi muscle is quite lifted up because the mass was here. So we are just raising it. So once we have raised the flaps, other way is that skin hooks are more traumatic. You can catch with your finger, and finger dissection as well as finger retraction, both are atraumatic blunt, so that also works. Other benefit is you can feel the flap yourself with the fingers, and you can ensure that there's no buttonholing happening. Here you see I'm working transversely, not going vertically down, because going vertically down we may damage and cause flap necrosis by making a buttonhole. So that is sometimes happen, especially in the lateral part near the axilla. So we have to be careful. Now, after raising flaps, next step is doing the mastectomy. So we have to raise the flaps. Many way of doing mastectomy is either standing in the front on the head end and then raising the flaps. And this plane has to be in the pectoral fascia. The white fascia you see is the pectoral fascia. Some vessels may come, and medially we have to be careful with the perforators. Second to fifth intercostal space. Here you see I'm working in the pectoral fascia. Some small vessels come from the muscles underneath that can be taken care of with the cauterization part. Only the perforators we have to be careful because they may be thick. Second perforator is the thickest. And this underneath middle part of the pec major, I realized that the muscles were unhealthy and some watery fluid came out. So I'm taking pectoralis major also. So that is a modification you can do. And dissecting the muscle off is quite easy. It is not morbid, and you have to be careful that you don't go beyond intercostal muscles, beyond the ribs. Otherwise, you will enter in the pleural cavity. Other thing is when we cut the muscles, we cut it slowly so that the coagulation is quite good. Some in between the muscles, fibers, the vessels come and they bleed and they may damage your plane. So using a cautery slowly works. And now I'm coming towards the lateral part of the pec major. So that marks the ending of the mastectomy part. And lower you can see the serratus anterior fibers. We should not remove the fascia covering the serratus anterior laterally. So we just dissect it off from the serratus the moment we see these transverse fibers of serratus anterior. So I'm working slightly away, leaving the fascia there. And then while cutting the muscle, other way, instead of cautery, you can use energy device like harmonic or M-seal. That works much better compared to the cautery because fibers have a lot of vessels, so they bleed. So these are thick fibers, so I'm using M-seal. This coagulates very well, but we need a scissor to cut it. The newer versions have got inbuilt cutting also, but this is quite good in coagulation part. So it makes the planes totally bloodless and helps us in doing a good dissection. So you can use various energy devices depending on what is needed at what point, like monopolar, bipolar energy devices. So this is the interpectoral plane. I'm just entering underneath the pec major muscle. So just cutting yellow axillary fat, you can see slightly coming up. So this completes the mastectomy part. So once the specimen is out, we can localize it, or if we do the axillary dissection along with it, so axilla marks the lateral end of the mastectomy specimen. So orientation for the pathologist is important, and maintaining a good hemostasis after your surgery is also same, equally valuable. So you see the specimen is out, we look for the hemostasis, and we look, other thing is we look for, especially for these large wounds, when we have removed so much of the tissues, we have to be careful with proper closure. The closure should not be tight. No tension on the suture line and no flap necrosis will happen. So I realized laterally it was bit tight, so I'm raising extra flaps. So this also you can do this easy step helps in getting the adequate proper closure, so that the closure is not tension free, is tension free and there's no tension, so that there is no wound problem in the future part. So you see laterally, I'm inferiorly also I'm raising now. So that is a plane where the rectus muscles are there. So we just walk above the rectus sheath and raise bit of the more flap. So here now I see the closure is quite good. We put the drain and you see at the end, this is postoperative day 1. The flaps are not flabby. It is all uniform and there is no flap necrosis. So with this, I thank you. I thank Dr. Sanjay and the organizers for giving me this opportunity. And I'm happy to have any questions if there are any. Thank you. So thank you for appreciating it. So I hand over to Dr. Sanjay now. So somebody, Paul sir has asked, can we use a sterile sealing drape over the mops? Yes, sir, definitely we can use. That also helps. In this, it was quite messy, so very foul smelling, fungating wound. So I just put that big drapes and she was hepatitis B positive also. So that was a thing, but sterile sealing drapes are also a good option. Thank you for sharing that insight. Another person has asked any documented evidence of decreased post-op infection by covering the wound tumor. There, I haven't searched the literature, but then for a surgeon, if the field is quite clear, I think that makes our dissection easier and it should be a clean surgery. So covering the wound also helps avoiding any spillage. The wound is quite infected. It even had maggots. So we can't sterilize the wound. So covering the wound helps that we avoid any contamination. Plus spillage of tumor cells also. Because if we keep our hands maybe rubbing or our mop may be rubbing and cells may spill here or there. So I think that way it helps. So thank you. Thank you, Vishwak also.
Thank you, ma'am. So next, Jogle ma'am is going to moderate the case, complex case discussions. We will have couple of them. We will not be able to do whole spectrum of cases. So, Jogle ma'am, over to you.
Yeah, thank you, Sanjay, for the invitation and for organizing this. It's been a great day listening to all the speakers and their great talks by everyone. I'd like to welcome our panelists. We are going to discuss the complex cases with our panels of global experts. I'd like to welcome Dr. Gabriela Calderon, who is a consultant breast surgical oncologist from Peru. And she's also been the past president of Peruvian Society of Mastology. I would also like to welcome Dr. Somen Das, consultant breast surgeon, Institute of Breast Diseases in Kolkata in West Bengal, India. Dr. Chandan Jha, a consultant breast and endocrine surgeon from AIMS Patna. And Dr. Rauf Ahmad Bichu, a consultant breast surgeon at Northern Lincolnshire and Gould NHS Trust, UK. I am Kuratulain Chogle. Everybody knows me as Aini. I did my breast surgical training in India and at the Tata Memorial Center in Mumbai before I relocated to the UK 3 years ago. And now I'm a senior breast and oncoplastic fellow at Guy's and St. Thomas's NHS Trust in the UK. We had 4 cases. We've shortened them down to 2. And I believe Dr. Gabriela has one of her cases that she would like to discuss. So do we have all the panelists? Can I just know that they're all on online?
Yeah, I'm here.
Okay, thank you. Welcome to everybody. We'll start with the
Sleepy
first.
though.
Okay, we'll go quick. Okay. So the first case is a young lady who presented with a right breast lump occupying almost the entire breast with a history of 5 months. It was insidious in onset and rapidly progressing in size. Not associated with any skin changes. There were few dilated veins seen over the chest wall, and it was associated with axillary lymphadenopathy. There was nothing significant in the systemic examination. It was unremarkable. She had a BMI of 24.1. On examination of the right breast, there was a 10 into 10 centimeter mass, which was hard in consistency, fixed to the chest wall
and the overlying skin was pinchable with some dilated veins seen. There was no nipple discharge and it was non-tender. This is the CT scan, which showed an isodense CT chest, which showed an isodense lesion involving the right breast parenchyma, and the fat planes were maintained, and the CT of the chest and ultrasound abdomen did not show any chest or abdominal metastases. She had an FNAC which showed undifferentiated malignant tumor cells, and and there was no bone scan available on site, hence it was not performed. But she'd had a skeletal survey which was negative for skeletal metastasis, and she went on to have a right modified radical mastectomy with axillary lymph node dissection. So, Dr. Chandan, would you like to take this? So, what would you think that the likely diagnosis is, and how will we approach it?
Well, there is a large mass which is fixed to the chest wall along with axillary lymph nodes. So, of course, the suspect diagnosis is always carcinoma breast. Am I audible?
Yeah, you are, yes.
But the way she was managed, we just did a FNA and did a modified radical mastectomy.
Right.
So again, proper triple assessment should have been done. Not much information would be achieved in this patient in doing right mammogram, but for the sake of completion, at least a bilateral mammogram would have been suggested, especially for screening of the left breast and ultrasound of the bilateral breast and axilla, followed by a core needle biopsy for determination of histopathology and ERPR, HER grading to arrive at and to assign at least a clinical prognostic stage. And management, we should have considered neoadjuvant chemotherapy to downstage it because the chest wall, the tumor is fixed to the chest wall. How would you operate? It is basically non-operable cancer. That is what I believe.
Right.
Can
So,
I just add one point?
yes,
Yeah,
sure.
so it's
Yeah,
a
please.
rapidly growing mass with dilated veins without the involvement of the skin. So one should keep in mind the
One should keep
possibility
in
of malignant
phyllodes.
pyloid also.
Yes.
So
Yes.
there comes the role of doing a core biopsy again. But even this has happened that based on FNAC, the mastectomy was done. That's during the mastectomy also, if you can keep in mind the possibility of phylloids, the margin should be taken little more. So that's another point.
Yes, fair enough. So, this was provided by one of the delegates, as I think they've encountered it in practice. And later, Sanjay's informed me that it was found to be a malignant round cell tumor. So it was. This is how it was managed. We'll just go on to the next one.
Hi, good evening with all. I think this is a young lady. I think three probable diagnostics. The first is a triple negative breast cancer for the fast growing and it's a young people. And the second diagnostic is sarcoma, probably sarcoma. And the third diagnostic is a metaplastic carcinoma. Is necessary complete the pathologic exams like immunohistochemistry.
Yes, Dr. Gabriel, that's absolutely valid.
So therein comes the role of triple assessment. Following the beaten path usually will not allow you to digress. If we follow triple assessment blindly, we will make the least number of errors possible.
Yes.
Yes, absolutely. Okay, we'll, just in the interest of time, I'm just going to go on to the next one. So again, it's a young lady. We encounter this normally in practice very often. I've seen this at even the Tata Memorial Center previously. So she's had a lumpectomy that was done elsewhere. There is no pre-op imaging available or pathology. She's had, when we do the histopathological examination of the excision biopsy, it's a left breast invasive ductal carcinoma grade 2 triple negative. So it's CTXN0M0. She's received 6 cycles of taxanes, carboplatin, and pembrolizumab. So she's presented with some residual lesion in her left breast. suspicious axillary lymph nodes, left internal mammary lymph node involvement, and the PET scan has showed an indeterminate left lung fissural nodule with a low SUV uptake, and biopsy is not feasible. So the key clinical questions are whether it is potentially curable with aggressive locoregional treatment, and what surgery would we perform? Dr. Somendas, would you like to take this?
Yeah. So the point here is doing a lumpectomy is an issue, and most of the times you won't get the margin. So this is a situation. This is a situation where whether you plan to go ahead with surgery again or put the patient on neoadjuvant, because this patient received Pemro. But if we analyze the data of Keynote 522, pembrolizumab in absence of tumor has got no such effect.
No.
So this is a scenario where you have done a lumpectomy, someone else has done a lumpectomy, so tumor is not there at the time of presentation. Now, giving pembrolizumab, whether that will have effect or not, that is one debate. Now, having said that, in present scenario, when I have a lesion in the breast residual as well as an indeterminate lesion in the lung, since she is quite young, so we should give the benefit of doubt for curative intent treatment.
Yes, absolutely.
Yeah.
Dr. Gabriela, would you like to add?
Somen sir, would
usually-
you? Sorry.
Yes.
Sorry.
Yes. Somen sir, would you
Usually,
consider VAT succession?
Well, but if the patient seems to be fit, she has received Pembro, well, the option of doing a VAT excision versus radiation directly, maybe that option should be discussed.
I probably will disagree with that, but if it's radiologically indeterminate, you're probably better off of repeating SCT in 3 months' time to see if changes. If it does change, then probably we can consider about histological. But again, it's like it depends on how radiologically suspicious you are about the lung lesion.
Said a low SUV, but that is fair enough. Yeah, that's what normally we follow in the UK as well. Yeah. And would you consider, so we would treat her curative, yes, with the breast and axilla will be managed curatively. Okay. Dr. Gabriela, we had 4 cases, but in the interest of time, Sanjay is asked to cut it down to 2. And I believe Dr. Gabriela has a case of her own that she would like to discuss.
this patient can benefit from PET-CT for determine the exact extension of the sickness, of the illness. Do you have PET-CT? Do you have the opportunity to make PET-CT for your patients?
This patient has had a PET-CT. That's how we know of the indeterminate left lung fissural nodule. They've said it's a low SUV uptake. However, a biopsy was not feasible.
Usually in Peru, we have a locally advanced breast cancer. If it's triple negative or HER2 enriched, we can the possibility to give a PET-CT for the patient for the exactly extension of the illness, because it's different a locally advanced breast cancer or for stage breast cancer.
Yes, fair enough. Yes.
I think
Do you have
one of the questions, sorry, one of the questions is really what would we do with the internal memory nodes? I don't think it's advisable to do excision of those internal memory nodes. It doesn't add anything. You probably consider radiotherapy to the internal memory chain. If we done axillary dissection, she has multiple nodes. She could receive radiotherapy through the internal memory chain rather than surgical excision.
Yes, I have, having worked in India and UK both, I've seen both the treatments and they're both valid at TMC. Whenever it was possible, we used to excise it. And I've been in the UK for 3 years where we radiate. So I agree both are acceptable options. Sorry, Dr. Gabriela,
Can I,
do you
yeah,
have a case of yours? Sorry.
yeah. So
Yes, I am
just
ready.
can I ask panelist one question? So this patient already she was on Pembro and she did not have response. Obviously, there are lymph nodes, there are residual breast lesion. So what should be the policy regarding further Pembro?
The guidelines usually suggests 1 year. So according to the keynote 522, so I think you would continue and complete that because that's what the evidence we have. Anybody else has anything different?
But then it should have been started in the pre-operative setting.
Agreed. Yes, absolutely.
Now we have probably not sufficient, but at least some evidence that Pembro is not working. It is not active.
Yes,
I
agreed.
think there was a trial which looked at specifically Pembro in adjuvant setting when they were not given it before, and it didn't show any benefit of Pembro. I think what they say, the pathophysiology of how it works is because it's an immune modulator. You need to have the primary tumor. So if you have primary tumor, you give Pembro, it activates immune cells, they help. So if you do not have the primary tumor, as Dr. Somans was saying, there was probably no reason for them to start on Pembro.
Yeah,
Yes, but
What have
yeah. If we take it as a neoadjuvant Pembro, and the patient has got a residual disease, we go for breast surgery, and if we find a residual is present, she is TN-BC, she is a candidate for adjuvant as per
Pembro.
data, Pembro, continuation of Pembro as well as the capecitabine. So that the medical oncologist needs to decide on that.
Yeah, it's a challenging case. I think it's sort of in between the two trials, which actually have steady Pembro.
Dr. Vishwak, would you like to unmute yourself? I believe you have something to say. Yeah.
This case having post lumpectomy status, but the notes were not addressed in the index
Yes.
presentation. So still the chemo which was given along with immunotherapy was considered as a neoadjuvant scenario. Now the patient will undergo surgery and then has to continue on adjuvant pembrolizumab until a year, as per this guideline, keynote 522 trial.
True, agreed.
Yeah.
Yeah, at tertiary centers, we very often encounter these patients who had excision biopsy done elsewhere. And so I had previously done a study as well. So it's very common. And I can quite relate to, and we've all encountered it, I think, during practice. Sanjay, do you want me to discuss the other cases or do we have time?
I have two cases. It's so late. It's night in India because I think only the first case. Yes.
Yes, sure.
Let's.
You can. Yeah, I'll stop sharing.
Yes.
I think
Can you see? Can you see the
Yes, we can.
PowerPoint? Can you?
Dr. Gabriela.
Okay. Thank you. Thank you for the opportunity. Let's start with the first case. Is a female patient with 29 years old with a family history with thyroid cancer in the maternal aunt, prostate cancer in the maternal grandfather, testicular cancer in the first cousin, breast cancer at 45 years old in the maternal aunt, and she beginning with a sick time of 1 month with leprous tumor of 3 centimeters and mass in the axilla to 5 centimeters, no pain, and lymph node of 1 centimeters in the group 4 in the left hemineck. We made an ultrasound. The ultrasound describes in the left breast in radio 3 to 8 centimeters of the nipple, a solid nodule. Irregular edges without vascular flow of 2.2 centimeters. In the left axilla, we can observe two nodules. The first nodule is the 3.9 centimeters, and she lost the fatty ileum and have a thickened cortex and vascular flow, suggestive of metastasis by RADS4B. And the first question is, will you request a mammogram for this patient of 29 years old? In what type of mammogram would you request? 2D, 3D, or combo mode 2D plus 3D?
Probably a tomosynthesis would be better than a 2D alone. Obviously, we will also recommend an MRI as well, not just an tomo, but
Yes.
an MRI as well.
I do agree with that. Tomo, and maybe she might require a MRI based on the density of the breast.
Because it's the first visit of the patient and the first choice is the echography. In a second time, the patient was performing mammography combo mode that describes dense breast, ACR category C in the left breast, in the posterior third of upper outer quadrant to 8 centimeters from the nipple. You can observe an hypodense mass that measuring 2.2 centimeters with regular edges. In the axillary region, we can observe two nodules suspicious to metastasis. The large nodule measured 3.9 centimeters. The patient was performed core biopsy in the breast tumor with the 14 gauge needle in the breast and the axillary nodule with a 19 gauge needle. In the second question is, in your daily practice, in the presence of clinical and radiological evidence of metastatic lymph node, do you perform a core biopsy or fine needle biopsy in the axilla? And do you place clip in the lymph node? Why yes or why not?
Here,
Yeah, we'll perform core biopsy. Yeah,
core
go ahead.
biopsy. And you put a clip? Do you put a clip?
Yes,
Yes.
they put a clip at the
You
time
should.
of biopsy. Yeah, usual practice
Both
in the
breast and nodes.
This patient have three nodes suspicious to metastasis. Do you put a clip?
If it is less than 3, yes. If they are more than, if they are 4 or more, then no.
Okay. The result of the core biopsy is invasive ductal carcinoma poor differentiated, and the axilla is metastasis to carcinoma. The immunohistochemistry is estrogenic receptor negative, progesterone receptor negative, Ki67 15%, HER2 negative, is a triple negative breast cancer patient. It's a young patient and have a rich history of familial with cancer. And in this case, the patient have evaluation for the genetic specialist and made 188 gene panel. In this panel, we can evidence the presence of pathogenic mutation in TP53 with diagnostic of multiple risk for multiple tumors, breast, sarcomas, brain, adrenal, leukemia, and 50% risk of transmission to offspring, and a strict recommendation to avoid radiotherapy for the risk of radiation-induced neoplasia. is a patient with 3C breast cancer. In the MRI, we can observe an extensive mass in the breast with satellite nodes, and in the axilla, the major lymph node with metastasis of 3.9 centimeters. The extension studies, like the CT scan of the chest, abdomen, and pelvis, was informed negative for extension. In the neck tomography, we can observe 1 centimeter lymph node in the foregroup. In the brain MRI was informed negative for metastasis, and the patient have a PET-CT2 negative for extension of illness. The patient receives neoadjuvant therapy with pembrolizumab, carboplatino, docetaxel for 6 courses without complications, and then next, the surgery. This is the MRI post-neoadjuvant therapy. We can observe a complete radiological response, a complete axillary response. In the ecography, it was informed a nodule of 0.7 centimeters, like mass residual mass in the axilla. And this patient have a left radical mastectomy modified like Madden, Madden, and for the risk of breast contralateral cancer, the patient have a contralateral mastectomy with immediate reconstruction with bilateral pectoral prosthesis. The results confirm the pathologic and complete response in the breast and in the axilla. During the procedure in both mastectomies, we need a frozen section of the retroareolar ducts and was informed negative for cancer. And next question is the adjuvant treatment. What systemic treatment do you recommend in patient with complete response that receives chemotherapy with pembro, carbo, and docetaxel?
You'll continue with pembro for a year. For the rest of it, I don't think she needs anything.
Yeah, I agree with that. She should continue the pembro for 1 year.
And if the patient have no economic resource for continuing pembro, what do you recommend?
Well, so most of the LMICs, now these pembrolizumab companies, they have come up with, if they are taking neoadjuvant course, they are giving free of cost adjuvant course in most of the centers. So in that regard, that is, they are getting a financial benefit. But if they are not able to do so, then the adjuvant, this patient cannot receive radiation because of the P53 mutation, then she should be kept in follow-up.
Okay. This is the pre-operate, and this is the post-operate image. We made an incision in bracket in both breasts. With this incision, we can make the axillary dissection too, plus mastectomy for only 1 incision. And the patient have an excellent recovery. We have put a round smooth prosthesis with 400 centimeters. And certainly the patient have a P53 mutation, and the recommendation is no give radiotherapy for this patient. But it's a younger woman with 29 years old with a 3C breast cancer. What do you think about the treatment with radiotherapy? is a great discussion. There are more benefits or more risks.
From what I'm aware, generally you would avoid the radiotherapy, but she's had a reconstruction because there's a risk of secondary malignancy. That's why the mastectomy is recommended. So I think she will be safe. Only thing I would have considered in her differently, if you have a plastic surgeon on board, is whether you would consider doing an autologous reconstruction. But other than that, I think you've given her the most optimal treatment. If I don't know if others would differ.
Yeah, I agree with that.
Okay. Is this patient is pending to discuss in the next multidisciplinary committee in the Tuesday, and I probably we think that she received radiotherapy because it's a tricky patient, it's a younger patient. We have other cases with the same reconstruction and that receive radiotherapy without complications. No, and it's a big question and it's a big decision. Thank you for your attention. Thank you for invitation to today. It's a long academic trip. Congratulations, Dr. Changai, Dr. Chugel, with all. Thank you so much. Welcome to Peru forever.
Thank you. Thank you
Thank
to
you.
all the panelists, and thank you everyone for joining. Sanjay, do you want to take over from here?
Yes, ma'am. So thank you, everyone. And we switch off this screen sharing. Yes. So now next, just briefly before we end our this first course, we have almost all the faculties have joined along with our head of the surgery department, Professor Deepti Bala Sharma. I would like to have a brief roundtable on future of breast cancer care in low and middle income countries. I would be very happy if the esteemed faculties can chip in, give their feedback, and would also invite delegates to give their feedback in the chat box or any queries they have. Thank you. Somen sir, can you please start?
Yes, so what I can see is low resource setting. I divide it not as LMIC, HIC. It is because in India also you will get good centers with all the facilities, and you go 50 kilometers away from that, you will have centers without any mammography. So it's always in single country also, you will have a high resource setting as well as a low resource setting. So a resource adapted planning should be taken, and this kind of meetings where experts from all over the world they gather and share their experience. And I liked the idea of the frugal innovations, because the low cost innovations are if they can maintain the same standard, they are actually going to be adopted by the HICs also, because it's always cost effectiveness is the primary one which is taken care of in LMICs. But if they can serve the same purpose with the same standard, then that can be adopted by the HICs also. So it's time whether we should work together to innovate, to validate our own solutions. So I always call it as it's for us, by us, with all, for all. So that's our slogan for the low resource setting, frugal innovations. So I think this is the first step with the bridge course where you have, I must congratulate your whole team. This is a great effort being taken. And I also take the opportunity to invite you all for ABCC, that is Asian Breast Cancer Consensus Meet in coming March 2026, where we will be discussing the low resource setting breast cancer management, and maybe that can be a physical extension of your bridge program in next March. Thank you very much.
Well, thank you. Thank you so much, sir. And I see Professor Cheng Harip is online, and she gave inspirational talk on her journey of breast cancer care resource adapted guidelines. So I would like to ask you, how do you see like breast cancer care in low resource setting? Do we still need to uh, have resource stratified guidelines, or everyone should be able to receive the same standard of care?
Well, I don't think everybody can receive the same standard of care because everything is based on cost. And I think we should talk more about financial toxicity because we have done studies on financial toxicity, and patients actually go into financial catastrophe paying for treatment. Well, I would like to see actually what we should do is try to follow the what was it, the Global Breast Cancer Initiative, the WHO initiative, where they have this 60-60-80 target. So 60% should be diagnosed in stage 1 and 2. The diagnosis should be completed in 60 days, from presentation to diagnosis, 60 days. And the last one is 80% should be able to complete multidisciplinary treatment. So I think trying to achieve these targets would be the best to be able to improve survival from breast cancer in the low and middle income countries.
Right. Thank you. Thank you so much, ma'am. Gaurav sir is there, Chandan sir, Chogle ma'am. So what will be your message to the delegates who have joined here? And I can see there are still lots of delegates who are listening to us at 11 p.m. So obviously they are very keen to improve their standard of care.
Almost
With
all of us who work in low resource setting, they do some sort of innovation. Either it is some frugal innovation in instrument or some modification in the work, in the way you handle your patient, you counsel your patient, whatever. Like there was a discussion on whether a bad BCS is worse or a good mastectomy is worse. In our setup, what is the type of reconstruction that my patients get? They, the type of reconstruction that they get is they will just put a hanky under their blouse. That is the most common reconstruction they get. They do not get any reconstruction. So even if I do a bad BCS, I believe if I have saved even half of the breast, that is better than that form of reconstruction. So when we talk amongst ourselves, especially people, those who are working resource poor setting, we need to be more forthcoming about our own methods. Today there was a discussion regarding the reuse of core biopsy needles. All of us probably would have done that. At least during our training days, most of us have been trained in government hospitals and treated poor patients. We have done that, but we are not that forthcoming. So from next time, we need to focus more on resource poor setting because there the information is low. And then when I see people practicing like me, I get more confidence. That would be my message. We should share our innovations. We should share our methods for practice in low resource setting.
Right. Well, that is very encouraging to hear from you. Gaurav sir, Vidya ma'am has also joined, kindly join in this discussion on future of breast cancer care and low and middle income countries.
Well, what I would like to say is that point has been made that within each country there are numerous different kinds of settings. We have the lowest possible ebb of practice of breast surgery and breast oncology without any appropriate evaluation with very less than ideal surgical and adjuvant treatments. On the other hand, we have maximal within the same country centers practicing maximal surgery and maximal oncology, even beyond what is justifiable. So one side certainly cannot fit all, but what we all must strive for is to achieve the very basic minimal standard in evaluating these patients and offering them the most basic acceptable standard of treatment, uh, even if it is at the cost of not doing breast conservation, not doing sentinel lymph node biopsies. Even in the year 2025, there would be centers and patients who would have to accept or who would have to compromise with standards, knowing that they cannot afford it, but they cannot compromise on these basic standards like a firm preoperative diagnosis, oncologically sound surgical treatment, and the most basic adjuvant treatment. Expecting all patients to have access to radiation overnight will be foolish. Expecting all patients to have access to targeted treatment would be foolish. So, the most basic hormone treatment and adjuvant chemotherapy or neoadjuvant chemotherapy is what needs to be ensured. And the way forward is multitasking. We can't expect medical oncologists to be there in each and every nook and corner of the world. All those who are involved with breast cancer care will have to be aware of and have a bit of training in each component of the treatment, be it diagnostic or therapeutic parts. So we are our own multidisciplinary team, to put in uh, maybe a provocative way, and then try and make our multidisciplinary teams. So on the upside, you can keep going up and up and having maximal resources with improvement, which is only slightly incremental. But uh, if we do not follow these most basic standards, the risk of downfall or suboptimal outcomes is multifold. So that is my take on this.
Well, that is that was very important point, sir. Actually, that every person who is trying to manage breast cancer, every surgeon should know basics of everything like chemotherapy, radiotherapy. It is very important in low resource setting. Like when I joined here, and I requested the chemotherapy used to be given by other colleagues who are not medical oncologists actually, but they were not keen to give chemotherapy to triple negative breast cancer, which is more than 2 centimeter or this thing. So I had to insist. I kind of had to really insist so that they could start giving neoadjuvant chemotherapy to these patients. So I think that is very important. Dr. Steve, Vidya ma'am.
Yeah, no, thank you very much, Dr. Sanjay and everyone. Was very impressed, especially with Dr. Yip's talk, and everyone really shared about a lot about what I don't know here or what I don't experience in America. And my experience last year in Cuba was also very eye-opening. When there's no radiotherapy, there's no screening, everything was done open. And yet, it was very, very still something that I took home and really shared with my colleagues here in America. I do think that there is role for continued de-escalation in the surgical approach as the systemic therapy continues to improve and to kind of start to encroach from a metastatic to adjuvant to the neoadjuvant setting. I think there are going to be other methods to assess whether there is a response. Just like Dr. Calderon presented a wonderful case, and maybe in certain patients, she unfortunately had a pathogenic mutation, but those who may not have a pathogenic mutation or wishes for risk reduction, there may be other approaches where we can take to minimize even surgical approach. So as a surgeon, our role as a breast cancer surgeon, our role will continue to evolve. And I think it is really, really important to embrace exactly what you are all doing. As surgeons, we are all leaders, and we are all committed to quelch cancer, despite not doing as much surgery. So I do encourage people of taking preventive oncology, where we do have to share a little bit more about to our patients and our medicine colleagues the importance of screening when we can. And just like Dr. Das and a lot of people have alluded to, is the need for using effective and cheap therapy that is able to risk reduce in a population setting, not just individually, but in a population setting, the incidence of cancer. But yeah, I think this is really encouraging, and I want to thank everybody, the participants and the faculty, because I learned so much from each and every one of you.
Right, Sanjay, am I the last?
Yes, no,
Okay.
Annie is there, Rose is there. So let us.
No problem.
Okay.
Please go ahead, Dr.
Please.
Vidya.
I just wanted to say this is just the beginning to promote high quality care. I think I've seen India top level treatment from robotic mastectomy to high class PET scan for diagnosis to neoadjuvant chemotherapy to excellent care delivery. If this could be done at the tertiary level, I think we can adapt ourselves and deliver this high quality care in low resource settings. But we have to be very ingenious and develop our local ways of treating patients to high level of care. I think learning to do the best and knowledge will be the best. And don't work alone. Collate with your colleagues if you're not sure of chemotherapy or radiotherapy, because chemotherapy drugs are changing every day and radiotherapy doses are changing every day. So collate with your colleagues, don't work on your own. And I would say this is just the beginning to start working together to deliver high quality patient centered care. And when you are back to work tomorrow, remember the patient is in the center of all this care and you want to deliver the best. Thank you.
Thank you, ma'am.
Sanjay, I'd just like to add, I would second what Dr. Vidya Gaurav Agarwal sir and what you said. It's important to give the best care that is available in the setting that you are in. And like you said, you need to be aware of what chemotherapy regimes or what adjuvant treatment is available so that another person may not wrong the patient just because you are aware and you work together as a team. And I think there's great work being done. I've worked at Tata Memorial Center where we were often criticized for doing axillary sampling and not doing sentinel lymph node biopsy, but we were trying to provide the best care that we had and we could for the patients at that time. And I'm here in the UK, and like Dr. Vidya said, there is robotic mastectomy going on in India. We have a lot of PET scans, we have proton, we have the works. So I think it's just you just have to keep working towards it, and it will we will be able to provide the best possible care in the years to come. Thank you.
Thank you. Dr. Gabriela, Dr. Guj, Shwak.
Sanjay, in all countries, there are two phases of the breast cancer, the public phase and the private phase. The public phase treat for all media to offer to the patient the best treatment. In Peru, 95% of the patients attend in the public health, in the server, in the public service of health. Only 5% is private. But in the public service, we have a PET-CT, we have a robot, we have a sentinel node, all instruments that you need to make the better for the patient. We work with kind of negotiation with APP, with the impuestos of the industry, with the collaboration with private institutions for buy the instruments that we need for make better our job. In the private practice, is more easy to treat to the patient that we have a lot you have that you need it, but is no difference the attention for the patient and the public and the private institution. Yesterday, I was in the Congress of the Controversial in Breast Cancer in Lima, and Dr. Javier Cortez says that chemotherapy is no different, but the that this patient receive immunotherapy in your complete response is 80%. No, because there are a lot of drugs that give the same response and give less secondary effects in the patient. You trade with patients. We don't trade with numbers. We don't trade with cost. We trade with patients. In all countries, we need understand that we trade with patients and all efforts conducive for the better of our patient. I am very happy that you make this conversatory this day a long academic and marvelous day, and I have the compromise with you and all initiatives that you have implemented in your country. Congratulations, Shanghai and all commission for this effort in this academic day.
Well, thank you so much. It would not have been possible without all the support and the like guidance we got from all the esteemed faculties. Dr. Bose, would you like to add something, Dr. Vishwa?
Thanks, Sanjay. I think the comments are speaking for itself, so there's hardly any room to add to what everyone has said, but I agree with all of it, and great effort by you and the organizing team. So I think the answer is in working in a collaborative way, as others have also said. So we probably need to get our heads together and come up with new ideas. And anyways, in India, we are quite used to coming up with indigenous ideas and jugaad, as we call it. But so I think we'll get there. It just needs lifting each other and coming up with new ideas and sharing ideas. We do it anyway on a regular basis. We have our own personal small groups where we discuss cases and we get ideas from other friends and colleagues and seniors. But I think meetings like this are very helpful, and it was great to hear ideas not only from India and UK but other parts of the world, and see the similarities and the discrepancy in how people are working with whatever they have available. So great effort. Thank you for doing this. Yeah, hopefully soon we'll meet again soon. Yeah.
Yes, thank you. Yes, Dr. Vishwa.
So everyone has said everything. I just want to congratulate you and the entire team for this excellent initiative and the tremendous effort that put into making this course successful. Seems like
No, so team is all of us.
all of us. I strongly believe we should take this forward by extending this training, the opportunities that surgeons in the Taluk hospitals empowering them to provide the basic standard of care in breast cancer management. So we all would be honored to join hands with all of you to make this important step in a reality. Thank you. Thank you so much.
Yes, that's the plan. That's the our vision, along with everyone like Indo-UK Breast Forum, then Breast Surgery International, and Indian Association of Endocrine Surgeons. We are planning that, and all the esteemed faculties have uh, said that they will help in, and soon we will have a physical meeting also, because I think 6 hours are not sufficient, as we over exceeded the time, because during initial talks we had so much interest from the delegates and so many questions that our time management got derailed. So I think doing it in 2 to 3 modules will be better. So obviously we will discuss with all of you and then plan from next year onwards. Then at the end, I would like to call upon Professor Deepti Bala Sharma, who is head of the surgery department at NSCB Medical College, Jabalpur. And as a whole, our department is continuously focused on locally adapted care, for not just for breast cancer, but for all other surgical diseases as well. And we have been doing it for quite some time. So, Deepti ma'am, kindly join us and give
Hello, good
thanks.
evening, everybody. As you all know, this bridge course is very first kind of worldwide online program about our breast cancer management. Thank you very much for our esteemed faculties for their pearls of wisdom. I think this course will be very helpful to our students and the general surgeons who are interested in the breast surgeries. Especially Dr. Sanjay, special kudos to you for taking all the pains and efforts to organize this. And thank you very much for all participants and the esteemed faculties. Thank you.
Okay, thank you everyone. So good night. And for others who have joined from US and Mexico, Peru, have a great day. So bye bye. See you soon. Thank you.
Bye. Thank you.
Good
Bye.
night. See you soon. See you soon.
Thank you. Bye-bye.